A very good afternoon, everyone. Once again, welcome to SATCON 2024, and I'm very much thankful to be patient with us. Very soon, we will be starting with our today's session by Dr. Anil Patil, and for that, I would like to call Dr. Vikas sir to chair this session. So please. Before starting the session, there are routine announcements like please switch off your videos and mute your audios and kindly be with us. Enjoy the session. Be free to ask all the questions. And now over to sir, please.
Thank you, Dr. Rajasri. I would like to start first session of SATCON 2024. I would like to call Dr. Anil Patil. He is a neurosurgeon practicing in Satara since last 22 years. He is a MCH neurosurgeon having his own hospital, which is a 70-bedded hospital, exclusively neurotrauma center, Yashwant Hospital. He is a MD and chairman of Yashwant Neurosurgery and Research Center. I would like to call Anil Patil for his lecture. Thank you.
So good afternoon everybody who is online, who is offline, who is sitting here, and I thank all the SATCON organizing secretary and IMA EC members for organizing such a nice conference. I think this is third year we are consecutively organizing this meeting. So today I am going to talk on the technological advances in neurosurgery pertaining to brain tumor, because technological advances are happening day by day and it's a very vast world. So we should restrict ourselves to the brain tumor. And my next sentence is, can we cope up? That means obviously we are not coping with it. We are far behind for all those things which are happening in this world. So recently this is the recent sensation.
Neuralink said on Thursday it had been given a green light from the US FDA to kickstart its first-in-human clinical study. It's a critical milestone for Neuralink after earlier struggles to gain approval.
We're confident that it is possible to restore full-body functionality.
On at least 4 occasions since 2019, Musk has said his medical device company would begin human trials for brain implants to treat severe conditions such as paralysis and blindness. Elon Musk's brain implant.
So now we can't consider that we will be immediately in this our country jumping to this Neuralink and all those things, which so many lucrative things which are happening, or all of the European and American world is claiming that it is near in the future it will happen. So my talk will be restricted to the things which are happening in our country, and probably few of them are available in my hospital, that is Yashwant Hospital. So in this slide you are seeing the operating microscope, then the intraoperative MRI. We don't have that. Then the intraoperative CT, then comes the yellow filter, then comes the intraoperative radiation, which is not available till at least in Maharashtra, and we have the neuronavigation. This year my presentation will be absolutely restricted to the yellow filter and tractography. So now before I start all this in detail of all these technological advances, I would like to tell some basics about the brain tumor. Now brain tumors are grossly divided into two parts, that is intraaxial and extraaxial. What is the intraaxial? That is any tumor which is arising from brain nervous tissue. is intraaxial, whereas any tumor which is not arising from the brain tissue but it is arising inside the skull, maybe the bone, dura, arachnoid or other supportive nervous tissue, they are extraaxial. By and large, extraaxial tumors are benign predominantly, whereas intraaxial tumors are malignant predominantly. This is one more classification for the brain tumor. This is not a book classification. This is the neurosurgeon's conceptual understanding about the brain tumor, that is histoloco-regional classification. So any tumor which is benign by histology, benign by location and benign by size, that is smaller than 3 centimeter, is a good tumor to be anybody should have, because it is not malignant, it is situated where nothing will go wrong by the surgery, and the size will be also smaller, so it is easier to excise. Then comes the benign by histology but malignant by location and benign by size. So like this can be converted into the 9 categories, where histology followed by location followed by size. Kusai sir, will you please keep quiet? So the next slide shows that how these are loco-regional classification works. Any lesion which is benign by size means smaller than the 3 centimeter. Any lesion which is located peripherally and which is smaller, also histology wise benign, is, as I said, very good lesion for anybody. It is very easily operable. So if you are seeing the slide, first MRI, my cursor is on the first view of the MRI picture, where this is a small meningioma. It is benign, it is small, so it can be observed. But immediately same type of histology which is situated in the next image is having a tumor which is very much situated at a very difficult situation, that is malignant by location, just anterior to the pituitary, and it is a cavernous sinus hemangioma or meningioma, where all the 3 cranial nerves of eyeball movements are located, and this is malignant by location. Whereas the next slide you are seeing, this is the malignant by size. This is a big tumor meningioma which is occupying almost 1/3 of the sagittal plane of this MRI, and all these 3 are combined in this lesion. That means this is a malignant lesion, this is situated at a very difficult situation, and its histology also will probably prove malignant, might be. So then comes the intraaxial tumor, means those which are situated inside the brain, like glioma or metastatic lesion or oligodendroglioma, where if the lesion is situated peripherally, it is safer to excise, but the histology is not favorable. Whereas if the same lesion is situated in the deeper site, then it is again, the lesion size is smaller, but it is into the eloquent area. I will explain what is eloquent in the next slide. And here both things are against. It is situated in the brainstem, it is a larger lesion, so it is very difficult to treat this lesion. Then comes what is eloquent cortex. As we all of know, the motor strip, then comes the sensory strip, and then Wernicke's area and the Broca's area, then speech area, then comes the brainstem, pons and medulla, including the optic chiasm, hypothalamus, pituitary gland. These are the parts of the brain where smallest injury while doing the surgery can lead to catastrophe. The consequences can be too difficult to handle for patient as well as the consultant. So the functionally eloquent cortex or the eloquent areas, and then comes the non-eloquent area. The next slide we will have the example of this. This is the same type of tumor which is seen, but the first MRI picture is suggestive of a tumor which can be taken out very safely, because this has got a right frontal lobe which doesn't have much affection post-operatively on the patient about his motor function as well as the sensorium and almost all higher functions. On the contrary, same size tumor which is seen on the next MRI image, very difficult to excise totally, because here lies the internal capsule, here lies the thalamus, and this is the left side, and his taking out of this tumor will definitely can lead to aphasia, altered sensorium, hemiparesis, and like this. This is one more example for the cerebellum, where you can see first slide where there is a big cyst, but the tumor is situated peripherally into the cerebellum, where there is a lot of scope for the excision of the normal brain also, cerebellum also. So if the tumor is situated in this area, you can compromise. Patient will have some ataxia, but within 3 months patient will recover. On the contrary, if this tumor is situated in this area like this or here, then this is the brainstem pons, where taking out of this tumor will be a really challenging job or practically impossible. So this is the concept of eloquent and non-eloquent area. Now here comes the newer technologies, that is tractography, yellow filter, neuronavigation, and intraoperative radiation. So we will see first the tractography, which is a part of investigation. Then we will come to yellow filter, which is a technology used during the surgery, and neuronavigation, if time permits, some glimpses of the neuronavigation. So now what is tractography? As you all of know, tract is the neurons which are taking the information to and fro from the centers which are situated in the brain. From the brain, they are going to other centers of the brain, or they are going to the peripheral nervous system, that is motor nervous system or sensory nervous system, even autonomous nervous system. So the tracts, these tracts are traced on MRI. Now these are the regular images, coronal and sagittal, of the MRI of contrast study of a tumor which is situated exactly behind or ahead of the motor strip. Now on looking this image, you cannot just judge that whether your motor fibers, motor strip is behind or anterior. And the same tumor, if you see in the tractography, this is the reconstructed images of the various 3D reconstructions, computer graphics used images, which clear cut says that the tracts are shifted anteriorly. So while removing the tumor before surgery also and intraoperatively also, for the planning as well as the execution of the surgery, there will be a lot of help to save the important tracts. So now what is the protocol? That is, the blue lines which are seen are the important, that is vertical. They are going from brain to the spinal cord and all peripheral nerves. That is called as cortical spinal tracts, motor and sensory. So they are blue, are vertical. The red ones are horizontal, that is crisscross, cross connection between the right and left, that is corpus callosum, for the transfer of the knowledge between, for the language and memory. Whereas the greens are anterior to posterior, again intellectual functions. So the tractography denotes the clear cut, or gives the clear cut idea of tracts or important fibers which should be or must be saved while doing the surgery. So now these are the images or the videos of, now you are seeing the MRI where this is the tumor scene which is exactly into the brain. Again I will show this, and it is ill defined even on the contrast, and here is the tumor, whole tumor. If you see the same MRI picture, same patient's tractography done at the same time, you can pick up the tracts, how they have been changed. I'll have to stop this in between. So here I am able to stop the video clear cut. Now these are the blue tracts, blue on the right side, they are seen very properly. This is almost just above the internal capsule. Here is the internal capsule and part of thalamus, and they are splayed, but predominantly they are shifted posteriorly. So while removing the tumor, surgeon will get a clear idea that his danger zone is posterior. So he should attack the tumor from anterior, and he should remain in the confines of this tumor, where he will have least chances of giving deficit after the surgery by damaging this motor strip or the motor fibers. That is the use of tractography. Now the same patient, I am showing you the coronal cuts, coronal images, where you are seeing the tumor is situated exactly here. Oh, they are all playing simultaneously. And the same patient's coronal cut here, you can see the splaying of the tracts clear cut. They are getting shifted medially and posteriorly. So if you go from here, you are bound to injure all these important things. So this is about the tractography. So same patient, I am having this 3D reconstruction. This is one more case where again we can see a cystic tumor which is very much situated in the motor strip. While excising some wall, you may lead to the deficits to the patient. So you can see the posteriorly shifted and anteriorly shifted tracts. Now these are the various reconstructed images by the computer, where you understand that where is the tumor and where you should not go. So now, aim of the neurosurgical intervention is maximum radical resection of malignant tumors without any additional permanent neurodeficit. Tumor is in the brain. A surgeon, while operating or removing the tumor, he is not to remove any normal neurons or nervous tissue. How does he identify the tumor? By visual impression, that is on the surface while resecting, tactile sensation to the instruments when he is operating, that is suction, bicep, forceps, cautery and CUSA tip, and then comes the neurosurgeon's own navigation, that is whatever he is thinking while doing the surgery and imagining the images of these MRI images or CT images of this patient, and where he is currently and where he should not go and where he should go. But at certain stages, differentiation between normal and tumor tissue can become impossible at certain stages. At that time, you get help of all these technologies, that is tractography is superimposed in neuronavigation. All these technologies are interlinked and all they are used simultaneously to help the surgeon for doing the best possible surgery and safe possible. So what is the yellow filter technology? The sodium fluorescence is injected. Ophthalmologists must be aware of sodium fluorescent. Sodium fluorescent is injected just at the time of the induction, which is supposed to reach up to the malignant cells, and they break the blood-brain barrier because malignant cells doesn't follow the blood-brain barrier and they are in the tumor, but they are not seen in the normal tumor. So that injection of the sodium fluorescent is giving yellowish green color to the malignant tissue, that is through the microscope, of course, with the yellow filter. That is the technology which differentiates the cancerous tumor or the malignant tumor from the normal brain. So comes these are the technical details of the use of this fluorescent, how it works and what this, but this is all chemistry. Now where else the sodium fluorescence is used? In the Second World War, parachute troopers, when they have to jump from the aeroplane, fighter plane, when they get some accident or some like that bombarding, when they jump, they used to land into the, usually into the water, and to trace them for the rest of the people, they used to break that one equipment which used to throw the greenish yellow light onto the water, and the rescue team used to locate their location by seeing this. The sodium fluorescence is also used for the retinal angiography. All of ophthalmologists must be knowing if they are online. This is the simplified figure of this technology, where you can just see on the left hand corner, right hand corner, sorry, this is the tumor. The surgeon is operating from here and seeing here. The blue basic is the light is thrown which has got a specific wavelength. The part of light is absorbed by this fluorescence which is into the tumor tissue, and rest of the light which has a different color, that is yellow and green, will be only reflected from the tumor, and that will be seen by the surgeon. So this is to identify the malignant tissue. Of course, every technology has got its own limitations. So this is the picture. Now this was a tumor. I don't have the MRI images of this patient, but a normal microscopic vision through the operating microscope is A, where there is no filter is used. Once you expose, you are seeing the brain, which is very much close to the motor strip, and now surgeon is thinking for 10 minutes at where he should put his knife or the start to take out the tumor, because there is no sign of tumor on the surface. And if he is exactly firing the normal brain tissue, then the patient will wake up with significant neurodeficits in the form of upper limb weakness, lower limb weakness, or everything. So now you are seeing the B image is, this patient has been given that sodium fluorescence injection exactly at the time of induction, and by that time we complete our craniotomy, that is 1.5 hours. The microscope change of the filter will give this image, and the surgeon will be definitely and comfortably able to take his incision on the brain. This is again the video which shows how this yellow filter works. This is the microscope, this is the surgeon, this is the microscopic view, and from here, which is white light, is getting converted into the blue light, and the image is changing, and what surgeon is seeing is now different color. So you have to change the source light, then it will be picked up by the malignant tissue as a different color. So now this is the actual microscopic recording of this technology. What you are seeing is the normal visual, and this is the yellow filter, and the tumor tissue is colored differently while removing the tumor. So this malignant tissue, as it is taken different color, fluorescent yellowish green color, it can be taken out easily. This is normal view. Now difficult to differentiate the normal brain tissue, and again you take the filter, you know that what you are removing is the malignant tissue. So this is the yellow filter technology, which definitely helps in the excision of the malignant brain tumors, including the metastatic lesions. So now few words about the neuronavigation, that is third technology. I will just have 2 slides about this. What is the neuronavigation? It is used for cranial as well as spinal surgery, for the cranial or the brain surgery, to locate your craniotomy exactly over the lesion, that is incision marking, then safe and radical excision for the total surgical excision, for functional neurosurgical intervention like epilepsy surgery or deep brain stimulation, that is DBS, what nowadays is coming ahead, that is the stimulators are implanted at certain places into the brain at the near centers, very microchips, and the battery is outside, and they are controlling the function of the brain for various diseases, like most common is Parkinsonism. Now, what is the neuronavigation? It is a simpler concept. If you are using a navigation in the car, the concept is the mobile or the data card is giving electromagnetic waves to the satellite. The satellite is confirming the electromagnetic waves from where it is coming on the map of Earth, and from there on the screen that data is sent to the server, and from server the location is confirmed on your mobile or the car navigation system. The same thing is used. The skull of that patient is converted into a small three-dimensional, I am saying three-dimensional, that is space oriented three-dimensional earth, very small, which has got a clear-cut map in the form of MRI images in all three axes. The image which is seen here, this is your computer which processes the data, that is this cloud server is this computer which is giving the screen. This screen is your device. This is Earth. This tracker is the EM generator or your data card into the card, and this is the satellite, that is gamma camera, which is putting the rays on this tracker and this whole field in three-dimensionally, and whatever the gamma rays are coming back, they are picked up by the receiver, and finally this area is converted into a navigated field. Now I am just showing a video where you will come to know that how these things are working. So the surgeon will have this car which will be located on the screen clear cut, and like that the surgeon will mark his incision. After marking the incision, once he is inside, the moment he is having or he is afraid that he may go or he is going in a wrong direction or he is in trouble, then he can just counter check it by confirming with the navigation. So this is how the navigation is working. I am not showing actual cases or the details of the presentation in the presentation, how it is useful and what. I am just showing you how it works. So the blue marker which is seen on that screen is a tracker, and intraoperatively you can put that into that and you can get a clear-cut idea that where right now you are on the MRI operating inside the skull, and then on this screen or the microscopic view, the images of the tractography are also or can be superimposed, and those tracts can be also saved. So thank you for this opportunity given to me by IMA Satara for presentation of these newer technologies.
Thank you, sir, for explaining briefly and very good presentation. I request Dr. Vikas Patil, sir, to give expert opinion.
A very nice presentation by Dr. Anil Patil, sir. One thing I would like to ask him, you showed a fluorescent technology to identify the tumor, Do you have a separate dedicated microscope having inbuilt facility to put on light, or you apply any other extra light source to identify that?
No, these are the special inbuilt microscopes, which are high-end microscopes, and they are the softwares and everything is built up according to that.
Thank you. Nice presentation. Sir, just I want to ask whether there is any scope for this navigation system in the setup in Satara as like Satara.
Pardon?
Whether there is any scope of getting this navigation system in the small town
Yes,
hospital
I do
villages?
have navigation, and I do have the best navigation, that is Metronics. Fortunately, we are able to offer or invest in that all these higher technologies, including this high-end microscope and navigation with yellow filter. We are having those facilities with our hospital.
Congratulations, sir. Thank you.
Thank you.
Congratulations, sir. Nice presentation. I request.
Sir, I want to ask one question. What is the prognosis after the surgery, or what are the success rates after such
Yes.
surgeries?
Now these things
as compared to normal surgery.
Yes, these things are divided into two parts. Number one, these technologies are helping surgeon to excise maximum possible tumor. I don't say that total excision of the tumor. Sometimes it is not possible, sometimes it is possible, but the amount of tumor safely excised is definitely increased with the help of these technologies. Of course, surgeon skills and his skills are more important than anything else, but they are helping to reduce the recurrence rate or the chances of recurrence. The recurrence free period after the radiotherapy also is higher with the radical excision and safe radical. A patient should remain as if he walked in the hospital, and you should achieve maximum tumor excision, and this technology are definitely helping us to keep our patient intact and to achieve maximum excision of the tumor.
Thank you, sir. I request Dr. Vikas Patil, sir, to felicitate our speaker, Dr. Anil Patil, sir.
Thank you, Dr. Anil Patil, sir, for such a informative lecture. Now let's move ahead with our second lecture. Tuberculosis in India has been prevalent since a long time, and we have been studying and gaining information about tuberculosis. So let's have our next session by Dr. Aruna Rasar Madam regarding what's new in tuberculosis. Let me introduce Dr. Aruna Madam. She has done her fellowship in HIV medicine, in pain and palliative care, and she has been working as a consultant anesthesiologist in HIV and TB consultant over past more than 2 decades. It's a pre-recorded lecture, and it's a live lecture. Sorry, it's a live lecture. Madam is joining live. Let's start with her madam's lecture.
Good afternoon, all. Before starting my talk, I thank IMA Satara City President, Secretary, Scientific Committee for giving me this opportunity. Today my topic is what is new in TB. It is not only about the new TB drugs, but also about the new diagnostic techniques. All of us, some or the other time, get TB patients in our clinics. TB is not only DOTS and prescribing AKT4 nowadays, but now we have to diagnose type of TB in every patient. Multiple mutations are occurring in TB bacilli, and accordingly, the drugs are becoming resistant And this is the way we have to change the diagnosis as well as treatment in all TB patients. So why we need to know this? As you see in this screen, there are almost in India almost 3 million TB cases, and mortality for tuberculosis is more than 4 lakh patients. Incidence of HIV with TB is 54,000. Mortality because of this is more than almost 1 lakh. And if you look at this picture, the MDR TB patients are increasing, and that is more than 1 lakh cases. So if we look at this data, the WHO's notification or estimate for in 2022 is for all tuberculosis cases, they estimated almost 3 million cases, and the notified cases are more than 2 lakh. That is 81% cases are notified. And out of all these, if you look, you can look at these figures. It is MDR TB, more than 1 lakh cases, and 54% of the cases are diagnosed as MDR. So what are we doing for this? So nowadays we all know that the strategy is for NTB strategy. NTB strategy is what we have to do. The milestones are reduction in TB deaths due to tuberculosis. By 2025, it is 75%. Reduction in TB incidence by 50%. And the proportion of families facing the catastrophic cost to 0. But the India has accepted the policy to reduce all this by 2025, and WHO's is for by 2035. So we need to do many steps and diagnose and treat the patient as early as possible for MDR. In this session, I am not going to talk much about the sensitive tuberculosis cases, but I will, because all of us know and we all learn in our curriculum about sensitive tuberculosis, but everything or every day there are changing strategies in managing the MDR TB cases. So we will focus more on MDR cases. So whatever the suspected TB patients coming to our clinics, we need to diagnose them whether they are sensitive TB patients or MDR patients. And for that, we should know what are the tests available, what are different diagnostic facilities available, what are the drugs available, and where do we get the drugs. And to diagnose MDR patients, we cannot just say that patient is MDR TB, but we need to know the resistant pattern also and the definitions of the MDR TB. So what is monoresistant? It is resistant to one first-line anti-TB drug only. The another is INH resistant, that is the biological specimen is resistant to INH, and these patients are sensitive to rifampicin. Nowadays, even if it is a sensitive TB, that is if the patients are rifampicin resistant, we should know what is their INH resistant pattern, because 72% of the cases are becoming INH resistant. Polydrug resistant, this biological specimen is resistant to more than one first-line anti-TB drug other than both INH and rifampicin. Rifampicin resistant, the biological specimen is resistant to rifampicin detected by either phenotypic or genotypic method. And what is MDR? All the biological specimens, whether it is a sputum or extrapulmonary samples, they are resistant to both INH and rifampicin, with or without resistance to other first-line anti-TB drugs. All these MDR patients can have additional resistance to all fluoroquinolones or any other TB drugs. Then pre-extensively resistant tuberculosis cases, where these patients comes in a definition of MDR TB, but they also have additional resistance to any fluoroquinolone. Then XDR TB, you all must have heard about XDR TB, because nowadays especially the patients for Mumbai are coming with XDR-TB reports, and that is all the MDR patients who are resistant to any FQ, that is levofloxacin and moxifloxacin, and at least one additional group A resistance, that is either bedaquiline or linezolid. We will come to know about what are the group A, group B, and group C second line TB drugs in the later slides. So what we have to do for that? So every sputum or every extrapulmonary sample, we have to send for CBNAT testing. So we will also come to know what is CBNAT and what is universal DST. But if you look at this slide, the special group. So what is special group? Special groups are all the patients who are either diabetic patients or HIV positive patients, children who are on chemotherapy or radiotherapy, or COPD patients who are on steroids. All the samples should go for CBNAT or NAT testing. So all the patients to whom we suspect for tuberculosis, samples will go for CBNAT testing, and depending on, we will start their treatment. So what does this CBNAT do? Do we have facilities for case finding? Yes. We have CBNAT, that is Gene Expert, and TrueNAT. These are the tests where we will be able to know the resistant pattern to rifampicin only within 2 hours, and that is in the OPD, and as fast as possible we can diagnose the patient whether they are rifampicin resistant or not. So what is the coverage of this CBNAT testing? It is also available in private setups, but I would like to share with you that CBNAT testing or TrueNAT testing or NAT testing is available in government centers free of cost. Why I am telling it is free of cost? Because CBNAT costs almost about 1,000 to 1,500 rupees for testing, and it is not available everywhere in the small setups. So we will get more time to get the reports. So even in Satara Civil Hospital and in Satara district, it is available free of cost in district hospital, in Beller Hospital Panchgani, and in Krishna Karad Hospital. So this CBNAT testing started from 2017, and now you can see there is a lot of coverage all over the India for testing CBNAT, TrueNAT, and NAT. So there is a wide range of tests, and I actually wanted to share this slide with all of you, because we just do go for sometimes only CBNAT and then we start them treatment with MDR, but it is not like that. We have to test for every drug for the resistance, and then depending on, we have to individualize the regimens. So with the Gene Expert, or we can see the it is a CBNAT, that is cartridge based nucleic amplification test, where we can simultaneously detect the sputum positivity as well as rifampicin resistant test. This is very sensitive, like if you are seeing in sputum AB simple test, if it is a trace positive or sometimes negative, but you are suspecting the patients are tuberculosis positive, and you are not getting the reports as sputum positive, then you can send the sample for CBNAT, and that will definitely give us some idea, or even if it is a trace positive. Then Gene Expert or XDR, this will give us the idea about resistance towards INH, fluoroquinolones, second line injectables, and ethanamide. TrueNAT is usually we do at a point of care unit, that is for diagnosis only. We don't do TrueNAT for follow-up tests. Line probe assay, this is a PCR and reverse hybridization test, and this is available at secondary labs, that is specially for Satara district. It is in the SRL Pune, that is in the Aun, and we usually get the reports within 5 to 7 days or maximum 10 days. So what do we achieve with line probe assay? It is either development or absence of the mutations, and depending on mutations, we do have to change the drug pattern in the treatment regimen. Solid culture, we are not doing nowadays much of solid cultures, because it takes almost 1.5 months to test and get the results. but definitely liquid cultures, that is MGIT, we are doing. MGIT is not available in many centers in government, but the sensitive lab we usually send, and that too under in the with the free to Hinduja Hospital with the Nikshay IDs. And what do we achieve with liquid culture? That is DST of, that is drug sensitivity test for first and second line antituberculous drugs. So this is CBNAT is a nucleic acid amplification test. So the disadvantage of CBNAT is that it takes, we should have a machines for that, or the highly sophisticated machines, and at one time we can test only 4 samples or maximum 6 samples. TrueNAT is a bit, the sensitivity and specificity is less, so we will believe more on CBNAT tests. CBNAT, as I told you, is available free in government centers. So how do we interpret the CBNAT reports? They will give us reports like gene expert report, MTB detected high, or MTB detected low, or MTB detected trace. And below that, you will get the report as rifampicin resistance detected or rifampicin resistance not detected. Line pro basis, this is available in secondary labs, not in district hospitals or even in Velar Hospital or in Karar Krishna. It is available in Aund, Pune, and in other private labs also. So what is the fantasy of this test? That we will get the mutation patterns and we will get the faster results for MDR. And as I told you that for INH, the sensitivity, they are becoming more resistant to INH, and we will get the reports, additional mutations and the drug sensitivity reports for FQ and SLI. MGIT is a very good test, and the fantasy of this test is that the capacity of this test at a time, that is almost 960 samples we can test for every hourly, and the results are available within 7 to 14 days. And other thing is that we can get the drug sensitivity pattern for the second line drugs, not only for FQ and SLI, but for bedaquiline, linezolid, and clofazimine also. So this is a bit complicated slide to see and to diagnose your patient and to start the treatment. But for your knowledge, I just shared it, and afterwards also we can see what are the mutations in that, and with seeing the mutations, how we can change the regimen pattern. So to simplify this, the DST-based treatment or universal DST, CBNAT or NAT for all the TB patients. If the reports are coming rifampicin resistant, all the samples will go for first line LPA and second line LPA and MGIT for other drugs. And depending on that, we will individualize the regimen, including bedaquiline and delaminate. If the rifampicin resistance is not detected, then we cannot just start them on AKT4 or all 4 drugs or 4 FDC. We have to send the samples for first line LPA, because many of the samples will come as INH resistance, and if they come as INH resistance, then we have to give them H monopoly resistant TB regimen. And if they are sensitive to INH, then we will give our routine AKT4 or 4 FDC. So what we have to do before starting the regimen? Because this is a Satara city branch arranging these, I would like to share a few points for Satara district especially. Before starting any regimen, we have to see for the drug resistant pattern in that region. That means people especially who are working in Mumbai, as I told you that basically the MDR cases started more from Mumbai, and the reasons are so many. I won't like to discuss the reasons why the MDR TB emerges and why we have more cases of MDR TB. But definitely, because Satara is a hilly region and we are our many patients go to Mumbai and work there, and then they come back with tuberculosis and to stay here or to diagnose, or once they are diagnosed, to start the treatment from their home place. So that's why the resistant pattern is different in Mumbai. It is same in Satara district many times, and that's why we need to know the history from where the patient is coming. Similarly, the drugs commonly used in that region, drugs were used previously by that patient, the drug resistant pattern in that patient, and comorbidities and contraindications for the specific drugs. Because the second line drugs are more complicated with, there are a lot of compliance issues in that, so many complications or drug side effects are there. So we have to take the detailed history of the drug before, of the patient before starting them MDR-TB regimen. So to summarize, proper history and knowledge of local factors, and to see the pattern of the resistance. So send all the samples for rifampicin resistance through CBNAT testing. If they are coming rifampicin resistance, all the samples will go for LPA, for for first line LPA and second line LPA. In first line LPA, we will get the reports for INH and ethionamide. If the patients are resistant to INH, ethionamide is automatically gone. We cannot give ethionamide if the INH resistance is there. And with second line LPA, we will get FQ resistance and second line injectables, that is amikacin and capreomycin. Then the samples will also go for MGIT. Why I am telling this? Because nowadays we do have all these drugs available in the government setups also. So, and many of the patients are coming with even bedaquiline and delaminid or moxifloxacin high dose moxi resistance. So we need to go for MG, that is individualized drug resistant pattern. Similarly, we also send the samples for follow-up during, this is additional information that MGIT we use for follow-up sputum examination after the treatment initiation. So with LPA, you can see the mutation patterns, and this will give us an idea about INH. So commonly what we see in resistant or INH LPA, the LPA report, it is INH-A, CAT-G, so and WT. So if INH-A is present, that means INH is low level resistance. So in the regimen, we can give the patients INH high doses. If CAT-G is present, that means INH is high level resistance, where we cannot give INH, and accordingly we cannot give ethionamide also. So with this report, we can interpret INH and ethionamide resistance. And we also get WT mutations or even the RB probe mutations. But with this, we can see, we can test whatever is available in the government setup is for FQs. If WT3 is absent or mutations T3B present, then so there are many combinations and of the mutations present, where we can use either we cannot use either levofloxacin or a high dose moxiflox. So depending upon the pattern of mutations available, we need to do the combinations of the second line drugs. So we'll see how to manage the cases of MDR. A 42-year-old female nurse from Delhi approached a tertiary care private hospital for evaluation of unexplained loss of weight. X-ray shows right upper lobe infiltrates. The sputum was, 2 samples of sputum were negative, and the CBNAT was also negative. But still, we had a suspect of MDR-TB. So we send the sample for genome sequencing, that is LPA, and we get the reports like this. See, if you see the report, we can see the sample is resistant to rifampicin, INH, ethambutol, and streptomycin. That means all the first line drugs are gone. So now what we have to look for? Like this is definitely a MDR case, but now we have to look for whether they are sensitive to FQ and second line drugs. So if you see they are the patient is sample is sensitive to ethionamide. So this is a bit doubtful report, because not doubtful exactly. This is generally showing us the resistant pattern, but not the mutations. So what they have seen that given that ethionamide no resistance is detected, linezolid no resistance detected, and other drugs are also sensitive. So depending on, now we have to see for prescribe the drugs. So treatment, so in general, I will elaborate about the treatment of MDR patients, how to give them treatment. These are all first line anti-TB drugs, and why I have not highlighted streptomycin, because in the private setups, definitely we give streptomycin for TB meningitis or pericardial TB fusions or bone TB, but it is not available in government setup, and the reasons are different, not for the efficacy of the drug, but it is for the availability of the drugs or availability of the sources to take the injections. So the drugs used in drug-resistant tuberculosis group, they made the groups, and because we need to take drugs from different groups. So in group A, it is levoflox or amoxiclox, bedaquiline and linezolid. In group B, it is clofazimine, cycloserine. Terizodine is not available in India. Delaminid in group C, delaminid, amikacin, pyrazinamide, ethionamide, PAS, ethambutol, penams are imipenem and meropenem, and one more drug is there, that is cycloserine. We don't use frequently imipenem or meropenems. So bedaquiline and delaminid, these are the two new drugs added in the regimen in 2017. Delaminid and bedaquiline, these are the drugs not available in private setup, and it is only available in government setups. But they are the backbone of the MDR TB regimens. Linezolid, I just want to comment that linezolid we are using in our clinical setups in septicemic patients or in other surgical infections. Linezolid definitely we have to use very cautiously, because we need to preserve this drug for MDR TB management. Clofazimine as I told you, pretomanid is not available in India. Similarly, sutezolid is also not available in India. So how to add the drugs? We have to include all the three drugs from group A, that is levofloxacin or moxifloxacin, bedaquiline and linezolid. So we will take all three drugs from group A. Then we will add two drugs from both the two drugs from group B, that is clofazimine and cycloserine. And just to complete the regimen, when group A or group B are when the drugs from group A or group B are resistant, or we somehow, because of side effects, if we are not able to use the drugs from either group A or group B, we have to add the drugs from group C. So the regimens formed will be levofloxacin, bedaquiline, linezolid, and clofazimine. So the regimens for DRTB, once your patients diagnosed with H monopoly or polyresistant TB, that is patients samples are resistant to INH, 6 to 9 months course of levofloxacin, rifampicin, ethambutol and pyrazinamide. As in other sensitive tuberculosis patients, we usually give 3 drugs regimen in the continuation phase, that is 4 drugs regimen for first 2 drugs, that first 2 months in intensive phase, and INH, ethambutol and pyrazinamide in continuation phase. Here we don't do like that. We give all the 4 drugs for 6 to 9 months. In MDR tuberculosis patients, there are two regimens available, shorter MDR regimen and longer MDR regimen. Shorter is, I'll explain you how we categorize for a shorter and MDR regimen. In shorter regimen, 4 to 6 months of bedaquiline, but in this bedaquiline we always give for 6 months, and levofloxacin, clofazimine, pyrazinamide, ethambutol. Here we always use INH in high dose and ethionamide. So this drug combination for 4 to 6 months, and for 5 months, levofloxacin, clofazimine, pyrazinamide, and ethambutol. So this is the regimen for total 12 months of shorter MDR regimen. And we have another regimen, a longer MDR regimen, where we give the drugs for 18 to 20 months. That is levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine. But definitely we have to change the drugs depending upon the resistant pattern for individual drugs. So if the pattern is like the sample is resistant to INH, that is INH A, and if it is sample is sensitive to fluoroquinolones, then we give bedaquiline plus shorter regimen. That means this is the criteria to give shorter regimen along with bedaquiline. Patients who are whose samples are resistant to INH A. I told you that INH presence of mutation of INH A is only low level resistance to INH. So the patient sample will be sensitive to ethionamide also, and we will give this regimen to these patients. And this is for shorter regimen for 11 to 12 months. If the samples are resistant to INH, and that is CATG mutation is present, then we give longer oral regimen, that is for 18 to 20 months. In this, again, if the samples are resistant to fluoroquinolones, then we always give oral longer regimen. Delaminid, as you've seen in this regimen, there is no delaminid added in this. So whenever the patients are with any other resistant pattern like levofloxacin, or they develop side effects of these drugs, then we can add delaminid in the regimen instead of that particular drugs. So usually we use delaminid as a primary drug in some cases, or replacement drug. So we might have to replace other drugs also depending upon the side effects and the drug sensitivity reports. So for this we called as a individualized regimen. So before starting them bedaquiline containing regimen, we have to always do a pre-treatment evaluation. Pre-treatment evaluation is for all other treatment issues. This is also, there are some additional tests to do because all these drugs are toxic drugs. So along with the routine test like complete blood count or liver function test or kidney function test or BSL, urine examination, we need to do additional investigation of thyroid function test, then pregnancy test, electrolytes, ECG, and two more are there, that is serum amylase levels, serum lipase, and magnesium levels for bedaquiline and delaminid. So additional considerations for bedaquiline, for pediatric patients also we can use bedaquiline, but the age has to be more than 5 years and the weight has to be at least 15 kgs. But it is always with the Center of Excellence consultation, we start bedaquiline in pediatrics.
Hello, ma'am. Last 5 minutes.
Yes. And in pregnancy and lactating women. So pre-treatment evaluation. So all these pre-treatment evaluation facilities are available in all primary health centers, or especially in district TB centers. So we have already discussed about H-mono regimen. follow-up and treatment outcomes are very important. Like once our patients have started on MDR TB treatment, we have to do periodic monitoring of the patient because that is must. And so periodic smear examination, their follow-up cultures, x-rays and other investigations depending upon the side effects of the drug. So there are some side effects of the drugs, especially and for these we call as adverse drug reactions, and many times we need to admit the patients for this. Hepatitis, especially for pyrazinamide. QT prolongation is a new side effect what we have to consider for fluoroquinolones, bedaquiline and clofazimine. So previously we always, not previously, nowadays also, for every bedaquiline addition or bedaquiline containing regimen, we have to admit the patient for 7 days. We follow routine. Every alternate day we do the ECG of the patient and we monitor for the QT prolongation. Another complication what is commonly we have to look for in MDR patients is about hematological abnormalities in linezolid. So monitor their hemoglobin levels because of tuberculosis their hemoglobin levels are less. So and additional anemia will be because of linezolid. Hypothyroidism definitely with ethinomide and PAS. One more important is about the psychiatric side effects, and cycloserine is the commonest drug which can cause psychiatric symptoms in MDR patients. And optic neuritis, not very common, but still we are getting patients with optic neuritis who are on linezolid based regimen, and ethambutol you know all. Then discoloration of the skin, that is reddish discoloration, the whole body becomes red because of clofazimine, but we never stop treatment because of this, and this doesn't cause any systemic side effects. So just discoloration of the skin we will not stop clofazimine. So you can see with this that the success rate for treating tuberculosis is increasing nowadays because of large coverage, early initiation of the MDR TB regimen and availability of the drugs on a wide scale. So now you all know that tuberculosis is a notifiable disease now. So every case we need to notify the case. Bedaquiline and delamine is available only at government centers. So to conclude my topic, so we need to increase the case findings, access to CBNAT testing. All the pulmonary and extrapulmonary test samples should be tested for CBNAT and drug sensitivity test. Diagnosed drug-resistant cases should be referred to nodal DRTB centers. So why I'm telling this, I know that this is not a platform to advertise our hospital, but in Satara district, Beller Hospital is the only nodal DRTB center where the MDR treatment initiation occurs, and every patient will get free treatment, free admission, and everything free for DRTB, MDR drug initiation. So everywhere, whenever there is a diagnosis of MDR TB, we need to send them to nodal DRTB centers in every district. And another I want to emphasize here for the partnership and involvement of all private practitioners also, because we always, whenever we start or any patient comes to us from the private hospital, we always connect with them, and we will refer the patient back to them as a treatment supplier. We give bedaquiline and delamine to the private practitioners also to continue their regimens. Thank you.
Thank you, ma'am. Any questions?
Hello. Good.
Hello.
Nice presentation, madam.
Thank you.
There is question for you.
Yes.
Can we start empirical tuberculosis EKT on clinical backgrounds? One. And another question is, in the private setup, can we start anti-tuberculosis treatment by the rules of government?
For first question, I would like to answer that we can start the treatment in private setups, but not for the MDR, because every patient's diagnosed as MDR, we have to notify them. We need to give them the Nikshay ID number, and as I told you that bedaquiline and delaminid is available only at the government centers. You will not get unless the patient is registered in the Nikshay ID. And another question is, I forgot what is
In the private setup, what are the facilities of the government to start the AKT?
Yes.
That's what I want to ask.
For the private setups, from all the private setups, we accept the sample for Sibinat, either in the DTC Satara or in the Karad or in Bellar Hospital. And once the patients are diagnosed, we will tell them to admit the patient in DRTB nodal centers for 7 days for the initiation of the treatment. And then the patient will be referred back to them and will continue the treatment from their own hospital or wherever the patient is patient wants to take from, either from the private or from the government setup.
So madam, without doing investigations, when we clinically diagnose this case as a tuberculosis on the
Empirically, the first question was empirically, sorry. Clinically, definitely we can start TB treatment empirically for MDR, for sensitive TB, but for MDR TB, definitely not.
We got the answer for MDR, but in the routine case, when we
routinely, definitely routinely for sensitive tuberculosis, you can start treatment in your own clinic, but every patient has to be notified because it's an act now. Every TB patient should be notified. You just have to the STS and STLS comes to the clinic. They always take the information from all the hospitals. Majority of the times where the pulmonary or extrapulmonary cases are diagnosed, even in like in Satara, where there are chest physicians, the STS and STLS go monthly to their clinic. They will ask the clinicians what are the what number of cases are diagnosed in their clinic, and they will register.
Yes, they are giving 500 rupees also.
Yes, there are many facilities available, like even for the nutrition as well as the transport allowance. Then for treatment evaluation also, all the investigations are free.
Thank you, madam. Very nice lecture presented by you. We are very much thankful to you. Your contribution in the SATCON is very nice. Thank you, madam.
Thank you very much, ma'am. As we all understand, tuberculosis is such a vast topic and we have a lot of questions. But because we are running out of time, we'll have to end your lecture over here. Thank you so much for sharing your wealth of knowledge and insight about tuberculosis. Let's move on to our next lecture. I would like you all to introduce you to our distinguished speaker. He is Dr. Rahul Dev Vilasrao Khade. He is a retired major and is a member of Medical Legal Association of Maharashtra, currently working as forensic expert in District Hospital Satara. He has been serving Public Health Department since 2004, and he's a gold medalist in Summer MUHS MD exam 2017. And as we all know, in this this paced world of medicine, keeping record is just not mandatory, but I'm sure most of us have experienced it has turned to be a lifeline sometimes. So now let's hear from our experts. I would like to welcome Dr. Khade sir to throw some light regarding how important it is to keep the medical records.
Thank you so much, ma'am. Yeah. Thank you so much. At the outset, I would like to express my sincere gratitude to Satara IMA, especially President Dr. Sharad Jagtap, Secretary Dr. Deepak Thorat, and all other doctors present here. As while introducing, ma'am has rightly told that medical legal documentation as well as medical records has a very important part in every doctor's life. So to begin with, how do we define medical records? So it is basically a systematic documentation, collection of information about individual's health and his medical history, which is created very systematically, maintained, shared by different healthcare professionals, for example, doctors, nurses, consultants, and other paramedical staff. So as I told, documents which contain a chronological written account regarding patient's medical history, complaints, physical findings, results of diagnostic tests, medications, therapeutic procedures, day-wise progress notes recorded by medical practitioner who is treating the patient. And of course, it is part of medical training. Let me tell you that it's not only a hospital, a big hospital, corporate hospital, but a GP also has to maintain this record, even if he is treating the patient on OPD basis. So why medical records, medical legal records are very important in any doctor's life? Why it is needed basically? So in the interest of the medical science, for own safety and interest of that particular treating doctor or a hospital, medical record serves as a basis for the patient's care, for continuity in the evaluation of patient's treatment, prognosis. It also serves as a documentation for reimbursement, insurance and legal interests. Let me tell you here that it is the only proof or a documentary proof that a doctor is treating the patient. So you can understand the importance of medical legal documentation as well as medical records. It also provides data for use in medical education as well as clinical research. We'll come to that afterwards. Chain of communication between the doctor who is treating the patient as well as any other healthcare provider, any other consultant who contributes to the patient's care. For assisting in protecting legal interest of the patient, hospital as well as treating doctor. Also for follow-up of the patient, evaluation of drug therapy and cost accounting. It is specifically and specially required in cases of professional negligence, claims of third-party payment under health and accident insurances, life insurance claims, disability policy, Workmen's Compensation Act, traffic accident. So here, if we speak of details, it is required in criminal cases as well as civil cases. So what are the requirements of ideal, accurate medical record? To start with, it has to have a proper name of the patient, his father's name, age, sex, occupation, address, date as well as timing of the visit of the patient to the nursing home, to a doctor or a hospital, evidence of informed consent. As we all know, we have to take it in writing in a language which patient understands. Then we have to go about brief history of the present illness, his complaints, relevant medical history, relevant past history, family history, findings of a general physical as well as systemic examination, diagnostic aids, any reports received applicable to the patient, date and hour of consultation with details and opinion of consultant if the patient is referred to other consultant or a super specialty, clinical impression with provisional and final diagnosis, progress notes which includes clinical observations, various instructions given to the patient, for example diet, etc., complications if any, further notification as to any lack of cooperation by the patient. We have to write that in his indoor case sheet if he is not cooperating for the treatment or any advice given by the treating physician, surgeon or consultant. Failure of the patient to follow the advice or to follow given appointment. See, these details are very important Generally in day-to-day practice, we don't follow that, but every one of us is supposed to, considering the fact that people with a lot of social media and information provided on WhatsApp and all, everyone is so aware of their rights. So it is pertinent and very important that we as a doctors, to avoid medical negligence suits or any further complication, it is very important and compulsory for us to write down each and every detail in the case papers. It also includes details of the treatment, any procedure, operation performed or recommended. In emergency cases, specific clinical data and observation should be noted periodically. In indoor patients, condition at the discharge, whether he is cured, relieved of complaints or referred to higher center, whether he is absconded, whether he has taken discharge against medical advice or discharge on request. So just to summarize what all is required, essential components of a comprehensive medical record, as you can see, patient's information, I've already mentioned medical history, physical examination, consent form, form of informed consent, doctor's orders, nursing orders, progress reports from the doctor, reports on consultations, additional or any other reports, diagnostic procedures as well as lab results, operative report, anesthesiology report, pathology report and discharge summary. So we come to different records and registers, which are like various registers we use at a hospital. So this covers government hospital as well as any private hospital. So first and foremost is OPD / treatment register. It is one common register for patients of OPD as well as emergency. It's a main register of a hospital where it comprises of a preamble, chief complaints of the patient, examination findings, what is the provisional diagnosis and what is the plan about the treatment. So this register has that. I would like to tell here that every register of the hospital, whether it is OPD treatment register or whatever registers we are going to see soon, it has to be numbered. To explain it in Marathi, आपण त्याला म्हणतो की register बांधून घेणे. म्हणजे we have to number the pages. It has to be certified by the CMO or RMO of a hospital with sign, signature and stamp. So second is inventory register, as we all know. Various consumables, non-consumables, we have to mention in that inventory register, indent register, information about drugs, consumables, equipment and instrument. Third is referral register, information on referral, in, out, with reason. Follow-up cases also it comes to that register. Handing over and taking over register, which generally involves when the duty is over, the relieving staff has to inform the incoming staff about the critical care equipment present in that particular ward, OT, and patient's daily notes. They have to hand over the patient, telling the incoming staff about everything regarding treatment as well as any other things. We have to have a patient / community feedback register at the hospital. It's very important. At-risk register for vulnerable patients, we have to take it in writing. Generally, we do it on the paper, but any register is always valuable as it can be preserved. Emergency register, first register of the hospital, should include demographic details about the patient, clinical findings, chief complaints, provisional diagnosis, and the referral of the patient to different departments. And last but not the least, very important, the medical legal register and medical certificate registers. So while maintaining the medical records, what are do's and don'ts that we should follow? So medical record, it should be or must be very accurate. It has to be appropriate. It has to be chronological, factual, relevant and complete. No alterations should be done, nothing to be deleted, substituted or added from the record. Tampering is a big no. So it may cast doubt on honesty of a doctor. Tampering may benefit the patient even in case of no negligence. I mean, large sum of money can be awarded to the patient if the suit is filed and tampering is found to the court. If correction if it has to be made, it has to be on a prior entry on a record. It should not be totally obliterated, but only a single line is enough, which is to be drawn on a word or a sentence to be changed. So correct information needs to be written above the line drawn and with date and person's signature, and that person has to have an explanation to justify why that change has been made. In case of litigations, court matters, court really appreciates and give importance to good notes. So good notes can act as a supporting factor as doctor's strongest evidence against patient or patient's witnesses. Now we come to the rights of the patients as far as medical records or medical legal documentation is concerned. So patient has the right to know what is in his records. He has every right. He is entitled to copy of the hospital record on his discharge by paying whatever fees. He is entitled to a Xerox copy, not an original, which has to be attested by RMO on duty. In case of patient's death, next of kin can get MR by paying the needful fees. Hospital and treating doctor has to maintain the confidentiality and secrecy of the patient's MR, that is medical records. Patient is denied medical records in case treating doctor thinks making available of this medical records to patient is harmful and dangerous or is not in the best interest of the patient. Without the consent of the patient, medical record is never handed to any other person, whether it is OPD papers or IPD papers. Even police does not have the right to demand medical records, except, as you all know, when there is a statutory provision for such a requisition in cases of medical legal cases. Only in that cases, police has to give the requisition in writing, and then only they can get the Xerox copies attested by RMO of a hospital. Medical records cannot be used in educational and for diagnostic purposes, conferences, research publications without the patient's consent. It's very important. That has to be kept in mind. Only instance where without patient's consent, MR can be used is for statistical purposes or to determine the care of the quality provided to the patient. So further, we move on to medical legal documents. So I have spoken about all the medical records which are of a normal patients, but as we all know, medical legal document is a very important document. Such cases are very important. There may arise in future disputes and the case may be filed against the doctors. So we have to be very, very particular as far as medical legal documents are concerned. So it has to be prepared by doctors on request of investigating officer, that is police, usually in criminal cases. But as I told earlier, not only in criminal cases, but in civil cases also, we have to maintain the documents. Examination of injured or a dead person is done only after requisition is made in writing by police or magistrate. As we all know, we can get the court orders also to produce a particular document in a particular case. So basically any medical legal documents or a certificate, it consists of three parts, that is preamble, the facts observed on examination, that is body, and the third is opinion drawn from the observed facts. It is admitted, as we all know, evidences only when doctor attends the court calls and testifies the fact under the oath in a court of law. So the preamble consists of name, age, sex, date and time of examination, place of examination. The body contains proper examination, and the conclusion has an impression which is derived from the facts that has been observed while the examination of the patient. So what care has to be taken while preparing medical legal documents? We have to avoid any loose wording or careless statements. Should show competence of a doctor or an expert. It has to be a record where there is a lack of bias, and it should offer a concrete professional advice. It should be very clear, concise, it should be legible, readable, should avoid technical terms, shouldn't have any abbreviations, should be in a duplicate copy always. One copy has to be preserved with the hospital and another copy with due signatures, taking the received signatures, has to be handed over to the police or a court. Then we come to different medical legal certificates which we issue to the patient. So what are the prerequisites? First and foremost is we just cannot hand over any certificate to patient without the police comes with a requisition. So requisition has to be made by the police. Of course, we can give the Xerox copy of the certificate to the victim himself, not to the next of kin or relatives of a victim. So we have to charge nominal fees, and then the Xerox copy attested by the examining doctor can be issued to the victim and to the police. The original document is handed over to the police. Requisition regarding different samples, especially in cases of poisoning. If by the order of the court, the copy of the court order has to be produced by the police. So what are the different areas of medical legal assistance? So medical legal certificates, as we all know, these are provided in form of injury certificates, age estimation. So this is generally done in POXO cases or rape cases. Examination of an alcoholic, drunk and drive cases, the very important thing is sexual assault cases, examination of accused of a sexual assault as well as victims of sexual offences, dying declaration and chemical analysis report. And of course, last but not the least, post-mortem work. So these are all areas of a medical legal assistant where with the judiciary as well as police, we work along with them to help the speedy justice. So what are the types of cases treated as a medical legal? So as we all know, injuries, burns, vehicular, factory or other unnatural accidents, suspected or evidence of a foul play in a case, suspected or evident criminal abortion, unconsciousness where cause is not natural or not clear, cases of suspected or evident poisoning, cases referred from court or police, cases brought dead with improper history. So the process is first line of treatment. Any case coming to your hospital, first and foremost is, as we all know, Supreme Court guidelines, we have to save the life of the patient. The rest of the documentation and medical legal part can be taken care afterwards. So first, as a doctors, we have to save the life of the patient. So treatment for medical legal cases include, as we all know, pharmacological, that is medication, medical, surgical, and psychosocial in cases of sexual violence and child abuse. We have to inform the case to the police without fault. MLC police information form has to be filled in duplicate. One copy is to be handed over to the police and one copy is written, as I told earlier, in the hospital records. We have to examine the case, prepare the medical legal report. There are different guidelines from Ministry of Health and Family Welfare, Child Welfare, especially in cases of sexual violences. Everyone knows the POXO Act. We have to have a copy of POXO Act in your hospital. It is not only the government hospitals which are supposed to examine the cases. In case of an emergency or police deems that fit, in absence of any government facility, a private practitioner also has to oblige the law and police and examine the female. Patient's case file is to be stamped as a medical legal case. Even the laboratory reports or a requisition sent to the lab or X-ray or radiology, each and every requisition form has to be stamped as a medical legal case without failing. Consent of the injured person on the medical legal register has to be taken. In case of minor, role of guardian is very important. Consent has to be taken if the patient is less than 12 years of old. Collection of samples and documentation. Different samples has to be collected without any delay. Documentation has to be the form, necessary forms, they are to be filled completely and handed over to the police. The medical legal cases, they should be kept under lock and key and in custody of the doctor concerned.
Last 2 minutes, sir. Sorry.
So in case of medical records, we are not supposed to provide the medical legal documentation under the RTI. It has to be kept confidential and secrecy has to be maintained. Only if the court and police ask, then only we are supposed to hand over, and then the third party or patient's relatives can be asked to take the Xerox copy from the police or a court. So we come to the few final slides where what is the period or a maintenance of a medical records, what are the standard guidelines. So in case of OPD papers, we have to preserve the OPD papers for 3 years. Indoor patients, it is 5 years from the date of commencement of treatment. Routine case records, they're up to 6 years after completion of the treatment and up to 3 years after the death of the patient. Where there is a chance of a litigation of a medical negligence, at least 25 years, especially minors. Medical legally important records up to, it has to be 30 years. After 30 years, if it has to be destroyed, a committee has to be made, especially in a government hospital, whereby the order is passed to destroy it. But now, since this is the age of digitization, we can summarize all the records, digitize it, and store it for eternity. Certain records are of public interest to be transferred to the public record library after 50 years of release to the public. Records which generally involve the confidentiality of the individual only after 100 years till the case is going on. It is not to be released. If request is made for the medical records either by the patient, authorized attendant or legal authorities involved, the same may be duly acknowledged and document without fail has to be produced or issued to the patient in Xerox within 72 hours. Now, as you know, in all your hospitals, there are various cases where the patient dies, especially in cases of road traffic accidents, poisoning, or any foul play. So, in cases where deceased was hospitalized prior to the death, and if the postmortem is necessary, so treatment record generally help the PM, the medical officer who is going to conduct the postmortem. So, he is able to deduce the cause of death by studying the hospital records for what he was treated, the different kinds of operations performed on the patient when he was live, differentiating therapeutic wounds and artifacts from those of assaults, as we all know. And in cases where suit of medical negligence is firm, all the documents are to be provided to the police along with the Panchanama, which has to be Xeroxed, attested by the treating doctor. So medical records in such cases carry a great significance. So list is never ending. Hence, bringing hospital records, like every practitioner should send hospital record when they are sending the body to the government facility for postmortem. Treatment records, they generally help the investigation mechanism, as well as they decrease the delay in investigation. So to conclude, good notes are of a great value, not only when handing over a patient to another, but also in meeting any criticism that may arise from. Thank you.
Any questions?
Sir, there are two things. One is about medical records in OPD patients, and second thing is about medical certificates we are issuing in OPD basis. त्याचे रेकॉर्ड्स ठेवायला लागतात का, किंवा एक कॉपी आपल्याकडे ठेवायला लागते का, आणि ओपीडी बेसिसच्या पेशंटचे रेकॉर्ड्स आपल्याकडे किती ठेवायचे, काय ठेवायचे, त्याचा काय रूल्स आहेत?
So the standard rule is any medical certificate you are issuing to the patient, it has to be issued in duplicate. The original copy you are supposed to hand over to the patient, and your OC or a Xerox or a carbon copy has to be maintained in your nowadays all the hospitals, they have a designated specific department called as a medical records department, and we give a MDR number to a particular case, whether it's a OPD or a IPD. So anything you issue to the patient, it has to be numbered, and original has to be issued with due stamp, your name, degree, and then a receipt has to be taken from the patient. It has to be stored. And in case of OPD papers, the rule is you have to have the record for 3 years from the date of examining the patient on OPD basis.
Wait. What should be the policy for the broad dead patient?
So the policy
Number
for
one,
the broad dead
and
patient.
another question: if somebody directly answers like me that at the end of 3 years I don't have a record of a patient which was got admitted, treated, expired or discharged, whatever it may be, but it is a MLC case and there is a case going on into the court. So if I admit in the court that unfortunately I am not able to maintain the record of this patient, so what can be the worst consequences?
Sir, it loosely comes under destruction of evidences. So if the judge is good, you are fortunate enough, then he can take it lightly. Otherwise, there may be the dire consequences. Secondly, in all the broad dead cases, the first and foremost thing is you have to inform the police. And broad dead cases, MLC number has to be given to that particular patient, because you don't know how he has died. So you have to inform the police, and then police will decide whether there is a foul play or otherwise. So every doctor has to inform a BD patient, entering all the details in his BD register, and then the copy in duplicate has to be prepared. MLC number is to be put, and then original has to be given to the police for information and for the needful action.
And the relatives are ready for all these things. It is very difficult to make it compulsory in
Sir,
a
in
private
civil
sector.
hospital now,
BD patient, once the houseman or anybody declares that it is BD, there is nothing can be done. They are in rush to take the patient back
no,
immediately.
that's what I'm trying to tell you, sir. Like in private hospitals, it may be a bit easier, but in civil hospital, it is very important and pertinent for, like, basically compulsory for us to inform. Now what, since I have joined here, what earlier used to be like just in case to avoid the postmortems, doctors were not that particular. If the relatives are saying if we don't want to go into the further medical legal procedure, they used to just carry the body just like that. But now we have formed a particular set of rules where each and every BD has to be informed to a police in a manner I just mentioned in duplicate, and then now the ball is in police's court. Now they have to decide, is there any foul play or otherwise. If they produce, what I have told all our medical officers is simple: if they produce a panchanama, head to the mortuary, do the PM, issue the report. If they don't produce the panchanama, you sit idle as long as the body goes, because once you inform the police that a BD case and MLC is registered, the body is legally the police's headache. It's not yours.
Once it has, or twice it has happened that we have informed to the police that there is a BD, but by that time the police is there, BD is gone.
So
The
it's none of
relatives
your
have
fault, na,
taken
sir.
the body.
See, what I'm trying to tell you is you have to have a documentary evidence that you have registered BD, you have registered MLC, and you have sincerely made an effort to inform the police that so and so BD has come at so and so time. So now the police will decide. They can even go to the house of the, there are many instances where from the funeral side the body has been taken back to the hospital and then the postmortem is carried.
Audience question, obstetrics records, birth records.
Since it is not an MLC, you have to have a whether it's an IPD for 5 years. If it is on a OPD basis, birth is, I suppose it's always has to be indoor. So the whatever rules are for indoor patients, it has to be applied to that also.
18 years, 20 years, still
No,
that baby get adults.
Let me tell you, this is in case of a surrogacy. In a case of a surrogacy, till that surrogate baby attains the age of 18, we have to maintain those records. It is only pertinent to surrogacy. Anything else? Thank you.
Thank you, Dr. Khade sir, for creating awareness regarding this less discussed and sometimes much neglected topic. And I'm sure that the awareness cultivated here is going to echo in our day-to-day practice. So I would like to request Dr. Thorat sir to felicitate Dr. Khade sir. Thank you, Dr. Khade sir. Dr. Thorat sir, please, I would like to request you to felicitate Dr. Patel sir for being a MMC observer over here. After having discussed about this much important topic. Now, let's move on to our next topic by Dr. Sanjay Patil, sir. I would like to introduce Dr. Sanjay Patil, sir, first. Sir is a gold medalist in ophthalmology from University of Pune, and he has been practicing over last 27 years. At present, he is the Honorable Secretary, Hospital Board of India, IMA, Director, IMA HBI Headquarters, Chairman, Hospital Board of India, Pune, Executive Trustee, IMA Pune, a regular CWC member, IMA Headquarters, Vice Chairman, IMA JDN Headquarters, and Member Finance Committee, IMA Headquarters. And it's just not that. During last 27 years, he has been working as an office bearer, sports chairman, and then joint secretary of IMET. It's a big list, sir. If I'll start reading, I think I'm gonna take next 20-30 minutes. But I would like to make a mention to everyone that it's not just academics. He has been a marathon runner, a cricket and a badminton player, and likes to go cycling also. It's really an honor to have you, sir, here. And without taking less time, I would request you to start with our next topic, that's problems in front of hospitals and their solutions. Thank you, sir. Sir is joining us online.
Thank you, madam. At the outset, I would like to thank Satara IMA, especially Dr. Jagtap and Dr. Thorat, and my friend Dr. Lahoti and Dr. Avinash Bhosle, and all team of IMA Satara. I must congratulate SATCON organizing team for organizing such a wonderful conference. Friend, to start with my topic, So our topic is problems faced by small and mid-sized nursing homes and the probable solutions, because we cannot pinpoint the solutions every time. So I keep it as a probable solutions. Just a minute.
Hello.
Yeah.
Hello, sir, you can start. We can see you.
To introduce the topic, I have chosen few important problems faced by small and mid-sized hospitals. The problems are like every day we face this renewal and new hospital registration, then NPCP issues, then fire issues, then manpower availability and other issues. Many a times we need to get the accreditation like NABH, then insurance. Recently it is cashless everywhere. Then Consumers Protection Act and few Rugna Hakka Parishad, like so-called patient NGOs, and violence, of course. So these are the problems, and we face these problems in the day-to-day practice. Previously, why these problems are increasing, and you can see that before say 2000 years, there was no need to keep such talk in our conferences, in academic conferences, and now it is a time to discuss such problems in the conferences, because the volume is increasing, the complexity is increasing. Previously, the nursing homes were like run by a doctor or a couple or a group of doctors. Now the corporates have entered in this our business, our profession. So the regulations are getting stringent and strict, and there are nearly 110 permissions required for any hospital to start with. But these regulations are becoming over-regulations for our small and mid-sized hospitals. So the problems are increasing. At the same time, the demands from society are increasing. And friends, the problems what we face are of important is if there is a problem, there is a solution, then another problem. But the problems are happening everywhere in Maharashtra with a different duration with different complexity, different variety and severity. So it is a complex process to solve these problems. And important thing is owners awareness is lacking. Many doctors, they can't find time to read all the documents related to the acts or the provisions. So it is better we get aware about the various provisions in the acts, various acts, especially Nursing Home Registration, MPCB, Fire, and Consumers Protection Act. Then new things there are two new things coming, that is Hospital Management Information System, that is HMIS, and second is Ayushman Bharat Health Account Card, and the government is making it mandatory for each and every hospital. And there is a problem with the government schemes, and very important thing is what we will discuss is the role of associations, how IMA and colleague association are taking part in the solving these issues. To take a few important issues, first is the renewal or new hospital registration under Bombay Nursing Home Registration Act. So friends, the Bombay Nursing Home Registration Act was implemented in 1949. Then now it is termed as a Maharashtra Nursing Home Rules, and it is amended in January 2021. That everyone is aware of this thing. For a new setup, we have to get building permission from building department, and according to National Building Code, we have to comply all the things, and then we apply to the health department to get the final registration. So building rules we should know by heart, that National Building Code, and we should have one consultant who can guide us, architect or some consultant from the local authority to guide us about the building plans and get the approval. This is regarding the new hospital registration, but for renewal, everyone knows that we have to abide by this Bombay Nursing Home Registration Act and amendments done in January 21. And most probably government is trying to implement Clinical Establishment Act 2010. So what are the problematic things in amendments of this Bombay Nursing Home Registration Act? So there are many problems we find in this amendment, but to enumerate a few important problems, that is first and foremost is registration fees. Registration fees, they have increased to 5,000 per 5 beds and 5,000 per 5 beds onwards. And top of that, for every renewal, subsequent renewal, they will increase this registration fees by 25%. So this is a big hike in a registration fees. And basically in Bombay Nursing Home Act, what do you mean by registration fees is to maintain the record of that hospital. So this much of fees is not required, because this is the work done by health department, and this is their mandatory work, to give a registration or do the inspection or to regularize the healthcare establishment. So the fees should not be like this. Then they have specified manpower requirements. For more than 10 bedded hospital, they have mentioned that RMO, who will be the MBBS, and one RMO per 3 beds, and qualified nurse, one nurse for 3 beds. And to that, this is in a shift format. So this is very difficult to comply, and the manpower is actually not available. So this is impractical to implement this amendment. Then most probably they will apply the infrastructure requirement retrospectively. So the hospital running for many years, they will suffer in this because of these amendments. Few minor problems are display of charges, but they are insisting that you have to display all charges. But in few cities, we are displaying the charges mentioned in the amendments only. So the chart is very small, and we can go through that chart. Then they have insisted to display the patient's rights and display the toll-free complaint number from the local authority. And previously they used to inspect your hospital every 3 years. Now they are going to inspect the hospital every 6 months. And top of that, the scope of inspection is not mentioned anywhere. So it is not defined. So what we are suggesting, or we have represented through IMA Hospital Board of India, and we had a meeting with Honorable Health Minister into October 2022 and various authorities. And then we had 2-3 meetings with the Joint Director of Health, and he recommended to the Health Secretary that there is a point in demands put by IMA, and we should reduce the fees to 1,000 rupees. Then we should give some immunity to these hospitals, say 5 years immunity for manpower requirement. Then no in the retrospective implementation of infrastructure requirements. And these 3 things we have accepted because these are the simple things to do, and we have insisted to get the scope of inspection. So we are waiting for Health Secretary's office to amend it further. So most probably in weeks time or to 15 days, they will modify it and we'll get a new amended circular very soon. So coming to the next issue is MPCB. This is a very necessary compliance because now they have included us in an industrial category, and for pollution board we are in their orange category. There are 4 categories: red, orange, yellow, and white. But we are in orange category. Most of the hospitals are in orange category. Few hospitals are there in the red category too. Because of National Green Tribunal Act and Central Pollution Board, they are taking cognizance of this pollution. And our category is mainly water polluting category. So we have to comply with the MPCB norms. Recently, they have come out with from November 2022, they have come out with the combined consent and authorization. Previously, we used to get authorization, but now they have started taking combined consent and authorization, that is a CCA. And problematic thing is that they take charges of this CCA as per capital investment of any hospital. Then everyone is aware of STP and ETP requirements. Then biomedical waste management charges per bed. We are asking to have biomedical management charges uniform all over Maharashtra, and it should be per kg and not per bed because the occupancy is less in a very few hospitals. Then there is a very interpretation of various provisions and manpower by various authorities at various places, various cities. They interpret differently. So we have demanded to MPCB. We had meeting with member secretary MPCB, Mr. Avinash Dhakne, and we had invited him as a chief guest at IMA Pune. And our demands to MPCB are many, but to enumerate few, that we should have a dedicated portal with the ease of application and with a minimum documentation, because our hospitals are registered with the Bombay Nursing Home Act with the local authority. So documents are already submitted. So if I get a Bombay Nursing Home registration document, that should be good enough. And there has to be a dedicated portal for the application of CCA. And we have requested them to reduce the CCA charges and not link it with the capital investment of any hospital, because various industries are located in a peripheral area where the land rates are very less, and we are running our businesses or our hospitals in the center of city, so the rates are quite high, and the CCA charges are quite high for any hospital from Maharashtra. So we have to get a clear guidelines for STP and ETP, because they have amended further and they have dropped this word STP and ETP. What they are asking, the latest circular is there. They are asking for the output discharge quality, and they have specified the quality measures required for the output discharge. So we should get clear guidelines and uniform rates for biomedical waste management all over Maharashtra, and should be per kg weight of biomedical waste. The third important is a fire. This is also a necessary compliance. and there are increasing incidences of fire in the hospitals also. And friends, we also insist that the hospital should have fire safety protocols or training or equipments. And this is for the safety of our patients, ourselves, and our staff. So, what is the fire compliance as such? Once you build a building or any builder construct the building, they get fire approval as an initial compliance. So fire approval is done and the commencement, we get a temporary approval, and with the completion certificate, we get the final fire approval. So this need not to be taken by any individual hospital. But then we started getting fire NOC from fire department. But fire department has got very less manpower, so they have delegated this work to fire agencies appointed by fire department of Maharashtra. That is, we get B forms. So once you get fire NOC or fire approval, need not to get that again as per one document which we have, and subsequently we should have B forms from the government approved fire agencies, and they have specified the required fire equipments and necessary measures in the Fire Act 2016. So we need to go through that act, and very important is training of our staff, mock drill of fire safety, and importantly, what IMA HBI is doing, we have releasing one advisory to our members how it should be as a fire safety compliant hospital. So fire is also important process. About the manpower requirement, there are two things. One is a Labor Act and Minimal Wages Act, and these various acts we have to follow. And important thing is availability of qualified nurses. So there is a very less availability of qualified nurses all over Maharashtra, and they cannot insist that one nurse per 3 bed. And we have put one RTI in Pune Municipal Corporation that how many qualified nurses do you have in your hospitals? And they have 1400 plus beds in the Pune Municipal Corporation, and they have only 198 nurses working with them. So they are also struggling to get the nurses. The figure is 1 per 10 beds. So we can put that RTI. I can share it with the IMA Satara. Another thing is insurance issues. Everyone is aware that cashless everywhere. They are going to force the cashless. Previously, there was a problem with the empanelment of the hospitals to get the cashless. Now they are forcing the cashless to the hospital, but they are still doing the trafficking. That they have mentioned only 40,000 hospitals all over India will get the cashless facility. The 40,000 hospitals which are registered with the Rohini portal, and many other hospitals are not registered with the Rohini portal. So there will be a problem and commotion with the many hospitals. And we should go through this notification released by IRDIA about the cashless everywhere. And IMA headquarters, along with the IMA HBI headquarters, are soon going to write to the GC, Governing Council of Insurance, about this cashless everywhere. So our plan is to have a scientific rate list at our end, and then we will sign it on a common platform, not as an individual. Now the NABH and accreditation things are in the past. Now it is not necessary for the cashless empanelment. So there are many other issues like Consumers Protection Act, Rugna Hakka Parishad. They are troubling our members. So they create unnecessary nuisance and they create unsafe atmosphere at workplace. So we have to deal it at a local level. Last point is about the violence. Violence, we are observing that violence is increasing for last 7-8 years. And why it is increasing? Because there are many reasons that society's demands are increasing, the number of procedures are increasing, the expectations are increasing, the number of patients are increasing, infrastructure and manpower availability and short of medicines or other instruments So these are many things leading to the increasing violence all over India or all over world against the healthcare workers. So IMA is working on this. IMA's aim is to total no tolerance to the violence. There should be zero violence, and there are many ways they have this. We have sorted out that there are many ways to for the prevention of the violence. How one can prevent and preparedness by the local association. One can have the rush teams. In IMA Pune, we have 32 rush teams as per police station, various police station areas, and we activate those rush teams when we get call from our member. This is the preparedness to be done by local associations, and it is important how to sense the violence at the hospital level, and your staff will give you the clues about the violent behavior, or they can give a intimation that this is a troublesome patient. And after the violence is happening there, the on-site management is also very important, and it is a topic of different, total different topic. And what we are demanding, we demand to have a strongest and stringent act so that it will take care of this violence. So friends, there are various solutions, and as I said, IMA, HBI are working on these issues very regularly, and in fact, we are working proactively for our members, and we are helping each other as per the theme of our conference that to help each other. So, but what I request everyone, it is important to become a IMA Hospital Board of India member. Every hospital should become a member of Hospital Board of India, because every member is affiliated or attached to IMA, but their hospital is attached to the IMA through this HBI sub-wing. I request everyone to become a IMA HBI member. And if you require any further information, you can contact me about this HBI membership. With this, I conclude over here. Thank you.
Thank you, sir, for such a brief and canned lecture. I know it is a very elaborative topic. You made it very brief, and we have a lot more to hear from you. Thank you thank you very much for sparing your time.
Thank you, sir.
At this moment, we cannot allow many questions because there are pending ones, but we are running short of time. So we hope to see you again.
Right. Thank you. Thank you.
Very good afternoon, dear delegates. After listening to the problems faced by the hospitals and the remedies over it, let's move on to another burning topic, is cyber parenting. I know recently you all might have heard that not even just 24 hours passed, Mark Zuckerberg has recently apologized in front of the whole world for the loss of children. And that has turned to be a very burning topic again regarding Child Cyber Protection Act. And now we are proud to say that in SATCON 2024, we have come up with a great panelist, those who are gonna throw light on cyber parenting. And without wasting some time, I would like to call upon Dr. Sanjog Kadam, sir, to chair this session. Sir, please come and have a seat on the dais. I would like to introduce, sir, that he has been civil surgeon and has worked for almost 3 years, right, sir? And for 3 consecutive years, he has been IMA president in 2014 to 2017. He has worked as an orthopedic surgeon since 1988. And he has helped, and during his work duration, he has done a lot of things for the people of Satara and around. We are really honored to have you here as a chairperson, sir. And now I'll switch on I'll hand over this mic to Dr. Reshma Rajbhui, who is a gynecologist, IVF specialist, and she is the treasurer of IMA Women's Wing Satara. To Dr. Reshma Rajbhui, please.
Thank you very much, Rajashri. for a kind introduction. Very good afternoon to one and all present here, respected chairperson, audience, and my dear friends. After an academic bonanza, now we are here for a non-academic topic, that is a cyber parenting. IMA Women's Wing Satara present here today's panel discussion on cyber parenting. I call upon our eminent panelist, iconic Mrs. Achal Dalal, ma'am is expecting in 10 minutes. Phenomenal Mr. Jay Gaikwad sir, who is a cybercrime expert, please come sir. Endearing senior most pediatrician, Dr. Chitra Dabholkar ma'am. Our own IMA Women Wings president, great psychiatrist, great human being, Dr. Rajashri Deshpande ma'am. And lovable, well-known radiologist and Mrs. Asia Pacific Universe, Dr. Rajashri Thoke. I welcome you all. I proudly say here, in last year, IMA Women Wing Satara, under able guidance of Dr. Rajashri Deshpande ma'am, we have conducted many awareness. This page is not going down. Cursor. Many awareness lectures, interactive sessions, and workshop. Cursor is not going down. Okay, thank you. For children and as well as for the parents. And today, I am very glad and delighted also to be on this dais and moderating this session. I take opportunity to thank Dr. Sharad Jagtap sir and whole scientific committee of SATCON 2024 for giving us this dais and opportunity to conduct this panel, which is the most burning topic of today. Crux of today's era of a digital world is a cyber literacy and need of an hour. When I was preparing this panel, my daughter asked, "Mama, what is your topic?" So I told her cyber parenting. She was, "It is your out of syllabus, Mama. How we will prepare?" "Don't worry, I will only provide you material." Because at school, she has received 3 to 4 videos for that. She insisted me, "Mama, you add ADHD and FOMO." I was surprised to hear those words because I was also not knowing the full form of these words. We are going to listen from Chitra ma'am afterwards. One more thing she told me, also include Mama cyber crime, because she told me one incident. Just 3 months back, one of her classmates had a issue about this social media. When she was in a 6th standard, due to just peer pressure, she opened an account on a social media. Then I am stunned to hear the words like hangovers, sleepouts from my daughter's mouth, because she told she got request of hangovers and sleepouts. Also bad messages. The age of the girl is just 11, 12 years. Then that she told to her elder sister, and the problem went to father, mother, and teachers. So really, I'm surprised to see all these problems. So my question is first to Jay sir. What are the most online threats that children face today, and can you explain with some incidences?
Sure, ma'am. Yeah, ma'am. Initially, when we are talking about cyber parenting, it's a initially a jargon word altogether, and in the digital transformation, we have a couple of initial associations in a various social media and all. But if we are talking about cyber crime, we are talking about cyber threats. So first is like cyberbullying is a essentially important factor or a threat, I would say. Second is like game UPI fraud is there. So UPI has a different frauds altogether. If you just check in a society, if UPI and other concern, financial fraud is a priority concern today. Second is game related or gaming related frauds. Those who under 13 or 8 to 13 years of old, they all are inclined towards gaming priorities. So these are the basic threats we are gonna deal in this society. Essentially, as a responsible parent or as a responsible netizen is the right word, I would say. We have to observe the content first. Secondly, we need to understand the parameters or boundaries of our parents and child, because every in a house we have a 3-4 mobiles in house, so we don't know exactly what childs are suffering, what they are initially understanding in the cybercrime scenario. But there are various cybercrime in the area, but cyberbullying is one of them. So in cyberbullying, basically few unused or unused content will be disseminated in the cyber era. And then second is stalking. Stalking is like those who are strangers, they interpret their identity, they impersonate their identity in a different way, they talk in a different manner to the children as per their age, and they exploit them in a criminal intimidation. So this is how the majority of child engage in these 3-4 incidences.
Really awakening start of the session. If we see these problems, we are seeing tip of iceberg, and what we are seeing is not much we are seeing. So as a parent, as a guardian, we should look for the ringing bells surround us. So my next question to Dr. Chitra Dabholkar ma'am: what are the signs or symptoms of a mobile addiction in children, and what impact can excessive mobile use and social media misuse have on child's health and development?
आता मी थोडं मराठीतून बोलायचा प्रयत्न करीन, आणि अर्थात जो शब्द ह्याला योग्य असेल तो इंग्रजीतच राहील, पण त्याचं एक्सप्लेनेशन देईल. मोबाईल ॲडिक्शन हे जन्मापासून सुरू होतंय की काय, अशी आता सध्याच्या काळात भीती आहे. 6 महिन्याच्या आतल्या मुलांना अजिबात मोबाईल किंवा कुठलंही स्क्रीन दाखवू नये, ह्याबाबत म्हणजे नुसतं WHO नाही तर American Academy of Pediatrics, Indian Academy of Pediatrics, and UNICEF, everyone has agreed to that should not be screen. Ideally, WHO and UNICEF has put guidelines, no screen below 2 years. But now the AAP has accepted below 6 months, no screen. From 6 months to 2 years, we can go for some kind of under observation 10 minutes of video calling under supervision. Then above that 2 to 5 years, not more than 1 hour. And after 5 years to adolescent, we take this opportunity to give supervised but less than 7 hours. That I'll discuss later, okay? The thing is, what she has asked is mobile signs and symptoms of mobile addiction in children. So after 6 months to 2 years, this mobile addiction, you know what mothers do? They feed in front of mobile. So children are addicted to mobile and they eat only if they are exposed to some kind of screen. I won't restrict myself to mobile because screen includes everything. TV, laptop, tabs.
Yes, all social media.
All kinds of screens. So all these can have ill effect on babies, right? So up to 2 years, they may get restless, there is sleep disturbances, and if they are exposed to these kind of screens repeatedly, to avoid looking after them, that is the important thing I feel. Then children don't have one-to-one interaction with caregivers or parents, and that interferes with language development, even concentration, and overall brain development. So this is very important to avoid at this age. I mean, 6 months to 2 years. After 2 years, 2 years to 5 years, only 1 hour. Here also we can see 1 hour in 24 hours, right, per day. So if you exceed that, they go for mobile addictions, and then that also, those children get sleep disturbances, those children get become restless, those children also have language problem, even lack of concentration and cognition development. All these things you see. After 5 years, if they are exposed up to adolescent, I should say, after 5 years this happens, these children, if they get addicted to mobile, there are physical, mental, social, all kinds of signs and symptoms, and those are related to health. Physical is they get obesity because of eating, binge eating, junk food eating. Second, again, these children have many sleep disturbances. And these sleep disturbances is because of screen. When they see the screen, especially at night, then they are exposed to that light, which decrease melatonin secretion. And because of that, children don't sleep and they go on watching some kind of whatever they want to watch on screen. And then they sleep late, they get up late, and the circadian rhythm is disturbed. And sleep is very essential. Up to adolescent age group, they should sleep at least 8 to 10 hours at night. So this is very, very important that parents should be vigilant and they should practice that child, there should not be any mobile with child or any screen in the sleeping room. Not even doctor's parents. Then, secondly, after sleep disturbance, what is detected is headaches, eye strain, eye burning and pain in the eyes, then neck pain, that is known as text neck. So they go on doing this, results in shoulder pain and wrist pain. So all these physical disturbances are seen with mobile addictions. Plus, beyond that, they get irritable, they get restless if they are not given screen. They, of course, Dr. Rajeshri will explain this more, but they go in depression. Either depression is the cause or it may result because of mobile addiction. Anxiety, anger, tantrums, many things are related to mobile addiction in children.
Yes, very rightly said, ma'am. Also, attention deficit hyperactivity disorder and FOMO, that is fear of missing out something, is importantly seen in those children. Yeah. One very nice study has been done, and it has shown that out of 5 children, 1 is having mental illness due to the mobile addiction. Yes. So my next question to Dr. Rajeshri Deshpande ma'am, are there any potential coexisting mental health issues that could be associated with excessive mobile or a social media use in children?
Yeah, we have just heard what Chitra ma'am said. मी पण मराठीत सांगू इच्छिते कारण बरेच जण आपले ऐकणारे हे एक्सपिरियन्स करतात डे टू डे ॲक्टिव्हिटीजमध्ये आपल्या मुलांच्या बाबतीतले हे प्रॉब्लेम सगळ्यांपर्यंत ते पोचायला हवं. डिप्रेशन, एन्झायटी ही फक्त एक नावं झाली, म्हणजे एन्झायटी डिसऑर्डर आहे, डिप्रेशनमध्ये जातात. पण हे सगळं होण्यासाठी नेमकं काय घडत असतं, तर मोबाईलला ग्लू होऊन बसतात, म्हणजे चिकटून बसतात मुलं. ती का बसतात, तर त्यांना सतत काहीतरी मोबाईलमध्ये खूप इंटरेस्टिंग दिसत असतं. आणि म्हणजे हे सोशल मीडिया फ्री का असतात, ही सगळी हे प्लॅटफॉर्म्स फ्री का असतात, तर ॲडव्हर्टायझर्स जे आहे ते कस्टमर्स आहेत या सगळ्या कंपन्यांचे, आणि ते मोबाईल कंपन्या किंवा सॉफ्टवेअर डेव्हलपर्स आपलं अटेन्शन त्यांना विकतात. आपलं our attention gets sold to the advertisers, and advertisers do get opportunity to advertise their contents. मग हे करताना जर आपलं अटेन्शन तिथं सतत राहायचं असेल तर वेगवेगळे व्हिज्युअल क्यूज, रंगीबेरंगी चित्र, इमेजेस सगळं मुलांना सतत दिसत राहतं. मुलांना काय, आपल्याला सुद्धा. हे जरी पॅरेंटिंगचा इश्यू चालला तरी खुद्द पॅरेंट्सना सुद्धा हे सगळं समजून घेण्याची खूप गरज आहे. तर आपण एका प्रकारच्या त्या सगळ्या ह्याला अट्रॅक्ट होत राहतो, त्या क्यूजना. आपलं अटेन्शन तिथे सतत चिकटून राहतं आणि मग हळूहळू काय होतं, जे आपल्याला बघायला आवडतं त्याच पद्धतीच्या गोष्टी पुन्हा पुन्हा दाखवल्या जातात. आता हे सगळ्यांना माहिती आहे की आपण जर समजा आता बायकांच्या बाबतीत जर त्यांनी शॉपिंग किंवा साड्यांचं हे बघितलं तर पुन्हा 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 तशाच जाहिराती येत राहतील. किंवा पुरुषांच्या बाबतीत कार्स किंवा हे असं त्यांनी सर्च केलं तर पुन्हा तेच. आपण फिरायला जाणं म्हणून एखादं लोकेशन सर्च केलं तर त्या लोकेशनचे हॉटेलचे ॲडव्हर्टाईज यायला लागतात लगेच. तर म्हणजे आपल्याला जे बघायचंय तेच दाखवलं जातं. आणि ह्या सगळ्यात होतं काय, मुलं व्हर्च्युअल एका त्या जगामध्ये जगायला लागतात. जे त्यांना दिसतंय, बघायचंय तेवढंच दिसतंय, बाकी खरं काय आहे, जगात बाहेर काय आहे ते त्यांना दिसतच नाही. सो दे स्टार्ट लिव्हिंग इन अ व्हर्च्युअल बबल. आणि दिस इज द मोस्ट डिस्ट्रक्टिव्ह थिंग विच इज हॅपनिंग टू देअर मेंटल हेल्थ. कारण आपलं ह्युमन बिईंगचं अस्तित्व आहे की आपण जगाशी जोडतो, बघतो, चॉईस करतो, बरं काय आहे, वाईट काय आहे, आणि मग आपण त्याच्याशी कोपअप करायचं कसं हे शिकत जातो. पण हे सगळं करण्याची संधी आपण त्या व्हर्च्युअल बबलमध्ये राहिल्यामुळं हिरावून घेतली जाते. आणि हे मगाशी मॅडमनी सांगितलं की ब्रेन डेव्हलपमेंटवर परिणाम करतं. लहान मुलांच्या नाही, आपल्यासुद्धा कॉग्निटिव्ह चेंजेस होतात ब्रेनमध्ये. आणि हा सगळ्यात महत्त्वाचा मेंटल प्रॉब्लेम आहे जो मोबाईल ॲडिक्शनमुळे होतोय. आणि मग कॉग्निटिव्ह चेंजेस व्हायला लागले की विचारांची दिशा ही फक्त एकाच दिशेने होतं, त्याला तारतम्य राहत नाही. त्याला म्हणजे आता उदाहरणार्थ खूप हिंसेचं प्रदर्शन जर मुलं बघत असली, गेमिंगमुळे असेल, आपल्या वेब सिरीज आणि याच्यावर असतील, तर त्यांना त्या हिंसेबद्दल एक बधिरता आलेली असते. आणि खरोखरच लागल्यानंतर किंवा दुसऱ्याला मारल्यानंतर आपल्याला काय भावनिक इम्पॅक्ट होतो हे त्यांना कळत नाही. आणि जेव्हा ते कळतं, म्हणजे कालच माझी एक केस सांगते मी की addiction is very common along with mobile addiction, other addictions like alcohol addiction or ganja or white powder or something. आणि ही मुलं हे सगळं करत असतात, त्यांना इझिली ॲक्सेस मिळतो मोबाईलवर, कुठून मागवायचं, कसं घ्यायचं सगळं कळत असतं, ते घेतात. तर तो घ्यायचा दारू प्यायचा आणि तो डिप्रेशनमध्ये होता. त्याला ते काही सर्टन लाईक्स आणि हार्ट्स मिळत, हे एक कॉमन आहे की सोशल कंपॅरिझन, म्हणजे मला एवढे लाईक्स मिळाले, तुला एवढे नाहीत. हा तर ही सोशल जी एक फिअर असते, मगाशी फिअर ऑफ मिसिंग आउट मॅडमनी मेन्शन केलं, रेश्मा मॅडमनी, तर ते काय असतं की हे बाकीच्यांना सगळ्यांना मिळते, मला नाही मिळते, मग ती अँझायटी डेव्हलप होते. सतत मला लाईक्स मिळाले पाहिजेत मला. आणि त्यांना हे माहिती आहे की हे लाईक्स मिळणं, हे हार्ट्स मिळणं हे आपल्या प्रेस्टिजचं लक्षण आहे, पण हे आपल्या कुणी ह्याला उभं राहणार नाही आहे. तर त्या मुलांनी काय केलं की सगळ्यांना कळवलं की मी आता स्वतःला पेटवून घेत आहे, आणि स्वतःला पेटवून घेते तर तुम्ही या. कुणी गेलं नाही, कारण त्यांनी आधी प्रिव्हियसली पण असं खूप 2-3दा झालं होतं, ते लांडका आला रे आल्यासारखं झालं. ह्या मुलांनी स्वतःला त्या दारूच्या नशेत पेटवून घेतलं. तो फक्त 10 ते 15% जळला होता, त्याच्या आधीच तो मेला. आणि ही डाईड बिकॉज ऑफ हार्ट अटॅक. बिकॉज त्या दारूच्या नशेत, त्या मोबाईलच्या, त्या सगळ्या ह्याच्यामध्ये त्याला हे कळतच नव्हतं, तो बधीर होता की आपल्याला पेटवून घेण्यामुळं भाजणार आहे, आपण जळणार आहोत. आणि जेव्हा त्याला ते कळलं की आपण नेमकं काय केलंय, ते चटके बसल्यानंतर नशा उतरली असेल, ते सगळ्या ह्याच्यातनं बाहेर आला असेल, ही रियालिटीची जाणीव आहे. हे फिजिकली घडलं की आत्ताचीच केस आहे 2-3 दिवसापूर्वीची. त्याच्या आईनं माझ्याकडे येऊन मला सांगितलं, हे सगळं मॅडम असं झालं आणि आपण खूप प्रयत्न केला, पण म्हणजे तो यायचाच नाही ट्रीटमेंटला. तो स्वतंत्र झाला होता, कमवायला लागलेला, त्याच्या टर्म्सवर जगत होता. सो ही जे रियालिटीचे चटके आहेत ना, ही तर फिजिकली चटका बसला, पण खऱ्या अर्थाचे जे जगतानाचे चटके आपल्याला बसल्यानंतर आपण ते कोपअप करतो, आपण फेल्युअर्स पचवतो, आपण अपेक्षाभंग पचवतो, आपल्याला नको त्या गोष्टी कशा डील करायच्या शिकतो. ह्या सगळ्यापासूनची डिटॅचमेंट म्हणजे थोडक्यात जगण्यासाठी आवश्यक असलेले सगळे स्किल्स आपण गमावून बसायला लागलो मोबाईल ॲडिक्शनमुळं. आणि हा सगळ्यात महत्त्वाचा परिणाम आहे आणि मेंटल डिसऑर्डर आहे की वी बिकम अ टॉय इन द हँड्स ऑफ द सॉफ्टवेअर कंपनीज.
Okay, thank you, ma'am. Very aptly you delighted us. कारण आपल्याला पण खूप विचार करावासं वाटतंय की पालक म्हणून आपण जे काही डे टू डे मध्ये बघतो तर आपल्याला पण खूप विचार करायची गरज आहे. कारण ज्या गोष्टी आपण करतो फक्त त्याच्यासाठी नाही, तर ज्या गोष्टी आपण करत नाही त्याच्यासाठी सुद्धा आपण तेवढेच जबाबदार आहोत असं मला वाटतं. सो माझा पुढचा प्रश्न आहे डॉक्टर राजश्री ठोके यांना. आर देर एनी स्पेसिफिक रिस्क फॅक्टर्स और वॉर्निंग साइन्स दॅट पेरेंट्स शुड बी अवेअर ऑफ रिगार्डिंग देअर चाइल्ड्स मोबाईल और सोशल मीडिया युसेज?
थँक्यू रेश्मा. मला आज एक डॉक्टरपेक्षा ॲज अ पॅरेंट म्हणून बोलायला जास्त आवडेल. मला 2 मुलं आहेत, मुलगी 11 वर्षांची, मुलगा 7 वर्षांचा. त्यामुळे त्यांचे जे प्रॉब्लेम्स आहेत त्यांचे जे मी आता फेस करते आणि त्या दृष्टीने आपल्याला काय करता येईल हे मी जास्त सांगू इच्छिते. सो जसं चित्रा दाभोळकर मॅडमनी सांगितलंच की साईन्स सिम्पटम्स काय आहेत या मोबाईल ॲडिक्शनचे, पण ॲज अ पॅरेंट म्हणून आपण त्याच्याशी कसं डील करू शकतो. ॲज अ पॅरेंट म्हणून मी जे शिकले किंवा मी जे एक्सपिरियन्स केलं त्यावरून मला असं वाटतं मुलांना आहे ना 3 वेळेला ॲज अ पॅरेंट आपली खूप गरज असते. सकाळी उठल्या उठल्या, जेव्हा ते शाळेतून येतात, इट्स अ लॉंग टाईम की ते आपल्यापासून लांब असतात, तिथून आल्यानंतर आणि रात्री झोपताना. या 3 वेळा आहेत. जर आई आणि वडील या दोघांनी मिळून किंवा दोघांपैकी एकाने तरी कोणी मॅनेज करून, बिकॉज वी ऑल आर डॉक्टर्स, जे ऐकणारे आहेत सगळे डॉक्टर्स आहेत, आय नो दे आर व्हेरी बिझी, पण जर कोणीतरी एकाने या वेळा पाळण्याचा प्रयत्न केला आणि त्यांच्याबरोबर असण्याचा प्रयत्न केला, जेव्हा शाळेतून येतात तेव्हा कदाचित फिजिकली नाही जमलं तर तेव्हा फोन करून कोणाशी बोलून काय त्यांचं म्हणणं आहे काय सगळं हे ऐकून घेण्याचा प्रयत्न केला ना, तर या छोट्या छोट्या त्यांना थोड्या वेळासाठीच आपण हवं असतो, त्यांना एक्सप्रेस करायला. त्यांना असं वाटत असतं कधी एकदा येतो मी घरी, आई बाबा कोणाला तरी बघतो आणि सांगून टाकतो जे काय हवंय ते. ॲक्च्युअली त्यांना लहानपणापासूनच एक्सप्रेस करण्याची सवय असते. ती आपण कुठेतरी ना आपल्याला कदाचित वेळ नाही म्हणून किंवा आपण त्याबद्दल अजाण आहोत म्हणून ती चुकून सप्रेस करतो, मुद्दाम असं नाही. तर यामुळे काय होतं, हळूहळू त्यांना वाटतं की आईबाबांना ऐकायचंच नाहीये, सोडून द्या. आणि याबरोबर आपल्याला वेळ नाही म्हणून एक गोष्ट पुढे येते, ते म्हणजे स्क्रीन इन द फॉर्म ऑफ अ मोबाईल, लॅपटॉप, TV, जे काही असेल ते. आणि मग ते हळूहळू त्या दिशेने वाटचाल करतात आणि आपण म्हणतो त्यांना व्यसन लागलं. आय एम सॉरी टू से, आय एम ऑल्सो वन ऑफ द पॅरेंट, पण मी म्हणते आपण लावलं. सो आपल्याला मुलांना थोडा या इम्पॉर्टंट वेळेला लक्ष का द्यायचं या गोष्टींना आणि त्याची आपण एक सवय का ठेवायची याचं मला इम्पॉर्टन्स मी सांगू इच्छिते. कारण यामुळे काय होतं, आपल्याला त्यांच्या बिहेवियरल चेंजेसमध्ये ज्या गोष्टी होत आहेत त्या पटकन लक्षात येतात. रोज हे एवढं एक्सप्रेस करणारा मुलगा किंवा मुलगी आज अचानक गप्प झाली आहे. रात्री झोपताना, सकाळी उठल्यावरती टेन्स दिसतीये का, काहीतरी मनात काहीतरी आहे का, जे सांगायचंय सांगू शकत नाही आहेत. वी बिंग पॅरेंट्स आपण इझिली कॅच करू शकतो. थोडा वेळ लागतो कदाचित त्यांना ओपन अप व्हायला किंवा काय, पण ही जर एक कन्सिस्टन्सी राहिली तर मात्र आपण आपल्या मुलांच्या म्हणजे सायबर बुलिंग होतंय का, स्कूलमध्ये फक्त मोबाईल रिलेटेडच नाही तर स्कूलमध्ये त्यांना कोणी बुली करतंय का, त्यांना कोणी काही त्रास दिलाय का, या सगळ्या गोष्टींवरती आपण नक्कीच लक्ष ठेवू शकतो. आणि मला असं वाटतं की ॲज अ पॅरेंट एवढी गोष्ट आपण नक्की करू शकतो. थँक्यू.
जरा त्याच्यामध्ये थोडंसं आपण ॲड करूया की मुलांचं हळूहळू अकॅडमिक फेल्युअर होत चाललंय. म्हणजे आधी चांगला असणारा मुलगा इंटरेस्ट त्यातला गमावतोय, अकॅडमिक्समधला, स्पोर्ट्समधला इंटरेस्ट गमावतोय, ते मित्रांशी बोलत नाहीत, ते बाहेर येऊन बसत नाहीत, त्यांचा स्क्रीनवरचा टाइम वाढत चाललाय. हे सगळं आपल्याला दिसायला लागलं ना आणि ते आपल्याशी डिटॅच व्हायला लागले. जसं राजश्रीने आता सांगितलं आणि कुठल्याही गोष्टी म्हणजे जर समजा मोबाईल ठेव म्हणलं तर इरिटेबिलिटी त्यांना व्हायला लागली, चिडचिड करतात, टेम्पर टँट्रम्स थ्रो करतात किंवा मग जर काढूनच घेतला मोबाईल तर त्यांचं लक्षच नसतं. दे आर सो असं सैरभैर झाल्यासारखे होतात मोबाईल त्यांच्या हातातनं काढून घेतला. तर ह्या गोष्टी आहेत की आपल्याला माहीत पाहिजेत की आपल्या मुलांमध्ये दिसायला लागल्या तर ओळखा, देर इज समथिंग रॉंग. आणि या
खरं
अजून एक गोष्ट मला सांगावीशी वाटते की बिंग डॉक्टर्स होतं कधी कधी असं आपल्याला की दोघेही पॅरेंट्स त्या वेळेला कदाचित नाही वेळ देऊ शकत. तर मला असं वाटतं अगदी प्रेमाने शांतपणे त्यांना समजावून सांगा आणि आधीच अपोलोजाईज करा. ते शिकतात की त्यामुळे एक्सप्रेस करायला, जर मला एखादी गोष्ट जमणार नाही आहे काय आहे तर सॉरी म्हणायला. आणि अगदी छानपणे ते हळूहळू तुम्हाला समजून घेतात आणि त्यामुळे ॲज अ पॅरेंट तुमच्या मुलांबरोबरचा बॉन्ड खूप जास्त चांगला होतो.
Thank you both of you, because your answer really stimulated our mind as a parent. Even audience must have felt it, because there should be a mental refining at some point of time which is need of an hour. So there are two aspects basically. One aspect is a psychological aspect, but the other aspect which we really don't know about, the technical aspects of this mobile addiction. So my question is, Jay Gaikwad sir, how can technically parents establish healthy boundaries around mobile and social media use for their children?
थँक्यू मॅम. ॲक्च्युली आपण जेव्हा टेक्निकल पर्स्पेक्टिव्हनी या सगळ्या गोष्टी पाहत असतो त्याच्यामध्ये हल्ली प्रत्येकाकडे अँड्रॉइड iOS डिव्हायसेस आहेत आणि आपल्याला हे माहिती नसतं किंवा बऱ्याचदा माहिती असतं पण आपण त्याचा यूज करत नाही की आपल्याकडे पॅरेंटल कंट्रोल किंवा पॅरेंटल कंट्रोल सेटिंग्स ऑलरेडी तुमच्या इस्टॅब्लिश्ड मोबाईलमध्ये असतात. आपण जेव्हा आपल्या मुलांना, जसं चित्रा मॅम म्हणाल्या की एज स्पेसिफिक तुम्ही तुमच्या मुलांना घडवलं पाहिजे किंवा सांगितलं पाहिजे आणि या बाउंड्रीज सेट करताना अगदी क्लिअर कॉन्व्हर्सेशन, क्लिअर कम्युनिकेशन तुमच्या मुलांबरोबर असलं पाहिजे. त्याच्यामध्ये जसं प्रत्येक सोशल मीडियाचा यूज करत असताना तुम्ही व्हॉट्सअप यूज करताय त्याचं मिनिमम एज जे आहे ते 16 इयर्स आहे. मग तुम्ही स्नॅपचॅट यूज करताय मिनिमम एज 13 इयर्स आहे. अशा प्रत्येक सोशल मीडियाच्या यूजसाठी एज डिफाईन केलेलं आहे. आणि आपण नॉर्मली काय करतो की आई बाबा असतील किंवा घरातले मुलं जेव्हा तुमचे मोबाईल्स वापरतायत, अँड्रॉइड डिव्हायसेस वापरतायत तेव्हा आपण कंटेंट फिल्टरिंग करत नाही. मग टेक्निकल पर्स्पेक्टिव्हने आपल्याला हे लक्षात आलं पाहिजे की कंटेंट फिल्टरिंग काय असतं. कारण बऱ्याचदा मुलं त्यांचे स्वतःचे ईमेल ID ओपन करतात आणि स्वतः त्याचे वापरतात, पण त्याच ह्याच्यामध्ये जर पालकांनी स्वतःच्या ईमेल IDनी मुलांचा मोबाईल जर यूज केला तर तुम्हाला पॅरेंटल कंट्रोलला सोपं पडेल. त्याच्यामध्ये तुम्ही स्पेसिफिकली जे क्राईम्स होतात म्हणजे त्याच्यामध्ये UPI क्राईम असेल, ज्याच्यामध्ये तुमचं क्रेडिट कार्ड क्राईम असेल, ज्याच्यामध्ये मुलं बऱ्याचदा अशी अनुभवलेत, आम्ही बघितलेत की मुलं आईबाबांचे क्रेडिट कार्ड घेतात, नंबर्स डायल करतात आणि पैसे जातात. तर त्या ह्याच्यामध्ये जेव्हा तुम्ही टेक्निकली साऊंड व्हाल, टेक्निकली स्वतःला अपग्रेड कराल, त्याच्यामध्ये मग या क्राईम्सचं प्रमाण कमी होऊन जाईल. मुलांना कंटेंट फिल्टरिंगसाठी तुमच्याकडे एक स्पेस असेल की मुलांनी कुठल्या वेळेमध्ये बघायचं, काय बघायचं, कुठला कंटेंट त्यांना स्पेसिफिकली दिसला पाहिजे. मग यूट्यूबवर असेल, तुमच्या जीमेलवर असेल, तुमच्या ॲप्लिकेशन स्पेसिफिक कंटेंट असेल, हे सगळं करत असताना हा टेक्निकल पर्स्पेक्टिव्ह. सेकंड इज लाईक की आपण जेव्हा घरामध्ये सोशल मीडिया वापरतोय तेव्हा राजेश्री मॅम म्हणाल्याप्रमाणे की आपल्याला हे सेट करता आलं पाहिजे, आपल्याला रेड फ्लॅग्स ओळखता आले पाहिजेत की मुलांचं बिहेवियर चेंज होतं आहे. मग बिहेवियर चेंज कशामुळे होतं आहे? मग सायबर बुलिंगमुळे होतं आहे का? किंवा अशा काही गोष्टी आहेत की पूर्वी मुलं स्कूलमधून घरी आल्यानंतर आईबाबांशी बोलायची, आईबाबांना सांगायची की भांडण झालं किंवा स्कूलमध्ये हा हे म्हणाला, हा मित्र हे म्हणाला, पण आत्ता तसं होत नाही. तुम्ही बऱ्याचदा बघितलं असेल की मुलं जेवताना सुद्धा मोबाईल पाहतात, ते काय जेवतात हे त्यांना कळतच नाही, फक्त मोबाईल चालू असतो आणि त्यामुळे ज्या फिलिंग्स आहेत, त्यामुळे ज्या मोबाईलचे इन्सिडेंट्स आहेत ते ॲटोमॅटिकली त्यांच्या मनामध्ये जात असतात. हे सगळं होत असताना बिईंग अ टेक्निकल गाय और बिईंग अ पर्सन, मला असं वाटतं की आपण या सगळ्या रेड फ्लॅग्स ओळखता आले पाहिजे, मुलांशी गप्पा मारता आल्या पाहिजेत, मुलांशी बोलता आले पाहिजेत. आणि हे सगळं करत असताना जेव्हा आपण आपल्या घरामध्ये मुलांना मोबाईल देतोय तेव्हा मोबाईल वापरायचा कसा हे पण त्यांना शिकवलं पाहिजे. म्हणजे याच्यामध्ये तुम्ही बऱ्याचदा बघितलं असेल की नोटिफिकेशन्स ऑन असतात मुलांचे आणि तुम्ही मोबाईल ठेवलाय पण बऱ्याचदा तुम्ही कॉन्व्हर्सेशन करत असताना, बोलत असताना, अभ्यास करत असताना मुलांचं नोटिफिकेशनकडे लक्ष असतं की अरे व्हॉट्सअपचं नोटिफिकेशन आलेलं नाहीये, अजून आलेलं नाहीये, मोबाईल व्हायब्रेट तर होतोय का, नोटिफिकेशन तर आलेलं नाहीये, हे इनडायरेक्टली सबकॉन्शियस माइंडमध्ये चालू असतं. मग ह्या सगळ्या गोष्टी जेव्हा पेरेंट्स म्हणून तुम्ही अनुभवता तेव्हा तुम्ही हे सेट करायला पाहिजे की नोटिफिकेशन फ्लॅग कधी ऑन ठेवायचे, कधी ऑफ ठेवायचे, डू नॉट डिस्टर्बचा फ्लॅग जो आहे तो कधी ऑन ठेवायचा, हे तुम्ही मुलांशी बोललं पाहिजे, सांगितलं पाहिजे. आणि मला असं वाटतं की ही सगळी रिस्पॉन्सिबिलिटी आपली आहे. बिईंग अ पॅरेंट ही आपली रिस्पॉन्सिबिलिटी आहे. आपण पूर्वी जसं आपल्या मुलांना एज्युकेट करत होतो की नाही तू इकडे जायचं नाही, तू तिकडे जायचं नाही, किंवा तू या मित्राकडे जायचं नाही, तू घर सोडून जाताना मला सांगायचं. पण आत्ता आपण हे विसरलोय. आपण डिजिटल यूजसाठी आपण पालक सांगतच नाही की तू काय बघायचं आणि काय बघायचं नाही. आपण पालकांनी जर मुलांना हे सांगितलं की तू काय काय बघायला पाहिजेस, मग तुझा सोशल मीडियाचा कंटेंट कसा असायला पाहिजे, तुझ्या लाईक्स कुठल्या आहेत, तुला काय आवडतं ते तू कसं बघितलं पाहिजे. बऱ्याचदा असं होतं की तुम्ही सर्च करत असताना जेव्हा तुम्ही एखादी ॲडव्हर्टाइजमेंट पाहता आणि आत्ता सध्या जसं मॅडम पण मगाशी म्हणाल्या की कंपनीज खूप स्मार्ट झाल्यात, त्या तुमचं सेंटिमेंट ॲनालिसिस करतात. म्हणजे सपोज तुम्ही तुमचा शूजबद्दल किंवा तुम्ही तुमच्या एखाद्या इव्हेंटबद्दल माहिती घेत असाल, तुमच्या एखाद्या इव्हेंटबद्दल माहिती घेत असाल तर तुम्हाला ॲटोमॅटिकली त्याच पद्धतीच्या जाहिराती यायला लागतात, त्याच पद्धतीची तुम्हाला माहिती यायला लागते. आणि मुलांना या सगळ्या याच्यामध्ये मुलांना असं लक्षात येतं की जर ही जाहिरात मला येते, मला टॉयची जाहिरात येते, तर कंटिन्युअस मुलांच्या सेंटिमेंट्सवर त्याचाच मारा केला जातो आणि हे इंटेन्शनली केलं जातं. म्हणजे तुम्ही बऱ्याचदा बघा की तुमचा म्हणजे मी बऱ्याचदा पेरेंट्सला आणि पालकांना सांगतो की तुमचा जो मायक्रोफोन आहे हा 24/7 चालू असतो फोनमध्ये. त्यामुळे जेव्हा तुम्ही पालक म्हणून डिस्कशन करत असता तेव्हा ज्या थर्ड पार्टी ॲप्लिकेशन्स आहेत त्या थर्ड पार्टी ॲप्लिकेशन्समध्ये इनडायरेक्टली या सगळ्या गोष्टी इनिशिएट होतात, ऐकल्या जातात, मायन्यूट लेवलवर त्याचं ॲनालिटिक्स होतं आणि सेकंड हाफ पासून तुम्हाला सेम पद्धतीच्या जाहिराती बघायला मिळतात, सेम पद्धतीचं तुम्हाला कंटेंट बघायला मिळतो. हे का मिळतं? कारण आपला मोबाईलचा, आपल्या मीडियाचा एवढा यूज केला जातो, आपल्या व्हॉइसचा यूज केला जातो, आपल्या कंटेंटचा यूज केला जातो, आपल्या फोटोचा यूज केला जातो, आपण ज्या परमिशन्स देतो त्या परमिशनचा यूज केला जातो. त्यामुळे मला असं वाटतं की जेव्हा तुम्ही मुलांना जेव्हा तुम्ही सांगताय तेव्हा परमिशन्स कुठल्या आहेत. म्हणजे एखादं ॲप्लिकेशन असेल, यूट्यूब असेल तर यूट्यूबला मायक्रोफोनची परमिशन द्यावी लागते, तुम्हाला फाईलची स्टोरेजची परमिशन द्यावी लागते, तुम्हाला कॅमेराची परमिशन द्यावी लागते. पण यूट्यूबला तुमच्या कंटेंट किंवा तुमच्या कॉन्टॅक्टची परमिशनची गरज नाही, कारण यूट्यूब हा कंटेंट फिल्टर करत नाही, यूट्यूब हा कंटेंट कॅच करतो. मग तुम्ही जेव्हा सर्च करता तेव्हा त्याच पद्धतीच्या जाहिरात लागतात. पण जर तुम्ही ते सर्च करत असताना जर त्याच्यामध्ये सेफ मोड ऑन केला, मुलांसाठी स्पेसिफिकली सेफ मोड असतो, तो जर सेफ मोड ऑन केला तर मुलांना एक स्पेसिफिक एजच्या पुढे कंटेंट दिसणार नाही. दिस इज हाऊ द टेक्नॉलॉजी. आणि या सगळ्या टेक्नॉलॉजीच्यामध्ये बऱ्याचदा पालकांना ते माहीत नसतं आणि पालकांना माहीत नसल्यामुळे पालक स्वतःच बऱ्याचदा 2 मोबाईल वापरतात. एकाचा पासवर्ड वेगळा असतो, दुसऱ्याचा पासवर्ड वेगळा असतो आणि मुलांकडे जेव्हा जातात तेव्हा मुलं पण सेम करतात. मुलं स्वतःचा पासवर्ड आईबाबांना सांगत नाहीत. मग या सगळ्या ह्याच्यामध्ये जेव्हा आपण मुलांबरोबर बसतोय, बोलतोय, त्यावेळी मला असं वाटतं की एका फॅमिलीसाठी एकच पासवर्ड असायला हवा. म्हणजे तो पासवर्ड बाबांच्या मोबाईलमध्ये पण सेम, आईच्या मोबाईलमध्ये पण सेम आणि मुलांच्या मोबाईलमध्ये पण सेम. त्याच्यामुळे एक ट्रान्सपरन्सी वाढेल. इनडायरेक्टली मुलांच्या लक्षात येईल की आपल्या मोबाईलचा पासवर्ड बाबाकडे आहे, आईकडे आहे आणि ते कधी पण चेक करू शकतात. त्यामुळे तो जो एक ट्रस्ट आहे तो ॲटोमॅटिकली तयार होऊन जाईल. आणि या सगळ्या ह्याच्यामध्ये पेरेंटिंग, डिजिटल पेरेंटिंग याच्यामध्ये पालकांनी बेसिकली मुलांना आउटडोर गेमसाठी एनकरेज केलं पाहिजे. या सगळ्या गोष्टी थोड्याशा इनिशियल याच्यामध्ये येतात.
Yes, very nicely told about it, because every idea and knowledge you shared will definitely help our audience and as a parent to me also to achieve the real cyber literacy. So basically, to control undue usage of our right, we have laws. Why we are having laws? Because we have to control undue usage of our rights, and to enjoy rights one should be responsible for their acts. So my next question To Jay sir, what legal actions can be taken if a child becomes a victim of cyberbullying or online harassment, and how can law enforcement assist in these cases?
बेसिकली जेव्हा एखादी हॅरॅशमेंट किंवा कुठल्याही सायबर क्राईम रिलेटेड केसेस असतात त्याच्यामध्ये फर्स्ट प्रायोरिटी असते की ज्या प्लॅटफॉर्मवर ती केस झालेली आहे, यूट्यूब असेल, व्हॉट्सअप असेल किंवा कुठलाही सोशल मीडियाचा, तर त्यांच्या ॲडमिनिस्ट्रेटिव्ह विंगला तुम्हाला ती पहिल्यांदा फाईल कंप्लेंट करावी लागते. त्याच्यानंतर आपल्या याच्यामध्ये आपली जी ज्युडिशरी आहे, आपलं जे पोलिसिंग डिपार्टमेंट आहे, त्या डिपार्टमेंटमध्ये सायबर सेल एक स्वतंत्र डिपार्टमेंट आहे की ज्या डिपार्टमेंटला तुम्ही ऑनलाईन कंप्लेंटसुद्धा फाईल करू शकता, प्लस ऑफलाईन कंप्लेंटसुद्धा तुम्ही डायरेक्टली फाईल करू शकता. हे करत असताना बऱ्याचदा असं होतं की ज्या कंप्लेंट्स फाईल होतात तर मुलांना अनइंटेन्शनली क्राईममध्ये मुलं जातात. म्हणजे सायबर क्राईम घडला म्हणजे इंटेन्शनली घडत नाही, अनइंटेन्शनली मुलं सायबर क्राईममध्ये ओढली जातात. आणि जेव्हा एखादा सायबर क्राईम घडला जातो त्यावेळी IPCमध्ये ज्या लॉजच्या अंडर सायबर क्राईम बुक होतो त्याच्यामध्ये IT ॲक्ट एक आहे की IT ॲक्टमध्ये आपण जास्त पनिशमेंट्स असल्यामुळे ज्या डिजिटल क्राईम्स होतात किंवा डिजिटल लेवलवर क्राईम होतो तो IT ॲक्टमध्ये बुक केला जातो. IT ॲक्ट प्लस IPC अशा दोन्ही कॉम्बिनेशनच्या ह्याच्यामध्ये तो जो ॲक्ट आहे किंवा ती जी पनिशमेंट आहे, तो जो क्राईम आहे तो बुक केला जातो. आणि दुसऱ्या याच्यामध्ये असं आहे की पहिल्यांदा पाहिलं जातं की मुलगा कुठल्या क्राईममध्ये इन्व्हॉल्व आहे, कसा इन्व्हॉल्व आहे, आणि त्याचे सगळे पॅरामीटर्स डिजिटल फुटप्रिंट्स हे शोधल्या जातात. त्याच्यासाठी सायबर सेल आहे, त्याच्यासाठी फॉरेन्सिक डिपार्टमेंट आहे. ह्या सगळ्या डिजिटल फुटप्रिंट्स शोधल्यानंतर आपण मग त्या डिजिटल फुटप्रिंट जे आहे त्या एव्हिडन्समध्ये कन्वर्ट करतो आणि मग मुलांपर्यंत किंवा मग त्या लीगल प्रोसिजरमध्ये जातात. पण लीगल प्रोसिजरमध्ये तसं जर बघायला गेलं तर लीगल ॲक्शन्स खूप स्ट्रिक्ट आहेत, खूप स्ट्रिंजंट आहेत. लहान मुलांसाठी जसं पोस्को आहे त्याच पद्धतीचं IT ॲक्टमध्ये सुद्धा लीगल प्रोसिजर प्रचंड स्ट्रिंजंट असल्यामुळं मुलं एकदा या प्रोसेसमध्ये अडकली किंवा एकदा सायबर क्राईममध्ये अडकली की त्याच्यातून बाहेर येणं, त्यांचं डिमोटिवेशन होणं, त्यांचं सेल्फ इस्टीम कमी होणं, ह्या सगळ्या गोष्टी होत राहतात. त्यामुळं मला असं वाटतं की हा थोडासा एक लॉ एन्फोर्समेंट एजन्सीच्या अनुषंगाने बोलण्यापेक्षा मला असं वाटतं की सायबर पेरेंटिंग किंवा डिजिटल रिस्पॉन्सिबिलिटी कशी घेतली पाहिजे याच्यावर बोलणं जास्त उपयोगी राहील इथे.
मला असं थोडंसं बोलावं असं वाटतंय रेश्मा की डिजिटल फुटप्रिंट म्हणजे काय हे मुलांना फार म्हणजे आधी पेरेंट्सना माहिती पाहिजे, डॉक्टर्सना माहिती पाहिजे आणि म्हणजे हेल्थ प्रोफेशनल, मी डॉक्टर्स म्हणत नाही, ऑल हेल्थ प्रोफेशनल्स, टीचर्सना माहिती पाहिजे. आणि मुलाच्या हातात मोबाईल देण्यापूर्वी त्याला ह्या विषयीची जागरूकता आणलीच पाहिजे. सो अवेअरनेस रिगार्डिंग डिजिटल फुटप्रिंट इज व्हेरी इम्पॉर्टंट.
Yes, rightly said, ma'am. Sir and ma'am, your inputs brought light to many aspects about the cyber literacy and really reawakening our thoughts. So my next question to Dr. Chitra ma'am, what are the recommended guidelines for mobile and gadgets uses, and what role do schools and educators play in teaching children about online safety, and how can parents support these efforts?
Yes. Before allowing children to use social media platform or a video game, you should get familiarized. You means educators, teachers, and health professionals, as well as parents. All of us who look after children should get familiarized with it, analyze whether it is appropriate for age, educate children about rules of online safety, as we just talked about, what is digital footprint, what not to be posted in any circumstances. During online schooling, maintain decorum of class. It should not be taken lightly. Wear proper attire and follow instruction of class teachers. Teach students about judicious use of internet. That is very important. Make children aware of malpractice. Explain what are cyberbullying, sex texting, online sexual solicitation, and all these are cyber crimes. So they should be, actually we should be aware, and we should teach children, and as early as I think 5th grade. So now like sex education, this cyber education should come, yes, in hand in hand.
Yes.
Make sure all students know how to recognize and report any suspicious and inappropriate behavior. That is also very important. Schools can initiate the process of improving knowledge about tech addiction, problems with increasing screen time by educating the children and empowering parents about these facts. And they can conduct internet addiction preventing programs integrated with other skill-based programs. That's what I feel for this.
Nicely answered, ma'am, because we have to rethink about what we are doing. So my next question to Dr. Rajashri Deshpande, ma'am, how can parents encourage open communication with their children about their online experiences while maintaining a safe and supporting environment? Because we are lagging in the communication basically due to time.
Very true.
Or any other thing.
Very true. You rightly said, Reshma, that we are lagging in the communication. खरं तर हा जो मोबाईलचा वेळ आहे ना, हा ह्यानी बऱ्याच गोष्टी खाऊन टाकल्यात. त्यात सगळ्यात महत्वाची गोष्ट खाऊन टाकली ते आपलं एकमेकांमधलं बोलणं आणि आपलं स्वतःशी बोलणं, स्वतःशी असलेलं आपलं रिलेशन. या दोन्ही गोष्टींमुळे झालंय काय की आपल्याला काहीच म्हणजे काही करायला नाही तर आपण डोकं नाही चालवत, मुलं डोकं नाही चालवत. आपल्या लहानपणी आपल्याला काहीच नव्हतं, आपल्याला काही करायला नसलं, कंटाळा आला, आईला विचारलं काय करू, कंटाळा आलाय, आई म्हणायची तुझं तू बघ. आपण कितीतरी नवीन नवीन खेळ शोधून काढायचो, उपद्व्याप करायचो आणि दॅट वॉज फन. पण त्यामुळे दॅट इज व्हेरी नॅचरली बूस्टिंग आवर इमॅजिनेशन आवर थिंकिंग. आणि हे सगळं आता काय, कंटाळा आला मोबाईल हातात, कंटाळा आला स्क्रीन हातात. मग ह्या गोष्टी जर आतापासूनच पालकांनी, मुलं लहान आहेत तेव्हापासूनच जर त्यांना सांगितलं की तुमचं डोकं चालणार नाही बरं का, हे जर असंच करत राहिलो तर तुमचं इंटेलिजन्स हे वाया जाईल. नॉलेज इज नॉट द थिंग, इन्फॉर्मेशन इज नॉट द थिंग, बट थिंकिंग इज इम्पॉर्टंट. तुम्हाला गुगल काय देईल, नॉलेज देईल, इन्फॉर्मेशन देईल. ती डीप फेकच्या युगात आहोत आपण. ती इन्फॉर्मेशन खरी आहे की नाही, खोटी आहे हे सुद्धा आपल्याला माहीत नसणार आहे. ते सुद्धा आपल्याला विचार करायला शिकलो तर कळणार आहे. सो आपल्याला जर आपलं मानवी अस्तित्व पणाला लावायचं असेल, टिकवून ठेवायचं असेल तर पहिल्यांदा आपल्याला स्वतःला विचार करायला शिकलं पाहिजे आणि ते आपल्याला मुलांना सांगितलं पाहिजे. म्हणजे हे ओपन कम्युनिकेशन आहे ना, हे सगळ्याच बाबतीत गरजेचं आहे. दुसरी गोष्ट म्हणजे कितीतरी पालक सांगतात की आम्ही सांगतोय मुलांना, मुलं ऐकतच नाहीत, मुलं सोडतच नाहीत, मुलं टेम्पर टँट्रम्स थ्रो करतात. आता हे कुठल्या वयातल्या मुलांना कसं सांगायचं हा विषय. अगदी लहानपणापासून जर तुम्ही सांगत असलात की जसं जय म्हटला की तुम्ही रिस्पॉन्सिबल नेटिझन कसं होणार आहे, मॅडम म्हणल्या डिजिटल फुटप्रिंट्स म्हणजे काय, कसं वॉर्निंग्स कुठल्या म्हणजे तुम्ही गोष्टी पाळल्या पाहिजेत, हे सगळं आधीपासून सांगत आलो तर ती एक पहिली मोठी गोष्ट आहे की आपण त्यांना सेफ एन्व्हायरमेंटसाठी ट्रेन करतोय. दुसरी गोष्ट म्हणजे त्यांना आपल्याला की ह्याचे परिणाम काय होतात हे आपण सतत त्यांच्याशी बोलत राहिलो. आणि कुठल्याही गोष्टीत आपण त्यांना म्हणू शकत नाही की तुझे सगळे मित्र मोबाईल वापरतायत पण तू वापरायचा नाहीस. आपण त्यांना हे म्हणू शकू तू कसा वापरायचा आहेस, स्मार्टफोनचा स्मार्ट वापर कसा करायचा हे आपल्याला मुलांना शिकवायचं आहे. पूर्ण त्यांना तोडून नाही टाकू शकत आपण मोबाईल किंवा गॅजेट्स पासून. ही तिसरी गोष्ट. आणि पुढची सगळ्यात महत्वाची गोष्ट म्हणजे त्यांना हे सांगायला पाहिजे आणि सतत की तुम्ही एक्सप्लोर करणार आहात जग. आम्हाला माहितीये की तुम्ही आम्हाला न कळू देता अनेक गोष्टी एक्सप्लोर करणार आहे, पण त्यामध्ये रिस्क असू शकते. आणि इफ एनी रिस्क कम्स वी आर नॉट गोइंग टू जज यू फर्स्ट, वी आर गोइंग टू प्रोटेक्ट यू फर्स्ट. वी आर देअर टू प्रोटेक्ट यू, वी आर देअर टू बी विथ यू. कदाचित असं येईल की आमच्याही हातून सुटून गेलेलं असेल बाण, पण ऍटलिस्ट त्या सफरिंगमध्ये आम्ही तुमच्या बरोबर असणार आहे. सो कम टू अस. पहिल्यांदा हे लक्षात घ्या की चुका होणार. मुलांना आपल्याला हे सांगायचंय, चुकू नका असं नाही सांगता येत आपण आपल्याला त्यांना, कारण चुकतात सगळेजण. चुका होणार आहेत पण त्या चुकांमध्ये आम्ही तुमच्या बरोबर आहोत. आपण मिळून त्या दुरुस्त करू, आपण मिळून त्यातून मार्ग काढू. आणि ती सगळ्यात शेवटची गोष्ट म्हणजे लर्न टू निगोशिएट. मुलं म्हणणार मम्मा 1 तास दे ना मोबाईल, आपण म्हणू नाही अर्धा तास. मग ते म्हणणार नाही अर्धा तास खूप कमी. मग आपण म्हणू बर ठीक आहे तू सांग मग 1 तास नाही अर्धा तास नाही. ते शिकतील 45 मिनिटं म्हणतील 40 मिनिटं म्हणतील. दुसरी गोष्ट मी तुला थोडंसं वाढवून देते टाइम, पण जर तू त्याच्या पुढं अजून 5 मिनिटं प्लीज असं म्हणलास तर दुसऱ्या दिवशीची 5 मिनिटं कमी होतील. हे मी एक्झाम्पल सांगते, प्रत्येकाला नवीन नवीन गोष्टी सुचत जातील त्याच्या बाबतीतल्या. पण मग आणि सेट द रूल्स ऑफ द निगोशिएशन्स, की एकदा ठरलं तर ऐकायचं. जर तू ऐकलं नाहीस तर मग हा मोबाईल नाही देणार. आज तू ऐकलं नाहीस तर तुला आठवडाभर मोबाईल नाही मिळणार. ह्या अशा गोष्टींनी आपण मुलांना हे शिकवतो की आपलं जे बिहेवियर आहे ते आपली डिसिजन आहे, आणि ते जर आपण नीट आपलं डिसिजन आपण नीट घेतलं नाही आणि दिलेले रूल नीट पाळले नाही तर त्याचा आपल्याला पनिशमेंट मिळणार आहे. यानं त्या पनिशमेंट म्हणजे काही फटके नाहीत, कोंडून घालणं नाही. पनिशमेंट म्हणजे रिवॉर्ड काढून घेणं. मग त्यांचं रिवॉर्ड काय आहे? मोबाईल यूज, तो काढून घेणं. तर अशा प्रकारच्या अनेक गोष्टी आहेत. इट्स अ लॉंग, खरं तर खूप मोठा सब्जेक्ट आहे आणि त्यामुळे मी थांबते. पण हे बेसिक रूल्स आहेत आपल्याला मुलांना त्या पद्धतीनं जबाबदार बनवण्याचे.
खरंय खरंय मॅडम.
त्याच्यात एकच महत्वाचं आहे की पेरेंट्सने स्वतःला काही नियम घालून घेतले पाहिजेत आणि मुलांना कळलं पाहिजे की हे आई वडील पण, जर आई वडीलच बघत बसले आहेत आणि सांगतात मुलांना मोबाईल नको तर ते ऐकणार नाहीत. मग आम्ही डॉक्टर्स आहोत आम्हाला पाहिजे असं म्हटलं तरी ते योग्य नाही होणार. त्याच्यामुळे असा काही वेळ पाहिजे की जेवायच्या वेळी किंवा झोपायच्या आधी 1 तास कोणीच मोबाईल हातात घ्यायचा नाही. आणि जसं नोटिफिकेशनच्या वेळी आपण जागरूक राहिलं पाहिजे तसंच मोबाईल कशा प्रकारे वापरायचा याविषयी आपण उदाहरण घालून दिलं पाहिजे. आणि हे सर्वात महत्वाचं.
Yes, very rightly said, ma'am. As we are running short of time, communication promotes a sustainable and harmonious coexistence between humanity and technology, ensuring brighter and more balanced future. I am having only 2 questions and then take home message. Just I'll take 5 minutes more. My question to Rajashri: what role can parents play in supporting their child's mental health, and basically how parents should help to engage them in some activities? Just in 2 minutes, Rajashri, please.
येस रेश्मा, ॲक्च्युली हा जो प्रश्न विचारला आहे तो खूप मोठा आहे. आपल्या मेडिसिन सारखं नाही आहे, फीवर म्हणजे आपल्या मेडिकल फील्ड सारखंच आहे. फीवर आला पॅरासिटामॉल दिलं, पण प्रत्येक एज ग्रुप वाईज त्याचा डोसेज वेगळा आहे. सो आय वुड से हा खूप मोठा टॉपिक आहे आणि प्रत्येक एज ग्रुपमधल्या पॅरेंट्सना या गोष्टीशी एका वेगळ्या पद्धतीने डील करायला हवं. जसं चित्रा दाभोळकर मॅडमनी सांगितलं, 2 वर्षापर्यंतच्या मुलांना एक्सपोज करायचंच नाही स्क्रीनला. पालकांना त्यांना खूप साऱ्या पोएम्स ऐकवायच्या म्हणजे दाखवायच्या असतात. ॲक्च्युली मला म्हणायच्या त्या ऐकवायच्या असतात, पण ते दाखवतात. त्यांच्या ऐकूनसुद्धा पाठ होणारच आहेत. सो देर इज नो नीड टू एक्सपोज देम टू द स्क्रीन. त्यांना त्या ऐकवा. त्यापेक्षा रेडिओ आहे, बऱ्याच गोष्टी आहेत. ज्यांचे टीनच्या आतली म्हणजे 12 वर्षापर्यंतची मुलं आहेत त्यांच्यासाठी मी म्हणेन थोडंसं सोपं आहे. त्यांच्यावरती कंट्रोल ठेवणं जर असं सोपं पडणार आहे, कारण आत्ताच राजश्री देशपांडे मॅडमनी जसं सांगितलं त्यांच्याशी नेगोशिएट आपण करू शकतो. त्यांना आपण प्रत्येक गोष्टीमध्ये त्यांना रिवॉर्ड्स देऊ शकतो किंवा ते काढूनही घेऊ शकतो आणि त्यांना अवेअर करू शकतो की मोबाईलचा यूज आपण कितपत करायचा आणि कितपत नाही करायचा. माझं स्वतःचं आयडियल मत विचाराल तर मला वाटतं की जोपर्यंत मुलं सोशली रिस्पॉन्सिबल होत नाहीत तोपर्यंत स्मार्टफोन देऊ नये. स्मार्टफोन इज अ स्मार्टफोन अँड टू बी हँडल्ड व्हेरी स्मार्टली. त्यामुळे मुलं तेवढी स्मार्ट व्हायला हवीत. आय डू अंडरस्टँड आजकाल काही सिक्युरिटी पर्पजमुळे किंवा काही गोष्टींमुळे आपल्याला त्यांच्याशी सतत कम्युनिकेशनमध्ये राहणं गरजेचं असतं, पण त्यासाठी सुद्धा आपल्याकडे ऑप्शन्स आहेत. जसे नॉन स्मार्टफोन जे आपण अगदी म्हणजे आपण कॉलेजमध्ये असताना वापरायचो साधे फोन, ते आपण त्यांना देऊ शकतो त्यांच्याशी कम्युनिकेट करायला. आणि अबाउट टीन इयर्स इज अ बिग टॉपिक. माझी मुलं सध्या टीनमध्ये नाही पोहोचली आहेत, त्यामुळे कदाचित आय एम नॉट द राईट पर्सन टू टॉक. पण जेवढं मी सगळ्यांचं ऐकतीये, विचार करतीये, सगळ्यांचा एकच इश्यू आहे की मुलांना लांब कसं ठेवायचं या स्क्रीनपासून. कारण इथे कुठेच असं नाही आहे की जिथे इंटरनेट मिळत नाही आणि त्यांना मोबाईल दाखवता येणार नाही. तर आय मे बी रॉंग, आय डोंट नो काय असेल माझं सजेशन. आज मी हे तुम्हाला सांगतेय ते मी जे एक्सपिरियन्स केलं आहे ते मोबाईलपासून लांब राहायला आहे ना, एक गोष्ट आहे ॲक्च्युली, यू कॅन गो फॉर द ट्रेक्स. यू कॅन गो फॉर द ट्रेक्स इन हिमालयाज. माझे स्वतः 2 ट्रेक झालेत. मुलांबरोबर आम्ही एव्हरेस्ट बेस कॅम्प ट्रेक केला या लहान छोट्यांबरोबर. तिथे अजिबात रेंज नसते. तिथे तुम्हाला कोणी विचारत नाही, मोबाईल तुम्ही हातात घेऊ शकत नाही. तर या टीनेजर्स नाही ना, हळूहळू छोट्या ट्रेक्सपासून मोठ्या ट्रेक्सपर्यंत न्या आणि या स्क्रीनपासून आणि मोबाईलपासून त्यांना लांब राहायला शिकवा. त्यांना दाखवा या स्क्रीनपासून पण एक वेगळं जग आहे आणि ते तुम्ही शिकवा. सायबर पॅरेंटिंग हा आपला टॉपिक आहे. पण आपण मॅक्झिमम मुलांबद्दल बोललोय, तर प्लीज पॅरेंट्सनी आधी स्वतःचं आत्मपरीक्षण करा.
There is a lot to speak about this. My last question of this panel and then only take home message. So my last question to Jay sir, can you provide tips for children about teaching online safety?
आय वुड मला बेसिकली हे सांगायला आवडेल की प्रत्येक पालकांनी पॅरेंटल कंट्रोल यूज करा आपल्या मोबाईल्समध्ये आणि जे खूप इम्पॉर्टंट आहेत मुलांना त्याची सवय लागेल. आणि सगळ्यात म्हणजे कंटेंट वेलबिईंग, इट्स अ न्यू टर्म बेसिकली की ज्याच्यामध्ये बऱ्याचदा मुलं जस्ट सर्व करत असतात किंवा कंटेंट स्क्रोल करत असतात. तर असं मुलांना फक्त कंटेंट स्क्रोल करायला न लावता मुलांना आयडियली पर्पजफुली काय पाहायचं काय नाही पाहायचं हे मुलांना नक्की शिकवा.
Thank you, sir. Unfortunately, we have to work with the time. My last question to all panelists, a single liner answer like an exam. How can we work together to create a safer online environment for children, and what role can the community play in supporting these efforts? First, Rajeshri, please.
मी ही गोष्ट माझ्या टाइम लिमिट असल्यामुळे नाही बोलू शकले. बट मोस्ट इम्पॉर्टंट थिंग इज मुलांना फेलियर्स पचवायला शिकवा. जर ते शिकले फेलियर्स पचवायला तर फोमो आणि बऱ्याच गोष्टींपासून ते लांब राहतील.
ग्रेट वन. राजश्री मॅम.
मुलांना हे सांगा की प्रत्येक बिहेवियरचे कॉन्सिक्वेन्सेस आहेत, परिणाम आहेत आणि त्याची प्राईस आपल्याला चुकवावी लागते, व्हॉट मे कम. त्यामुळं आपलं बिहेवियर रिस्पॉन्सिबल ठेवणं ही आपली जबाबदारी आहे. बाकी मग रिस्पॉन्सिबिलिटी कशी घ्यायची ते शिकवता येईल. आणि सेफ एन्व्हायरमेंटसाठी मुलांसाठी अशा जागा क्रिएट करा की जिथं मुलं एकत्र येतील आणि मोबाईल सोडून खूप मज्जा करतील.
चित्रा मॅम.
मला वाटतं सगळ्यांनी म्हणजे एज्युकेटर्स, टीचर्स, पेरेंट्स अँड हेल्थ प्रोफेशनल्स सगळ्यांनी एकत्र येऊन ह्याविषयी अतिशय सखोल विचार करून मुलांसाठी ही स्पेस निर्माण केली पाहिजे. आणि काय म्हणतो आपण मोबाईल फ्री किंवा स्क्रीन फ्री अशी मजा करायला त्यांना शिकवली पाहिजे.
जय सर.
मला वाटतं की या पर्स्पेक्टिव्हनी पालकांनी मुलांना क्राईम रिलेटेड ज्या गोष्टी असतात किंवा ज्या पेपर्समध्ये येतात त्याच्याबद्दल सांगितलं पाहिजे. सायबर क्राईम कसा होतो किंवा काय झाल्यानंतर त्याचे कॉन्सिक्वेन्सेस काय आहेत पोलिसिंग पर्स्पेक्टिव्हनी ते जर मुलांना सांगितलं तर त्याचा जास्त चांगला इफेक्ट होऊ शकतो या सगळ्या इनिशियल डिस्कशन सुरू करण्याआधी. थँक्यू.
Thank you very much for taking time to be here despite of tight schedule.
अत्यंत सखोल हाताळल्याबद्दल मी सूत्रसंचालकांचं पहिले अभिनंदन करतो.
आभार
सर्व
आहे, सर.
पॅनलिस्टचाही आभार मानतो. अजून ही चर्चा अशीच घडावी कारण मोबाईल एकदा हातात घेतला की ते संपू नये असं वाटतं. तशी जी चर्चा आहे पण ह्याला आपण एक पार्ट 2 नंतर ठेवण्यासारखा इतका विस्तृत टॉपिक आहे. मी मान्यवरांचे आभार मानण्याकरता मी डॉक्टर कटारिया यांना विनंती करतो.
I thank moderator Dr. Reshma Rajbhoi, panelist, and for this wonderful panel discussion. It was a panel discussion that should go on and on, but due to time limit, we are concluding this session and we are forwarding to the further inauguration ceremony. I would like to welcome Dr. Yuvraj Karpe sir, Civil Surgeon Satara, for inauguration ceremony. I like to welcome Dr. Ravindra Kute sir. I welcome Dr. Nitin Ghorpade sir. I welcome Dr. Asha Jadhav, Joint Secretary, South Zone IMA. I also welcome Vice President Dr. Nitin Ghorpade, South Zone Maharashtra, IMA. We'll proceed to inauguration ceremony now.
I'll request Dr. Deepak Thora to felicitate the dignitaries with permission with moderator, ma'am.
Yes, yes, sure, sure.
Dr. Chitra Dabrokar, madam.
Here, just take opportunity while these things are going on. Here, IMA Women Wings is not stopping here with just panel discussion.
Dr. Rajeshri
Here,
Deshpande, madam.
I would like to
President
announce
Women's Wings, Satara.
one
IMA.
workshop in soon with all these my panelists.
Dr. Rajeshri Thoke, madam, active member of IMA Women's Wing. Godse sir. Gaikwad sir. And not to forget our moderator, with always a smiling face, Rajbhoi ma'am, Reshma Rajbhoi ma'am. I would also request our dignitaries to felicitate Chairperson Dr. Sanjog Kadam sir. Thank you. Thank you for such a wonderful panel discussion on cyber parenting. Thank you. Now we'll proceed for inaugural function of SATCON 24.
Thank you all delegates for being with us. Today we gather here for the inaugural ceremony of SATCON 2024 conference. I would like to introduce you all to the rich and glorious legacy of 7 decades. That's almost 70 years of IMA Satara, established long back in June 1954. With almost 350 dedicated members enrolled, the IMA Satara branch stands as a testament to the unity and commitment of our medical fraternity. It is an honor to announce that our branch has its own building premises, providing a hub for collaboration and learning. Furthermore, I am proud to share that IMA Satara branch has been bestowed with the President Appreciation Award 4 times, a remarkable recognition of our collective efforts and dedication to excellence. This year marks a significant milestone as we welcome the establishment of the Women's Wing in Satara. The Women's Wing has swiftly become a driving force, successfully organizing various programs that contribute to the holistic development of a community. As we reflect on the past and embrace the present, let us continue to uphold the values and that have shaped the IMA Satara branch into a thriving and dynamic institution. Together, we can look forward to a future filled with shared accomplishments, continued learning, and the unwavering spirit of collaboration. And to continue next program, I would like to call upon our famous radiologist, Dr. Yuvraj Salunkhe sir.
All the delegates now will proceed for inaugural function. So I would like to call upon the dais President Satara IMA, Dr. Sharad Jagtap sir, and to escort with him the dignitaries present for the inaugural function today, the guests present for the inaugural function today. Dr. Asha Jadhav madam, Dr. Nitin Ghorpade sir, Dr. Yuvraj Karpe sir, Civil Surgeon Satara, Dr. Ravindra Kute sir. I would also request Dr. Deepak Thorat sir, Secretary Satara IMA, to be on the dais. Also, I will welcome Dr. Subhash Kadam sir, Additional Civil Surgeon Satara. Let us start with, we are also having 2 our guests online with us. Dr. Saurabh Sanjanwala, Secretary IMA State, Maharashtra State, and Dr. Dinesh Thakre sir, President, Maharashtra State IMA. I would also like to welcome Utture sir. He is also with us for the inaugural function. I would like our President, Dr. Sharad Jagtap sir, and Secretary, Dr. Deepak Thorat sir, to felicitate and welcome all the members on the dais. Civil Surgeon sir, Dr. Yuvraj Karpe sir, he is our family member of IMA Satara. We are very much privileged, we are blessed, and we are very proud to welcome Dr. Karpe sir, the Civil Surgeon Satara. He served for more than 15 years in the government services. His work during the COVID pandemic as Superintendent of HDS Koregaon with 100-bedded COVID hospital is appreciated and awarded at all levels. He's having a vast experience in obstetric and gynecology, and his specialty is laparoscopy. I would like to felicitate, request Dr. Jagtap sir to felicitate. I would like to ask Dr. Deepak Thorat sir to felicitate Ravindra Kutte sir. He is a past president IMA Maharashtra. He is a Central Working Committee member. He has many appreciations in the award. The time won't permit to mention all. He's having awards at the national level, state level IMA. I would like President IMA Women's Wing, Dr. Rajeshri Deshpande Madam, to felicitate Dr. Asha Jadhav Madam. She is a Joint Secretary for the South Zone of Maharashtra. She is an ex-chairperson, Women's Doctors Wing, Maharashtra IMA. And not less to mention, she is the first lady surgeon of Kolhapur. Welcome, Dr. Asha Jadhav Madam. I would like Dr. Jagtap sir to welcome Dr. Nitin Gorpade sir. He is a Vice President IMA Satara, IMA Maharashtra. He is an active member of IMA for last 22 years. He is the recipient of President Appreciation Award for 3 times. He is an Action Committee member of State IMA for many committees. I would like Dr. Deepak Thorat sir to welcome Dr. Subhash Kadam sir, Additional Civil Surgeon, Satara. He is also a family member of Satara IMA. We also welcome virtually sir, Dr. Saurav Sanjanwala sir, Dr. Utture sir, and President Maharashtra IMA, Dr. Dinesh Thakre sir, virtually. Welcome from Satara IMA sir. Now we'll proceed for light lightning and Dhanvantari Pujan ceremony. I would request Dr. Sharad Jagtap sir to escort the dignitaries for the ceremony. Dhanvantari, the god of health, usually depicts with 4 hands, one of them carrying a bowl of Amrit. Let us all wish Dhanvantari may shower Amrit of health, wellness and harmony on entire humanity. Light lighting is going on. Not to forget the prayer of IMA. Let us resuscitate the prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Indian Medical Association. It is a representative voluntary organization of doctors of modern medicine, a modern scientific system of medicine, with the objectives: number 1, the promotion and advancement of medical and allied services in all branches; number 2, improvement of public health and medical education; in India, the maintenance of honor and dignity of medical professionals. Now, with the permission of President Maharashtra State IMA, the presiding officer of the meeting, would like to start with the inaugural function. I would request Dr. Sharad Jagtap sir, President IMA Satara branch, for the welcome address for the SATCON 2024 and all the dignitaries. Dr. Sharad Jagtap sir, please.
Respected chairpersons on dais, honorable guest, Civil Surgeon Dr. Karpe sir, Dr. Thakre sir, President IMA Maharashtra Dr. Sanjanwala sir, Secretary IMA Maharashtra, Dr. Nitin Gorpade, Vice President South Zone IMA Maharashtra, Mrs. Asha Jadhav, Madam, Joint Secretary South Zone of IMA Maharashtra. I welcome all of you for our annual conference. We have conducted this 3-day conference. This is our third consecutive year of this program with 6 MMC points. We have included very informative and interesting topics which are helpful for common IMA member. In this event, we include not only doctors but all the dignitaries who give their valuable inputs for our members which requires in day-to-day life. I would like to make you a notice that Satara IMA branch is conducting so many activities for our members and also for the society as like medical health checkup camps, blood donation camps, membership increasing drive, tackling medico-legal issues, senior citizen felicitation, etc. I would like to point out to our office bearers that as a IMA still we are lacking somewhere in developing our strength as a powerful team. As we all know, practice is becoming hard day by day and heavy rules are imposing on us day by day. Common IMA member expect that registration process of the hospital and his practice should be hassle-free. With this conference, we are trying to get unite and expecting better outcomes for our members. With this, I would like to thank our dignitaries, Dr. Kute sir, Mrs. Jadhav madam, and Gorpade sir who came here. I would like to thank our executive committee members, Dr. Kataria sir, Deepak sir, Nitin sir, women wing members, Dr. Deshpande madam, all has worked a lot and taken efforts to their best. Thank you all of you.
Thank you, Jagtap sir. I would like to mention that women's wing of Satara IMA is very active and we should highly appreciate the work done by the women's wing. So may I welcome the ex-president Maharashtra State Women's Wing, Dr. Asha Jadhav madam, to address the session. Now she is Joint Secretary, West Zone, Maharashtra IMA.
Thank you. First of all, I thank President and Secretary Satara Medical Association for calling me here, inviting me here. As you mentioned about the Women Doctor Wing, I remember as I was chairperson for Women Doctor Wing, say 2 years back. That time, just Satara Women's Wing, they asked me the advice how to form the wing, even in Karad. And now they have grown to so much magnitude. So I am very happy that they started at that time. And their activities, and I can see also how enthusiastic women, I can say that when I came, I could note that women's wing is prominent here. So I am very happy about that. Another thing, as Dr. Kute sir is here, Dr. Gorpade, Dr. Dinesh Thakre sir, Sanjanwala sir, being a joint secretary of South Zone of Maharashtra, I'm very much thankful to all of you as they appointed me as in at this post. Being a joint secretary on this area. I'm very happy to join in, come to Satara and physically meeting all of you. Now the work is going on about everything, HBI wing, the violence against doctors, all these things, these very enthusiastic office bearers of Maharashtra state are working on that, and I'm very happy that I'm in their team, and I will now the recently membership development is magnitude is so much that I'm very happy that I'm one of the part of the team. I will continue to work like this only, and I'm very much thankful that you called me for this event. Thank you very much.
Thank you, madam, to be have so supportive words and shabaskichi thap on the work done by our women's wing and also to the IMA Satara. I would request Dr. Nitin Gorpade sir, Vice President, Maharashtra State IMA, to address the session.
Respected President Thakre sir, respected Secretary Sajjanwala sir, the icon of Maharashtra IMA Utture sir, my colleague of Ortho, who I got the opportunity to work in Miraz, who is working as at present President of Satara IMA, Sharad, all the dignitaries and of the Satara IMA, and the people who helped to become this conference. I am from very small branch. You will be surprised that I am working as a Vice President of Maharashtra. I can tell you in one word, काम ही मेरी पहचान है. So I am from a branch of Kurundwad where the only members are 25. You have seen the flood in 2019 and 2021. You have seen the destruction at the Kolhapur where there is a Panchanga river, and you have seen the destruction at the Sangli where there is a Krishna river. But you can imagine what happened to the place where there is a Sangam of Krishna and Panchanga. And I stay at the place Kurundwad, there is a Sangam of Krishna and Panchanga. I have seen the movie in 1997 Titanic, that everything washed away. Exactly, we are within 2 hours there is an intimation from the collector that the water level is going to rise, and nobody have a single minute. Everybody was running. I'm working as an orthopedic surgeon and my hospital is at the first floor, but everything was washed out. But even that time, IMA was strong. We have not left being an IMA member, and we have provided services to the people. Everything washed away, but not the spirit to provide medical help. That was the motive, and that was accepted and appreciated at every conference in the Pune as well as at Mumbai. I got so many awards. There's appreciation 3 times award, national award for the flood, as well as the first person to get the best president award for 2 consecutive years for the small branch. That is 100 less member. So if you are really working by a devotion, if you are really working for the IMA, place, person, or your number of members doesn't make a difference. Your work, the message given by all the icons and the dignitaries of the IMA, if you are really working hard for the IMA, your work will be appreciated at the state level. So if I will be very happy that from Satara, Sharad, if somebody from this place, this is have a very rich heritage, especially I am from a Santaji Ghorpade family, and this is a place where छत्रपतींची जी नगरी म्हणतो आपण ती आहे. त्यामुळं या ठिकाणाहून सुद्धा we like to see one of the president of IMA Maharashtra will become from Satara. I just wish all the best to all these members, and I hope Sharad you will work so hard and you will make not only me proud but everyone proud. So lastly, this is a few stanza. काम ही पहचान है. काम ऐसा काम करो कि काम अपनी पहचान बन जाए, ऐसा कदम उठाओ कि उसका निशान बन जाए. जिंदगी तो ऐसे ही जी लेते हैं लोग, जिंदगी तो ऐसे ही जी लेते हैं लोग, ऐसा जिंदगी की कदर करो कि वो मिसाल बन जाए. So you have to work such a way that your work in the IMA will become a misal. You will have a respect when you are in the post. Now you are the president of IMA, therefore you have a respect. But if you work really hard, that respect should be carried even though you are not on the post. If you've done such a work, then you are really done justice to that post. And I'm confident that you will do such a work along with all your colleagues. Once again, I thank all the members of this Satara Association calling me and appreciating me as a vice president. And I will definitely just give assurance that if there isn't some CME or any program which will be organized by Satara IMA, I will definitely there physically, I will be definitely present. Thank you. Thank you very much.
Thank you, Gorpate sir. We will always cherish your words. Kaam hi pehchan hai. And now I would like Honorable Secretary, IMA State, Maharashtra State, Dr. Saurabh Sanjanwala, to address the session online. Over to Dr. Saurabh Sanjanwala, sir.
Thank you very much, sir. At the outset, I would like to thank first our chief guest for today, my own president, Dr. Dinesh Thakre, sir, sitting national vice president, and our guide, Dr. Shiv Kumar Utture, sir, President, IMA Satara, Dr. Sharad Jagtap, Secretary, Dr. Deepak Thorat, Dr. Kiran Sonwalkar, the scientific head. I must really appreciate for the entire team of IMA Satara who has created such a beautiful academic feast for the members, covering all important topics which are practically related for the CME. That the theme for the is enriching relationship among doctors, which I think is very important in today's world. Maintaining the dignity, honor amongst ourselves is of prime importance, because doctor-doctor relationship will ultimately help in maintaining a doctor-patient relationship. So the theme of the conference also is very wisely and rightly chosen. I congratulate entire committee, organizing committee on 24, and I am privileged to be addressing this gathering. I wish them all the best, and I hope to encourage them to give such future programs. Just to add, I just happened to join at 5 o'clock and I attended the cyber parenting lecture. Excellent tips. I have requested Dr. Kiran Sonwalkar to share the details, the contents of the lecture, so that I can pass it on to all members and those parents of Maharashtra members who are parents of teenagers, and be a good guide for them. Thanks a lot once again. I hand it again back to Dr. Godbole. Thank you, sir.
Thank you, sir, for joining and addressing long from the Mumbai. Thank you very much, sir. In between, I would like to felicitate our own past president of Satara IMA, who retired as Deputy Director of Health Services from Pune region, Dr. Sanjog Kadam, sir. We would like to felicitate him because he was the person who rejuvenated Satara IMA, which was in the dormant phase, and now he has brought up the saplings like Dr. Sharad Jagtap sir, Dr. Deepak Thorat sir, to such a level. So they are doing so active work. Dr. Sanjog Kadam sir, please, for the felicitation. I would like Dr. Kute sir to felicitate Dr. Sanjog Kadam sir. We are very much lucky to have Dr. Sanjog Kadam sir to make the IMA active. Now, I would like our own family member, and for which we are very much proud and very much blessed, that Dr. Yuvraj Karpe sir from Satara IMA is now a civil surgeon Satara, and he is monitoring not only IMA Satara but also entire Satara district. Please welcome Dr. Yuvraj Karpe sir, please.
Namaskar. Respected dignitaries present for this inauguration of IMA SATCON 2024. Dr. Dinesh Thakre sir, President IMA Maharashtra. Dr. Nitin Gorpade sir, Vice President IMA Maharashtra. Dr. Asha Jadhav Madam, Joint Secretary South Zone IMA Maharashtra. Dr. Saurabh Sanjanwala, Secretary IMA Maharashtra. Dr. Ravindra Kutte sir, Past President IMA Maharashtra. Dr. Shivkumar Uttare sir, Past President IMA Maharashtra. And our Dr. Sharad Jagtap, President IMA Satara. Dr. Deepak Thorat, Secretary IMA Satara. And office bearers and dear delegates. I am honored to be here as a chief guest for inauguration of IMA SATCON 2024. IMA Satara, as I have seen has been giving you a wonderful opportunity to upgrade your knowledge in all aspects in various specialties. I can see the speakers from Satara and Satara district and around have been doing a great job in presenting a variety of day-to-day topics. IMA throughout the country has been doing a praiseworthy work, be it academics or any other social issues in which help is required. Let's all continue to support and urge newcomers to be part of this wonderful organization. As the civil surgeon of Satara district, I will always be there to support you any related issues and urge all the members to follow the guidelines regarding hospital registration rules, to run a hospital strictly for your own benefits. I wish this conference a grand success. Thank you. Long live IMA. Jai Hind, Jai Maharashtra.
Thank you, Civil Surgeon sir. You always remain supportive to entire IMA members, all the doctors of the Satara district. And now I would like to welcome Dr. Ravindra Kutte sir, Past President IMA Satara, to address the session.
ओके, फारच जोर व्हायचं नाही तर. Good evening, friends. President IMA Maharashtra, Dr. Dinesh Thakre, the very active, dynamic and communicative Secretary, Dr. Saurabh Sanjanwala, National Vice President, Dr. Shivkumar Uttare sir, President and the person who is behind SATCON conference, and a very active, dynamic President of Satara branch, Dr. Sharad Jagtap. ॲक्च्युली इन्स्टॉलेशन सेरेमनीला मी प्रेझेंट होतो आणि मधल्या काही ज्या काही ॲक्टिव्हिटीज आपल्याकडे झाल्यात, ब्लड डोनेशन असेल, ऑर्गन डोनेशन असेल, त्यावेळेस रेसिडेंटशिप चालू असल्यामुळं इतरही काही कंकरंट प्रोग्राम असल्यामुळं येऊ शकलो नाही आणि म्हणून आज या ठिकाणी मी समक्ष हजर आहे. सेक्रेटरी डॉक्टर दीपक थोरात, IPP डॉक्टर सूर्यकुमार खंदारे, then Joint Secretary IMA Maharashtra Dr. Asha Jadhav, Vice President Dr. Nitin Gorpade, Treasurer Dr. Nitin Ombase, Civil Surgeon and member of IMA Satara family, very cooperative and communicative Civil Surgeon Dr. Yuvraj Karpe sir, Vice President Dr. Sakar Kataria, Dr. Deepak, Dr. Sanjog, all the members, Dr. Rajesh Deshpande Madam, Jivan Lahoti, and all the managing committee members of SATCON 2024. All the faculties, all the delegates. जेव्हा आपण तो सायंटिफिक प्रोग्राम जर बघितला, इट इज व्हेरी वेल डिझाईन अँड व्हेरी वेल प्लॅन. कारण त्याच्यामध्ये जे काही टॉपिक्स आपण निवडलेले आहेत, दे आर हेल्पफुल फॉर डे टू डे मेडिकल प्रॅक्टिस. आणि ॲज फार ॲज सॅटकॉन इज कन्सर्न, सॅटकॉनचे बरेच वैशिष्ट्य आहे आणि त्यातलं पहिलं म्हणजे इट इज व्हेरी मेटिक्युलसली प्लॅन. 3 डे कॉन्फरन्स 2nd, 3rd and 4th of February. आज बऱ्याच ठिकाणी 1 डे कॉन्फरन्स होती आणि त्या कॉन्फरन्समध्ये सुद्धा नियोजन करण्यासाठी मोठ्या अडचणी येतात. आपण या ठिकाणी 3 दिवसाची कॉन्फरन्स ठेवून एक उच्चांक या ठिकाणी निर्माण केलेला आहे. त्याबद्दल मी डॉक्टर जगताप सर, सर्व टीम यांचं मी पहिल्यांदा अभिनंदन करतो. एक अवघड असं काम आपण या ठिकाणी केलेलं आहे. इट इज प्रॉपरली कम्युनिकेटेड. ह्या इकडच्या जेव्हा ब्रांच बघितल्या तर त्या ब्रांचचे बरेच मेंबर या ठिकाणी डिस्ट्रिक्ट सातारा डिस्ट्रिक्टमधल्या छोट्या ब्रांचेसचे बरेच मेंबर या ठिकाणी आपण इन्व्हॉल्व केलेले आहेत. ॲज अ फॅकल्टी म्हणून बरेच जणांपर्यंत ही सॅटकॉन कॉन्फरन्स होते आहे ही माहिती पोहोचलेली आहे आणि ॲक्टिव्हली त्यांनी पार्टिसिपेट केलेलं आहे. 2016 आपण सातत्याने हे ॲन्युअल कॉन्फरन्स सॅटकॉन या नावाने घेत आहेत आणि आज हे तब्बल 9वं वर्ष आहे. आपण एकही वर्ष न वाया घालवता हे 9वं वर्ष आपण सॅटकॉनचं पूर्ण करत आहोत. त्याबद्दल अभिनंदन. आपण ह्या वर्षापासून काही ओरेशन सुरू केलेले आहेत. विशेष करून सातारामधले काही आपले IMA मेंबर्स हे हेमलकसा या ठिकाणी जाऊन त्या ठिकाणी सेवा करतायत, सर्व्हिस करतायत. सर्व्हिस वीक त्या ठिकाणी सेलिब्रेट करतायत आणि ॲनेस्थेटिस्ट डॉक्टर संदीप श्रोत्री आणि काही त्यांची टीम यांच्या माध्यमातून आपण या वर्षापासून एक वैशिष्ट्यपूर्ण कार्यक्रम सुरू केलेला आहे, सातारा ओरेशन्स. त्याबद्दल अभिनंदन करतो. नंतर नवीन सदस्य वृद्धी हा सध्या डिस्काउंटेड मेंबरशिप ड्राईव्ह चालू आहे आणि सातारा IMAची मेंबरशिप ॲट प्रेझेंट इज 362. मधल्या काही काळामध्ये आपण नवीन मेंबर्स बनवलेले आहेत. IMA महाराष्ट्राकडे सुपूर्द केलेलं आहे. आजही आपण काही नवीन मेंबरला या ठिकाणी निमंत्रित केलेलं आहे. तर नवीन सदस्य वृद्धी सातारा आणि सब डिस्ट्रिक्ट ब्रांचेस यामध्ये मोठ्या प्रमाणात चालू आहे. ॲक्टिव्हिटीज आत्ताच सांगितल्याप्रमाणे ब्लड डोनेशन असेल, रुरल हेल्थ कॅम्प्स असतील, डॉक्टर्स डे सेलिब्रेशन असेल किंवा आपल्या हा ओन IMA हॉल जो आहे तो आपण आज त्या ठिकाणी बऱ्याच त्या ठिकाणी रिस्ट्रक्चर करून एक स्वयंपूर्ण असा आणि एक चांगला IMA हॉल या ठिकाणी सातारा IMAने उभा केलेला आहे. फ्लड हा एक आणि डिझास्टर याच्यामध्ये नेहमीच महाराष्ट्रातनं सातारा IMA पुढे असतं आणि मला वाटतं फ्लड असू नये तर नसो आपली टीम या ठिकाणी नेहमीच सज्ज असते आणि ज्या ज्या वेळेस फ्लड आलेला आहे तो पहिला मदतीचा हात दिलेला आहे तो नेहमीच सातारा IMAने दिलेला आहे. ज्येष्ठ IMA मेंबरचा आपण गौरव केलेला आहे. तर हा एक महत्त्वाचा भाग आहे का आपल्याच फॅमिलीमधले आपल्याच ब्रांचमधले जे ज्येष्ठ आहेत ज्यांनी महत्त्वपूर्ण या ठिकाणी कामगिरी केलेली आहे त्यांना आपण त्या ठिकाणी त्यांचं कामाचं कौतुक आणि त्यांचा सत्कार एक महत्त्वाचा. क्रिकेट टुर्नामेंट्स, ॲकॅडमिक ॲक्टिव्हिटीजबरोबर आपण बाकीच्या काही गोष्टी साध्य केलेल्या आहेत. त्यामध्ये टुर्नामेंट हा एक महत्त्वाचा आहे. इन्व्हॉल्वमेंट एक अजून एक वैशिष्ट्य आहे ज्यामध्ये मेंबर्स आज डेलिगेट्स या कॉन्फरन्सला मोठ्या प्रमाणात त्या ठिकाणी सहभागी झालेला आहे. आजही मला वाटतं 200+ ऑनलाईन दिसत आहेत. तर अशा प्रकारे इन्व्हॉल्वमेंट ऑफ मेंबर्स, डेलिगेट्स, स्मॉल ब्रांचेस, गव्हर्नमेंट ऑथॉरिटीज, कम्युनिटी इन्व्हॉल्वमेंट या सर्व पातळीवर IMA साताराने महत्त्वपूर्ण असं कामगिरी केलेली आहे. आता सौरभ यांनी सांगितल्याप्रमाणे थीम इन रिचिंग रिलेशनशिप अमॉंग डॉक्टर्स खरोखर हा एक महत्त्वाचा भाग आहे. आज डॉक्टर पेशंट रिलेशनशिप बरोबर डॉक्टर रिलेशनशिप हे महत्त्वाचं आहे. कम्युनिकेशन स्किल हे महत्त्वाचं आहे आणि ह्या मुद्द्याला धरून आपण या ठिकाणी जी थीम योग्य अशी थीम निवडलेली आहे ती खरोखर कौतुकास्पद आहे. नॅशनल फॅमिली वेलफेअर स्कीमबद्दल मी सांगेल कारण ह्या वर्षी मी त्याचं कोऑर्डिनेटर म्हणून स्टेटचं काम करतो आहे. ही एक महत्त्वपूर्ण स्कीम आहे आणि मला वाटतं आपल्याकडे अजून त्याचे मेंबर्स नसावेच IMA सातारामध्ये. फायनान्शियल असिस्ट टू दी फॅमिलीज इन द इव्हेंट ऑफ डेथ हा एक महत्त्वाचा भाग. त्याबरोबर फायनान्शियल असिस्टंट टू दी मेंबर्स विच बिकम परमनंटली डिसेबल्ड, इनकॅपॅसिटेटेड और अनफिट टू दी प्रॅक्टिस. मग अल्झेमर असेल, पार्किन्सन असेल किंवा डिमेन्शिया असतील किंवा न्यूरोपॅरालिटिक कॉम्प्लिकेशन असतील, स्ट्रोक असेल, वेगवेगळ्या कारणास्तव जर आपला मेंबर इज अनेबल टू कंटिन्यू हिज हॉस्पिटल हिज सर्व्हिसेस तर या ठिकाणी आपण त्यांना रिएम्बर्स करतो. त्याचबरोबर इट इज ॲप्लिकेबल अप टू द एज ऑफ 65. आणि याचा इन्स्टॉलमेंटसुद्धा ॲन्युअल इन्स्टॉलमेंट फार कमी आहे. इफ यू जॉईन ॲट द एज ऑफ 30 or 40 इट इज हार्डली 3,500 per annum. आणि लास्टली ॲन्युअल सबस्क्रिप्शन इज ₹500 आणि द इन्स्टॉलमेंट्स आर टिल 25 years. तर अशा प्रकारे नॅशनल फॅमिली वेलफेअर तिचं कव्हरेज जे आहे ते मेंबर, स्पाऊस, चिल्ड्रन, पॅरेंट्स, इन लॉज अशा प्रकारे एक अम्ब्रेला कव्हरेज असणारी ही जी स्कीम आहे नॅशनल फॅमिली वेलफेअर स्कीम, ही मोठ्या प्रमाणात आपण या ठिकाणी सर्वांना परिचित करून द्यावी, जास्तीत जास्त सदस्य वृद्धी याची करावी असं मला सांगावं असं वाटतं. त्याचबरोबर हा जो काही मेंबरशिप ड्राईव्ह आहे 25% डिस्काउंट, तर तो अजून काही दिवस हा डिस्काउंट असणार आहे. ह्या डिस्काउंटमधनं आपण जास्तीत जास्त मेंबर्स IMAच्या स्ट्रीमलाईनमध्ये आणावेत, जास्त सदस्यवृद्धी करावी असंही मला सांगावं असं वाटतं. आणि हा जो काही आपण 3 दिवसाचा या ठिकाणी कॉन्फरन्स आयोजित केलेली आहे सॅटकॉन, एक उत्तम नियोजनाचे एक उदाहरण आहे. त्याबद्दल सर्व मॅनेजिंग कमिटी, ऑर्गनायझिंग टीम, ऑल सातारा IMA मेंबर्स या सर्वांचं मी अभिनंदन करतो, शुभेच्छा देतो. धन्यवाद. आणि ह्या उत्तम नियोजनाबद्दल डॉक्टर शरद जगताप सर यांचा एक छोटासा सत्कार मी IMA महाराष्ट्राच्या वतीने करू इच्छितो. डॉक्टर नितीन यांनी तो करावा. साई वस्त्र, असीम. त्याचबरोबर दीपक थोरात सर यांचा आशा जाधव मॅडम. नितीन गोरपडे सरांकडे.
This is a blessing directly from Sai Shirdi. I hope this will give an inspiration to my colleague also.
त्याचबरोबर माझे जे सहकारी आहेत नितीन गोरपडे, आशा जाधव मॅडम, यांनाही वर्षभर या ठिकाणी साऊथ झोनमध्ये काम करायचं आहे. त्यांनाही मला वाटतं हे सर्वांचं आज या ठिकाणी पहिल्यांदा भेट होत आहे. त्यांना मी शुभेच्छा म्हणून त्यांचाही सत्कार करतो. With this, my warm regards and best wishes to the IMA Satara for SATCON.
Thank you, respected Dr. Kute sir, always being in the role of mentor to Satara IMA and helping out in all the situations that required to go ahead in the course of time. Our president, Dr. Dinesh Thakre sir, is live from Amravati, his hometown. He had been here in Satara before. Always a calm personality. President of IMA Satara would address the session and mainly enlighten all us on the role of local IMA branches tackling challenges in medical practices. Over to you, Dr. Dinesh Thakre sir.
Thank you, Dr. Kiran Sonwalkar sir. If I am right, I am not able to see who is speaking. I expect that this was Dr. Kiran only.
I'm Yuvraj. We had been there during elections.
Yes, yeah. I am not able to see the faces. So, our National Vice President, Dr. Shivkumar Utture sir. My Secretary at State IMA, Dr. Saru Sanjanwala. Past President of IMA Maharashtra, Dr. Ravindra Kute sir. State VP from the zone, Dr. Nitin Gorpade. State Joint Secretary from the zone, Dr. Asha Madam. Respected Civil Surgeon of Satara, Dr. Yuvraj Karpe. Secretary, Dr. Deepak Thorat. And all the dignitaries sitting there. Now, I have gone through the Satara SATCON details, and as rightly said by Dr. Saurabh, the topics were very good, and most of the academic topics are involved.
And from the feedback that I am receiving, I am seeing from here, is that it was a good feast for all of you. Formally, first I declare that SATCON 24 is inaugurated officially. Regarding the speech, Dr. Saurabh and Dr. Kute sir, they have guided you about all the things from Maharashtra state. Dr. Kute sir's speech was not less than IMA Maharashtra state president's speech. So you have got all the information regarding the IMA Maharashtra and the schemes and the which president ought to tell you. So I think, and also we are nearly half an hour, I think, late. And also I am eager to listen Dr. Uttare sir's talk on NMC. So I think I should start with my talk. And I would like to ask how much time do we have for my talk? So you can have a time about 15 minutes. Okay. I will try to finish up in 15 minutes. And if someone is likely to have questions after my talk, so you may share my number and ask me to contact if he wants something more. So I will try to complete in 15 minutes. I'm sharing the screen. I hope that I am visible and audible also. Please confirm.
Yes, yes.
Dr. Yuvraj?
Yes, sir. You are audible
Yes,
as
sir.
well as
Yes,
visible.
sir. You're very much audible.
Yes. So we'll start. So today's topic, a little change one. Contents are same. Tackling challenges in medical practice, and especially role of local branches and IMA members. Current and near future scenario is that lawmakers feel that we are under-regulated. Therefore, they are bringing in newer and stringent laws or changing penalty to imprisonment in various bills. They are withhold violence against doctors bill at parliament level. Now, government feels that acts passed by legislation are lenient. So what they do, they make the rules stringent and innovative, like biomedical waste rules, PCB rules, hospitalization renewal rules, we are seeing, electric audit, structural audit, etc. This is not less. So judiciary feels that acts and rules are pro-doctor. So what they do, they apply stringent formula in CPA for compensation to go in crores. They punish doctor for bad handwriting. They want doctors to display their mark sheet of all UG and PG exams in OPD. If you don't believe, see the news in papers. SC fines for poor handwriting. Ask doctors to display their attempts in clinics like that. So they give more important documentation than the untiring efforts of the doctor behind those documents. In their flow of interpreting words, sometimes they fail to empathize with the healing hands. Precious time of doctors get wasted. Science students are choosing law as a career than medicine. They feel it's better to punish doctors than to get punished being a doctor. Then comes the police. They feel that doctors are villains, taking advantage of the fiduciary position. They arrest doctors in cases of medical negligence under the cover of maintaining law and order. They treat doctors like criminals. Then comes the media. Media feels that doctors are inhuman, hardcore criminals, and have no empathy for helpless patients. They start media trial, make public opinion negative, and end up defaming doctors. Like this, deuterium namis sampuntam. Then comes the public. Public feels that they will not get justice on making complaints. And even if they misbehave, all the machinery will fail them. So what they do, they take the law in their hands. They themselves want to punish the doctors. And unfortunately, major section of the society supports them. The one who misbehaves with the doctor, like a leader, political leader, local leader, he is praised by the public media. Wow, kya kaam kiya. And it's like he is fighting to help the poor.
against the draconian and villain doctor, though the doctor may have tried hard to save the patient. So it's like the doctor says, यह बात अलग है कि मेरा कातिल भी वही था और उस शहर में तारीफ के काबिल भी वही था, तो उसने डॉक्टर से बचाया. Then some of our own colleagues feel that all other doctors except me are black sheep. They help all of the above entities in their deeds, wrong deeds. They defame their own fraternity to please their masters, maybe political masters, and to satisfy their own superiority complex. Now, if such is the case, what is the way out? What is the solution? Who will change this scenario? Who will work to change the laws to stop our harassment? Who will change the misperception about us? Usually common answer we get that government should be. We should request, do protest to get it. Authority should appreciate our intelligence. Judiciary should appreciate that there is no mainstream, means guilty man. Police should be polite to us. Media should not publish defamatory stories. And public should complain at proper forums. But can we do something? या फिर ऐसा हुआ है कि रोशनी की तवक्को है अब उधार के चरागों से, हवा ने हमारी शम्मा को कब का बुझा दिया. The consumerism has taken up. Of course, we should expect others to do the things and favors to us. But if they are not doing, we as the doctors are strong enough mentally, socially, financially. We are intelligent enough, wise enough to address the genuine concerns by acquiring some new things, to give befitting reply to each of the assaulters above, and that too in the language each one of them understands. Respected Abdul Kalam said that my impression of the American people can be summarized by a quotation from Benjamin Franklin. Those things that hurt instead. I realized that people in this part of the world meet their problems head on. They attempt to get out of them rather than suffer. It was his quote. Best way to solve any issue is to turn back and face it. That Vivekananda has said. Best way to predict future is to create it. Abraham Lincoln. Can we do it? Let's see. But again, सिर्फ सोचने से कहाँ मिलते हैं तमन्नाओं के शहर. चलने की जिद भी जरूरी है मंजिलों को पाने की. I repeat, सिर्फ सोचने से कहाँ मिलते हैं तमन्नाओं के शहर. Dr. Sharad Jagtap was talking about what are the problems we are facing and what should we do. So सिर्फ सोचने से कहाँ मिलते हैं तमन्नाओं के शहर. चलने की जिद भी जरूरी है मंजिलों को पाने. So there are 12 modules of IMA Hospital Board of India. Each module is of 30 to 40 minutes. I will just go through each module in short time. Just give you the access. First module is make effective communication an integral part of your daily practice. How? Now the answer lies with the HBA or the local subchapters or local branches. They should arrange workshops to train hospital staff especially to enhance their communication skills. Effective communication, why it is necessary effective communication? I will quote शेर. उसने इतना कह के फोन रख दिया कि कोई आ गया है. उसने इतना कह के फोन रख दिया है कि कोई आ गया है. मैं आज तक समझ ना पाया घर में या जिंदगी में. So this is lack of effective communication. In cinema films, Hindi cinema, you see when a patient dies, the doctor says, "I am sorry," and we understand what he wants to say. But it's very risky to say in today's era. Many times it is a really lawful demand of the patient. The doctor should give him sufficient quality time. Answer all his queries gently with empathy. He says, "गर जो तुम पूछ लेते मेरा हाल तो क्या हो जाता. माना कि कोई रिश्ता नहीं दिल का, पर दिल तेरा घर बेचैन हो जाता मेरे लिए तो क्या हो. इस मुश्किल दौर से गुजर रही मेरी जिंदगी. अगर जान लेते तो क्या हो जाता." खास करके विजिटिंग डॉक्टर्स. तुझसे बातें करना, तुझसे मिलना एक सपना है, मिलती नहीं विजिटिंग डॉक्टर्स. अगर ये हकीकत में हो जाता तो क्या हो जाता. So second module is, I am going a bit fast. Proper documentation, relevant training to the staff. Don't allow any Tom, Dick and Harry to humiliate you just because you are poor in documentation. Doctors are most intelligent people in society. and they should use their talent to be perfect at least in the documentation. So see what Shair Allama Iqbal says, खुद ही को कर बुलंद इतना कि हर तकदीर से पहले खुदा बंदे से खुद पूछे बता तेरी वजह क्या है. You know this, all of you. Now let's see what Shair Dr. Dinesh Thakur says. खुद ही को कर कलमी मजबूत इतना परफेक्ट इन डॉक्यूमेंटेशन कि हर फैसले से पहले हर एक साहब, मे बी जुडिशियल पर्सन, गवर्नमेंट ऑफिशियल, मेडिकल काउंसिल ऑफिशियल, पुलिस एक्सेट्रा, तभी मीन्स डॉक्टर से खुद पूछे अब तू ही बता कि तेरी खता क्या है. सो खुद ही को कर कलमी मजबूत इतना कि हर फैसले से पहले हर एक साहब तबीब से खुद पूछे अब तू ही बता मेरे बाप की तेरी खता क्या है. आंसर बाय ऑनेस्ट डॉक्टर कम्युनिटी इज दैट खता तो मैंने बहुत बड़ी की है. मरीज के पहले अपना गिरेबान बचाया है. मुकम्मल इलाज करने इस्तेमाल करना है मेरा जो जहीन दिमाग, वो मैंने इन कागजातों को मुकल्लम बनाने में. ये अल्फाजों के सरदारों, तुम नहीं दे सकते मुझे इस खता की सजा, क्योंकि सौ बका एक लिखा अमल करने को तुमने ही मुझे मजबूर किया है. ये अंधा कानून है जो अंत में मरीज का ही नुकसान करता है. Now there are some solutions that are provided for documentation especially. Continue fight to repeal unnecessary documentation, efforts to bring in better documentation. Till then, follow compulsory documentation and learn how to maintain documentation happily, properly and wisely within the universities. And who can do it? Local branches can arrange workshops and can do it. Smart monitoring with delegation of work to staff. Third module is synergy and cognitive empathy. The local branches should arrange workshops to provide tips, training and guidance to members on handling all kinds of situations of professional distress, acquiring life skills, developing cooperation for mutual financial benefits like bulk purchase, hiring common agents for various services we need. Saving is earning. Doing efforts to improve interaction and contacts and level of mutual perception by organizing interactive sessions with various authorities, law implementing agencies, judicial personalities, advocates, journalists, social reformers, public figures, and suggesting staff help programs, schemes, organizing various staff training programs or documentation. We have to make our medical practice society oriented with obvious, deliberate, and transparent disclosure of empathy and self-reflection. The whole talk revolves around this quote. I again repeat, we have to make our medical practice society oriented with obvious, deliberate, and transparent disclosure of empathy and self-reflection. Such type of staff training program can be arranged at local branch level for staff, like what mistakes we do, rights of patient and attenders, responsibility of patient attenders, various situations that may arise in a hospital, how to act regarding hospital violence, how to act regarding various non-medical situations, medical situations, and how to act as per various acts like discipline. Fourth is various insurance related to hospitals. Appropriate choices for sleep. Local branches should arrange talks for office bearers of IMA Professional Protection Scheme to provide guidance on why professional indemnity insurance is the need of our, whether to take personal or hospital indemnity or both, and why, how much amount for cover, insurance of instruments, hospital building, fire, etc., whether take or not, group insurance of staff. Peace of mind and sound sleep is our basic right too. Fifth model is medical justing prevention. Medical justing means criticizing the treatment that patient has undergone so far before consulting you. And Dr. Uttare sir will also agree with me that this is the most common reason behind rising cases, maybe civil or criminal, and abuse and violence against doctors in hospitals. That is medical justing. Bad mouthing you can say. So branches should form this cell, medical justing prevention cell, and provide concrete solution to stop the menace of bad mouthing, which leads to most of the cases. We can provide you a draft or model rules for this. Promotion of harmony and spirit of brotherhood for benefit of. Sixth prong is medical legal cell. Whenever there is a medical emergency, doctor can handle because he is trained. But whenever there is a medical legal emergency, he feels helpless and depends on lawyers who have insufficient medical legal knowledge. So all branches should form this cell with the objective of imparting basic medical knowledge to the members, training IM members to be ethically and legally correct in daily practice, and to boost confidence in common IM members to face any medical situation in daily routine practice, and also to suggest such changes in practice in medicine which may either nullify or minimize adversities caused by a particular legal order. For example, the POXO Act, how to behave during the POXO Act. Seventh is public awareness against legal jargon. During daily regular interaction with the patient, relatives, people from different strata of society, we should make them aware about the legal jargon related to documentation. During our counseling, you can tell them repeatedly that I had to take so many signatures and consent because of so and so legal provision. You feel that I am frightening you by telling complications of the treatment, but the rules compel me to do so. We trust each other, but the legal provisions compel me to do such a documentation as if we don't trust each other. Cost of this particular treatment has increased because of so and so relevant rules. And also we need to identify the people who have the power and authority to direct us what we should do, what we should not do, irrespective of their own knowledge about the intricacies of medicine. Like we have seen in the corona, तंग आ गए अब हम तो रोज आते सरकारी फरमानों से, हमने तो सरकार बनाई थी कितने अरमानों से, सरकार किसकी भी. So according to me, only way to get rid of legal jargon, especially CPA, is liaising and lobbying with the politicians and lawmakers. Dr. Jagtap sir, I will draw your attention here. Liaising and lobbying with the politicians and lawmakers. Second practical way to get some relief from hospital registration, biomedical waste, fire NOC, electric audit, structural audit, and various licenses is liaising and lobbying with the law implementing authorities till the relevant amendments take place in rules and acts. Now, 8th module is reciprocal public grievance redressal cell. Majority of complaints of patients and their relatives, NGOs, civil society organization, outsource, etc., can be resolved through proper counseling of and across the table interaction with the aggrieved parties and the concerned medical professional and vice versa. So, branches should establish this cell with the involvement of reputed members of society for reciprocal grievance redressal for members of all sorts of society and members. Such a redressal cell at IMA Nagpur has shown good results. Now, 9th module is assault of study and response cell. Whenever an unfortunate incident occurs at any hospital or otherwise also, some miscreants try to take undue advantage for their illegitimate gains by unnecessarily harassing the doctors by various means. Most of the time, we know the habitual assaulters in the city, but we prefer to be unresponsive for the sake of peace of mind. Who can be such miscreants? Who can be such assaulters? It can be local politicians, various authorities, judiciary, media, police, public figures. Any XYZ can be such an assaulter. Who were the assaulters in Dr. Archana Sharma case? Local politician, the reporter, media, and police. Can this be considered as an assault on doctor? This is by then President of India. Quote, as doctors, your services must be available both to those who can afford your fees and also to those who are less fortunate and cannot. It is for society to profit from medical science, and it is not for medical science to profit here from society. Mr. Wasim Ahmed have given a befitting reply to then President, Mr. COVID. This Lutshai, I have told you, Lutter Nami Sampamta. During COVID pandemic, Mumbai Police Commissioner gave statement on doctors. Don't treat patients like commodity. I got relieved of corona just by paracetamol. Shouldn't this be considered as an assault on doctors? Most of these wise men would tell us target black ships within us first. First, they targeted black ships. Shout at them to follow legal provisions and to be ethical and blah blah. But what happens next? They accept the bribe and things go on. What has stopped in medical practice? ये बंद कराने आए थे तवायफ की कोठी, मगर सिक्कों की खनक देखकर खुद ही मुद्रा कर बैठे. That is happening. And agony of the innocent doctor is that the one who is taken to the task by the media. Media trial is done. हम पर तो कोई जुर्म साबित ना हुआ. कई local politicians, so-called समाज सेवक, what they do? हम पर तो कोई जुर्म साबित ना हुआ मगर तोहमत लगा लगा के वो मशहूर हो गए। हमारे यहाँ पे हम आई रिपीट विद द लोकल एग्जांपल हियर, हम पर तो कोई जुर्म साबित ना हुआ मगर तोहमत लगा लगा के वो आमदार हो गए इन और अमरावती। So assault or study response is that it's all about how you respond to an assault on you. Now the time is over, so I will try to finish in 5-6 minutes. Now it's all about how to respond to an assault on you. This is the just wait, Okay, this video is not playing. Let it be. Otherwise, also we have always time to identify and so what the assaulter study and response cell should do to identify and neutralize such assaulters. The local branch should form this cell. It is assaulter study and response cell to formulate and implement a well-planned strategy to respond to them by using all sorts of Sam, Dam, Dand, Bhed. Speak that language only which respect to entity understands. This is again not playing. Okay. So this is going to happen. पीडीएमसी में डॉक्टर और मरीज के बीच मारपीट, भी डॉक्टर भी मारने लगे हैं रिप्लाय में. जामनेर शहरातील मल्टीस्पेशालिटी हॉस्पिटलची खोट्या माहितीच्या आधारे बदनामी केल्याप्रकरणी मनसे तालुकाध्यक्ष अशोक पटेल यांना पुराव्यासह न्यायालयात हजर राहण्याची नोटीस. So such things are happening. Our doctors are getting aware. They are fighting back. Continuous political licensing is important to stop these assaulters. No admission of complaint in any forum if there was violence by patient side in the past. Exclusion from CPA 2019 with the establishment of medical tribunals. Guidelines for prosecution of doctors based on Honorable Supreme Court's guidelines. Prospective application of rules framed under various acts like our Hospitalization Renewal 2021 GR. Again, continuous and consistent legal fight. Filing contempt of court for non-implementation of the favorable judicial process. Challenging unacceptable and legally not tenable legal provisions in various rules and acts. Most importantly, whenever a new police officer joins any police station in your city, gift him copies of Jacob Matthews judgment, Martin D'Souza judgment, and State Specific Medical Protection Act, with after highlighting important provisions. 10th module is violence against doctors. So local branches should arrange talks to provide training to the members and their staff, importantly staff, on all aspects: prevention, anticipation, preparing for handling, and post-event response to any incident of this. Now the talk on this module is of 30 minutes. It will see later. 11th module is healthcare delivery to be led by medical profession. As you are aware, the leadership in the healthcare delivery is slowly and steadily in passing into the hands of entrepreneurs of all backgrounds, and the medical profession is at risk of being relegated to the sidelines. So we need to stop entry of non-modern medicine personnel and companies in our fraternity. The modern medicine doctor should be the leader of the team in any given modern medicine hospital. Group practice and receiving and hiring services only from modern medicine doctor is the need of, and also need to understand and deal with the ground realities about cross-study and cross-reference. 12th module is last module is the unity. If there is a case or abuse against doctor in the city, some colleagues talk against it. They start talking against it. They are damn sure that the doctor must have done something. Some others choose to remain unresponsive or aloof. What they say, I will respond only when I face them. They are not at all at fault. Overall mentality of the society is like that. See this picture. Thank God the whole is not yet on our head. Mentality of many of us. लगेगी आग तो आएंगे घर कई जद में. लगेंगे आग तो आएंगे कई घर जद में. यहाँ पे सिर्फ हमारा मकान थोड़ी है. जब आएंगे जब देखेंगे. Many doctors unfortunately do not support efforts of IMA. It's like टूटा बिखरा हुआ हूँ मैं अपने वजूद में, रोज कील ठोक रहा हूँ मैं अपने ही ताबूत. So stronger HBR, stronger IMA means stronger United Hospital across in the city. Unity of modern medicine hospitals pan-India under the banner of IMA is the need of ours, especially under Hospital Board of India, to show the strength to get our issues resolved. IMA Hospital Board of India needs manpower and expertise to do this work, and it is duty of each and every modern medicine doctor to contribute. Please choose the work in the area of your interest and start under the guidance of the IMA leaders. Issue-based work groups to be formed to handle issues at the hand. We have done it at state level and headquarter level also. Strong Hospital Board of India sub-chapters are needed to coordinate the work with the state branches under the guidance of our national leaders and percolate the information of the organizations. You are requested to come forward and take at least one response. We may discuss each and every module at later point of in detail. There are many other unique features of each module which I have not discussed today because of the time. If you wish, you can arrange a full day webinar on physical workshop, even branch to understand all the modules. Like this, such type of workshop can be taken, which will be in which we will teach and make the members aware about all the modules. Now, this is the poem. It is Stronger I Am is Stronger Me, but it is already 25 minutes. So I will not read it out. I will send it on the WhatsApp, and I will request President Sharat Jagtap sir to percolate it in your branch. I will just. Thank you very much.
Thank you, President sir, for officially inaugurating the SATCON 2024. And thank you for the slogan, Stronger IMA, Stronger Me. Request Dr. Deepak Thora sir for vote of thanks.
हा सगळ्यांच्या सेशन नंतर एक वोट ऑफ थँक्सचा कार्यक्रम हे करताना खरं इतर स्टेजवरती सगळे असलेले आणि ऑनलाईन आणि ऑफलाईन असलेले ठाकरे सर असतील, संजनवाला सर असतील, उत्तुरे सर असतील, तर सर्वांच्या प्रेझेन्समुळं आणि आमच्या सगळ्यांच्या पूर्ण टीमच्या मेहनतीमुळं आजचा कार्यक्रम हा खूप यशस्वीरित्या झाला आहे आणि अजून कार्यक्रम चालूच आहे आणि तो उद्या पण राहणार आहे. तत्पूर्वी इथं आलेले सगळे मेंबर्स ऑनलाईन ऑफलाईन जे आपले टीचर लोक आहेत किंवा सर लोक आहेत, सर्वांचं धन्यवाद. डॉक्टर कुटे सर असतील, घोरपडे सर असतील, जाधव मॅडम असतील आणि आमची IMA टीमकडून सर्वांचे धन्यवाद. थँक्यू.
Thank you.
With the permission of President sir, hereby declare the function is over. Over to you,
Permitted.
Dr. Rajeshri.
Thank you so much, all the dignitaries. We'll start with our next session soon as we are running out of time. I would like to request Dr. Shivkumar Utture sir to continue with our next lecture, that is about MMC Code Ethics 2023. Utture sir is Vice President of IMA Headquarters, Delhi. He is a President of Maharashtra Medical Council, member of National Medical Commission, Advisory Committee, and Executive Committee, Maharashtra Medical Council. And apart from that, he is being awarded AKN Sinha National Award recently, and many more with him. So, sir, please continue with the next topic and guide us on the code ethics of MMC 2023, the recent ones. Please, sir.
Yeah, thank you, madam. I think you have just now heard the State President, Dr. Thakre, in his classical amicable style, telling you about what you should do and how IMA should be strong with all his modules and all which he has created himself. I think that was a great talk. So Dr. Thakre, President, Maharashtra State, Dr. Saurabh, Dr. Kute, sir, past President, IPP, my friend Dr. Nitin, Gorpade, Jadhav Madam, Dr. And of course, State President, Branch President Dr. Jagtap, Secretary Dr. Thorat, and all office bearers of IMA. Congratulations on this great program that you have been having. And let me just go share my screen because as it is, I think we are running very much late as far as the timing is concerned. So can you see my screen?
Yes, sir.
Yeah, okay. So let us see now, Dr. Thackeray, I think with his talk of what is going on at present in as far as the medical profession is concerned, even has scared me. So what I would like to do now is that, if you are aware of what exactly you're supposed to do and not supposed to do in your day-to-day practice, definitely it will go a long way in solving all these problems that you'll be facing in your day-to-day practice. And that's what my main aim would be as far as the new NMC Code of Ethics, which was declared, and it was gazetted on 2nd of August, and it was called as the National Medical Commission Registered Medical Practitioners Professional Conduct Regulations 2023. As soon as it was gazetted, there were few provisions in that which was absolutely opposed by all medical professionals, and especially IMA, where we had to go right up to the health minister, central health minister, and then immediately because of those provisions, immediately this was put in the cold storage, and then on 23rd of August 2023 itself, that means within a span of, if you see the date of 2nd August and then 23rd August, that means within 20 days, this document or this notification one was taken back, and it was said that the National Medical Commission Registered Medical Practitioners Professional Conduct Regulations 2023 are hereby held in abeyance with immediate effect. And having put it in abeyance, so we are back to our 2002 Code of Medical Ethics as put forward by the Medical Council of India at that time. So this happened because of our opposition, and just like how Dr. Thackeray said that, when people ask you what IMA is doing, why should we be a member? This could be a huge thing that you can say that it was the collective strength of IMA which even made the National Medical Commission bow down and put this document which was detrimental. And there were only 2 or 3 aspects which were detrimental to us, because of which we opposed it. And we'll come to that. I will come to that in that document. So what I will be talking about, why I am talking about this document, because as it has said, it is in abeyance. It has not been abrogated, as these are the legal terms that they use. When they say in abeyance, means tomorrow, sometime or the other in the near future, this document is going to be again notified with some corrections in whatever we have opposed, but it will be coming. So it is always better to know in advance, as I said, that in your day-to-day practice what you are supposed to do and what you are not supposed to do. So just I'll go fast because there is no time. This lecture is almost around 2 hours lecture, but I'll try to finish it within 20 minutes that have been given to me. So basically what will happen is, as of today, you all have the Maharashtra Medical Council number which you quote in all your documentations. But once this code of ethics comes in, there will be a unique ID code or number which will be generated by the National Medical Commission, which you will have to use in all the future. This is a good thing that is coming up, because as you know today that there is a lot of duplication, triplication, especially the same doctor is working in 2 different states. He gets 2 different numbers, which both the numbers appear in the National Medical Registry. And all that will be stopped once we have a unique identity, just like your Aadhaar card. This is going to be a unique identity number for wherever you practice as far as India is concerned. Then, of course, another important aspect which we have been fighting as IMA is that, people who come with these foreign medical degrees, and over there they get the degree of MD, which is equivalent to MBBS. And they used to get a registration as MD, and they used to work as consultant, though they had no experience as far as or qualification as far as consultants are concerned. So this has been taken care of by NMC, and they have very clearly said that only approved equivalent medical prefixes and suffixes can be put by all these students who come from, or FMG students, that means the foreign medical graduates. Keep a watch on all this in, wherever this L1, L2, L3 will be coming, because I'll be explaining to you at the end what this exactly means by L1, L2, L3. Then, of course, you should not be associated with any unqualified persons whenever you are giving a treatment. That means be careful, especially to my anesthetist friends. I would say that if you are going to give anesthesia for those people who are not registered with the National Medical Commission and there is a complaint against you, you may find yourself in trouble as far as the National Medical Commission is concerned if there is a complaint against you. Nor will you employ in connection with your practice any healthcare professional who is neither registered nor trained under the relevant medical acts in force related to the practice of modern medicine. This again is, this is what will be affecting a lot of us in the future also, because especially in small towns, as you are aware, that we have a lot of RMOs and everybody who are basically not modern medicine doctors. So be careful. You can employ them as far as looking after the patient is concerned, but they cannot primarily treat your patients with modern medicines or prescribe modern medicines on their own. So that care you will have to take in the future whenever you are employing them. Then, of course, renewal of license, which was there in Maharashtra state, it was compulsory every 5 years, and you had to do 30 credit hours, which all of you all have now doing. That is going to come all over India. There are more than 50% of the states who do not have this. So they have followed the Maharashtra model, exactly what we have done. And they have said that those documents of completing those credit hours should be submitted when you are doing your renewal. Then RMPs who are licensed to practice in that state after payment of requisite fees in that state, and their names will appear on the state medical registry. Why this is important is there was always an argument going on that suppose you have registered with the Maharashtra Medical Council, your name automatically goes in the National Medical Registry, which is kept by the National Medical Commission. So people thought that because in the National Medical or the old MCA, it was written that once your name appears in the registry, you can practice anywhere in India. So there was, arguments on both the sides, but that has been very much clarified over here. Now it will be compulsory for you to, to get a license from the state in which you are actively practicing. So if you are practicing on the border and you are practicing in 2 states, you will have to be registered in both the states. And there is a thinking behind this also, because if suppose you are practicing in Maharashtra, but you have got a registration in Gujarat Medical Council, and in Maharashtra there is a complaint against you because you have treated some patient. The Maharashtra Medical Council cannot hold a hearing against you because you are not registered with the Maharashtra Medical Council, whereas the Gujarat Medical Council cannot hold this hearing because because the powers of that state council is the boundaries of that particular state. So obviously they cannot hold a hearing against you. Then let me tell you, even as doctors, you will be in soup, because then it directly goes into the high courts or whatever, CPA, high courts, whatever it is, where definitely you will not get that justice and fast justice as you would expect in a state council. Another good thing that has been put up over here, which was not there in the old MCI Code of Ethics, is that as an RMP, you can refuse to continue to treat the patient if the fees as indicated are not paid to you. Now, this gives you a lot of legal backing and a lot, especially from a council, which is a statutory body, because today, if the patient is with you and you're treating the patient, and in between the treatment, the patient refuses to make your payment, you are stuck with the patient, you cannot do anything. But now, this Section 6 gives you the right to see to it that you can shift the patient to any other government institutions and the council will not take any action against you. Then, of course, which was there in the old thing, that you cannot soliciting patients is not allowed directly or indirectly. But in the old MCI Code of Ethics, it was restricted to only RMPs. We knew that this was because I was part and parcel of the National Medical Commission for 2 years when we formulated majority of these sections. It was not a level playing field for the individual doctors and their individual doctor-owned hospitals, because big hospitals, big organizations, nursing homes, corporate, especially corporate hospitals, used to left, right, and center advertise, and nothing could be done to them because they were not coming under any statutory body. So we have tried over here to bring them also under the control of the National Medical Commission, so that would be a level playing field for even individual RMPs or registered medical practitioners. At the same time, as much as powers or as much leeway they would have as would be in a corporate hospital. Then fee splitting was there in the old also, so I won't go into the detail in that, so you cannot do that. Advertisement is another thing which we have at least taken one step forward, though I was very much interested in bringing quantum changes in this advertisement. And just as in Western country, something called ethical advertisement. I had even given a big presentation in the National Medical Commission on this. But somehow or the other, though it was accepted in the National Medical Commission when it went to the higher authorities, somewhere they said we will not be able to take such a big step. But at least the first step forward has been taken. So if you see over here, there are two aspects. One thing, in the old MCI Code of Ethics, they said that you could advertise if you fall under one of these 7 categories, on starting practice and public declaration of charges, changing address, etc., etc. But it never said how long you are allowed to do this. So is it for 1 day? Is it for 1 week? Is it for 1 month? So it was not, exactly denoted how many days you could do that. But here we have said that up to 3 months, definitely you can advertise if you fall under any of these categories. Not only that, as I said, we have gone one step forward and we have said that you may place announcements in the lay press, but these should not contain anything more than the name of the institution, the type of the patients admitted, kind of training and other facilities offered, and of course the fees that you are charging. So to some extent you can advertise if you stick to whatever is written down over here. And this is in the guidelines of the social media conduct also, it has been given. So we have taken the first step as far as ethical advertisement is concerned. Again, the idea behind this was to give a level playing field to our individual doctors. Then, of course, another big problem that we used to face, especially with the insurance companies coming into play, because the old MCI Code of Ethics said that under no circumstances you could sell medicines to the patients. So it has to be part and parcel of your, say, daily rounds or your professional.
Excuse me, sir. We are running short of time, sir. So, sir, last 2 minutes.
I don't know. You have given me such a big topic. Anyway, I'll just read whatever is important and hope you'll understand what I have said. So you will be able to sell the medicines to your own patients in the future also, right? Then, of course, the documentations that you had to give to the patients were, it was said that within 72 hours, but it has been extended to 5 working days because in your busy practice, you may not be able to do that in the future also. Certificates is another thing. You have to keep a register of whatever certificates you have given to your patients. Then, of course, informed consent is something also that is going to come in a big way. Today, we are not following informed consent. So you will have to follow informed consent, which again is a 1-hour topic itself as far as what is informed consent is concerned. So, and another thing we have also put that you will, in the Central Government Clinical Establishment Act, it has said that all emergencies you are supposed to treat free of cost in your place. But we have specifically said over here that the RMP shall provide only first aid according to his expertise and the available resources in his institution. And if he does not have that, he can give the first aid and then shift the patient immediately to the this. Another aspect is that which Dr. Thackeray has also touched upon. It has been put over here that if there is an abusive or unruly or violent patient or relatives, you have got every right to refuse further treatment to that patient. And after informing the local authorities, you can directly shift him to the government institutions. So this is all there. You can go through this online also of your conduct as far as the social media is concerned, because a lot of doctors are going on social media. They should understand what they are allowed to do. One or two things I will just try to tell you that no, you cannot post the photographs of your patient or scan images on social media if you have not taken the prior written consent from your patient. Then of course this is for the patient. Patients they cannot you cannot let others know what the patient is suffering from. Confidentiality has to be maintained. And another big aspect is that you cannot purchase likes, followers. All of us are aware how some of our colleagues are putting that this, their patients, right? Of course, they are really not their patients, who say that I was suffering from 10 years and this is the best doctor I have found, and you will not find a better doctor than this. So all these things which were not there in the old MCI code of ethics, you please go through all these details. We will not be able to do in the future. Then, of course, this is something that we had objected to, that they had said that RMP should not be involved in any third-party educational activity like CPD, seminar, workshop, symposia, conference, which involves direct or indirect sponsorship from pharmaceutical companies. All of us are aware that if this happens, all our CMEs and conferences in the future will be it will not be able for the organizations and the associations to have these conferences. So we had absolutely opposed. This is one of the points we had opposed. And then, of course, another thing was brought in that within 2 years, there was no, in the old code of ethics, after 5 years, 10 years also, there could be complaint which could be lodged in the local councils. But now that has been brought down to only 2 years, which is definitely good as far as we are concerned. Then, of course, if you see disposal of they have given in detail how the complaint has to be followed and how it can be disposed, right from dismiss the complaints, warnings, right up to taking out or suspension of your name. Again, this whole thing has been followed verbatim what we were doing in the Maharashtra Medical Council. Appeals, you have got 60 days to appeal if there is a problem, where even the doctors are allowed to appeal against the state medical councils to the EMRB, that is the Ethics and Medical Registration Board. And if you have, you are not satisfied with what they say, you can go to the National Medical Commission. Means this is just like going to the High Court and then going to the Supreme Court in appeal. So these two are the courts that they can go and appeal in the future. Generic name was another thing which we had absolutely opposed, where it was saying, if you read what it is said over here, that you cannot, only they said that only prescribe drugs with generic names and avoid prescribing branded generic drugs. Now, this is also practically not possible, and we had opposed this also, and luckily the ministry listened to what we said. So I'll just go through the code of ethics in details. It is given. Whatever I have said that has been put down over here in short. This I won't go into the details. This is another thing that you have to take. This is what everybody is not aware, that we no more take the Hippocratic oath, nor in between it was there that we are supposed to take the oath which normally the Ayush people take. No, this is not there. The NMC clearly says that the Declaration of Geneva 2017, that is a physician's pledge, has to be taken whenever you get your license to practice. So in last 2 slides only, see now what up till now it was left to the state councils to decide what punishment to give you. But now, just like it is done in the other court of laws, if some section has, if you are the, there's some section which is applied to you in that court, that section itself denotes how much punishment can be given to you. So similarly, if you're level 1, it can be warning. If you're level 2, then it can be, up to 1 month suspension. Level 3, it can be, up to 3 months suspension. And level 4, it can range from 3 months to 3 years. And of course, level 5, It has very rarely you can take this where you are totally removed away from the medical council registry and you will no more able to practice. So sorry for going a little bit fast because of constraints as far as the timing is concerned. I hope you have understood what you are supposed to do in the future also as far as your medical practice is concerned. And if you follow all these rules and regulations, definitely you can, do your practice peacefully. Thank you. Thank you, Satara IMA, for having invited me to give this talk.
Thank you so much, Dr. Uture sir. Such a vast topic, and in a less span of time, you made us understand so many things, sir. Thank you so much, sir. Now, all the delegates, let's move on to the most awaited topic of discussion today. Our next panel discussion is going on medical negligence, which we come across in our day-to-day lives. So for this very important topic, I would like to call all the dignitaries on the stage, and before that, yes, Dr. Sharad Jagtap sir, our president, who is going to moderate this panel discussion. Medical negligence is such an important topic we all come across in everyday practice, needs quite a lot of discussion, and we have all the dignitaries here from various fields. Our civil surgeon, Dr. Karpe sir, our additional civil surgeon, Dr. Subhash Kadam sir, our past IMA president, Dr. Jeevan Lahoti sir, Dr. Bhushan Patel sir, a well-known cardiologist, Dr. Aparna Patange madam, she is HOD Medicine KIMS Karad, Dr. Samir Sohoni sir, he is the senior most anesthesiologist in Satara. So for the next panel discussion, I'll hand over to our president sir, Dr. Sharad Jagtap.
Good evening, everyone. We are starting the panel discussion. I welcome all of you for this panel discussion, the panelists who are here. Today's our topic of panel discussion is medical negligence board meeting. In the day-to-day practice, we know that I escort Kadam sir also to be seated over here as a panelist. In the day-to-day practice, we know that we are facing many problems in the regarding medical legal issues, and when the issues come, then all scenario is going according to the laws in the police when they came and the inquest starts. When the inquest starts, that inquest goes to now this thing we know that direct arrest is not for the doctor, but there is arrest and some procedure is there. They are following that procedure, and then it goes to the civil board. We all know that there is a board and they analyze all the things which has happened in our hospital during the mishap. That mishap is analyzed and according to the report is given. So what type of that medical board is there, and what decisions are made, how the decisions are made, who are the panelists, and what is the rules according to the that panel. So here we are getting the awareness sort of regarding this medical negligence board meeting. Next slide, please. So what is the objective of today's this panel discussion is to create the awareness about the documentation required for the medical negligence board. So this is the GR. So accordingly, this I have specifically put this slide because of this type. GRs are always in this type only. I will just read for you. This is GR according to which the panelist and the ॲक्शन आर टू बी टेकन. वैद्यकीय व्यवसायासाठी अथवा रुग्णालयाकडून रुग्णांवर उपचार करताना निष्काळजीपणा दाखवल्यामुळे किंवा योग्य उपचार न करणे, उपचार वेळेवर न करणे अशा प्रकारच्या तक्रारी रुग्णालयाच्या नातेवाईकांकडून केल्या जातात. प्रसंगी डॉक्टरांवर तसेच रुग्णालयावर हल्ला केला जातो. प्रसंगी रुग्णालयाच्या मालमत्तेचे नुकसान केले जाते. त्यामुळे डॉक्टरांच्या नाहक मानसिक छळ होतो. डॉक्टरांविरुद्ध अथवा रुग्णालयाने उपचारादरम्यान हलगर्जीपणा केला आहे किंवा कसे ही बाब प्रथम या क्षेत्रातील तज्ज्ञ व्यक्तींकडून तपासून घ्यावी. संबंधित डॉक्टर अथवा रुग्णालयाने योग्य उपचार वेळीच केले नाहीत अथवा उपचारादरम्यान काही चुका केल्याचे निष्पन्न झाल्यास या अहवालाच्या आधारे पोलीस यंत्रणा पुढील कारवाई करेल. तसेच तज्ज्ञ समितीच्या निष्कर्षानुसारच पुढील कारवाई केली जाईल. समितीच्या अहवाल घेतल्याशिवाय अशी कारवाई झाल्याशिवाय केवळ वैद्यकीय अधिकारी रुग्णालयाविरुद्ध तक्रार नोंदवता येणार नाही. असे निर्देश माननीय सर्वोच्च न्यायालयाने मार्टिन डिसूजा वर्सेस मोहम्मद इशफाक AIR जे काय नंबर आहे तो सुप्रीम कोर्ट पॅरा 117 दिले आहेत. सदर परिच्छेद पुढील प्रमाणे आहे. वी देअरफॉर डायरेक्ट दॅट whenever a complaint is received against a doctor or a hospital by a consumer fora, whether district, state or national or by the criminal court, then before issuing the notice to the doctor or hospital against whom the complaint was made, the consumer forum or criminal court should first refer the matter to the competent doctor or committee of doctors specialized in the field relating to which the medical negligence is attributed. 1 minute. हाँ सर येत आहे नाही या की लगेच या लगेच चालू आहे. सिव्हिल सर्जन सो आय जस्ट attributed and only after field relating to which the medical negligence is attributed and only after that doctor or committee reports that there is a prima facie case of medical negligence should notice be then issued to the concerned doctor or hospital. This is necessary to avoid harassment to the doctors who may not be ultimately found to be negligent. We further warn the police officials not to arrest or harass doctors unless the facts clearly come within the parameters laid down in Jacob Matthews case. Otherwise, the policemen will themselves have to face legal action. So these type of the verdicts are passed by the Supreme Court, and accordingly the panel or the meeting has been set, and this meeting will be conducted by civil surgeon, the higher authority in the district level. Also one JR has passed in that they have directed that who should be the panelist. So जिल्हा शल्य चिकित्सक, वैद्यकीय अधिकारी वर्ग 1 भीषक, वैद्यकीय अधिकारी वर्ग 1 शल्य चिकित्सक, महाराष्ट्र मेडिकल परिषद यांचे प्रतिनिधी, तक्रारीच्या अनुषंगाने वैद्यकीय महाविद्यालयातील विशेषज्ञ, निवासी वैद्यकीय अधिकारी. So in this way they have given the directives about whom should be there in the panel of discussing that or analyzing this case, which has come in front of the civil committee board. So this is the GR which I have mentioned. One thing again, they have mentioned that शासन निर्णय न्यायिक उपरोक्त विषयास अनुषंगाने आपणास कळवण्यात येते की संदर्भित शासन निर्णयाचा अन्वये डॉक्टर रुग्णालय यांच्याकडून वैद्यकीय उपचारादरम्यान हलगर्जीपणा झाला आहे किंवा कसे याचा तपास करण्यासाठी समितीचे गठन तथा रचना विहित आहे. सदर समितीमध्ये महाराष्ट्र वैद्यकीय परिषदेचा एक प्रतिनिधी सदस्य असल्याबाबत प्रावधान आहे. शासन निर्णय अंमलबजावणी अनुषंगाने आपणास कळवण्यात येते की वैद्यकीय उपचारादरम्यान हलगर्जीपणाचा तपास करणे कामी समितीची बैठक आयोजित केल्याचे सूचना या परिषदेस आगाऊ देण्यात यावी, जेणेकरून परिषदेला आपणास सदस्याचे नाव कळवण्यात येईल. So I am a member or I am a dignitaries is the one of the part of this committee, which is the medical negligence board meeting. So accordingly, we have today arranged one panel discussion, which is the as a sort of what type of discussion is going on in the civil board negligence meeting. So our today's panelists are Dr. Yuvraj Karpe sir, civil surgeon Satara, Subhash Kadam sir, who is additional CS Satara, Dr. Aparna Patange madam, unit head professor medicine department KIMS Karad, Dr. Jeevan Lahoti, who is a surgeon, Dr. Sanjog Kadam sir, he will representative of the IMA Satara, Dr. Bhushan Patil sir, who is a cardiologist, and Samir Soni, he is the anesthesiologist. So these are the panelists who are here today. So now we will go to one model case today for the discussion. All the panelists are here. In front of them we will put up this case, and all the panelists should analyze this case, and after getting the analysis they should give the conclusion. The same things are happening in front of the civil in the civil hospital in front of the CS, who is the head of this meeting, and when he analyze all the things, he gets support from these all panelists who are expert in this analyzing the case, and he is giving the final report. So this case is there. 40 years male patient presented with anuria for 2 days and vomiting, left side ureteric colic for 2 days. No any history of fever or trauma. Past history, no any major illness. He is not taking any medication, or he is not taking any medicine. General examination at present, when he presented, he was conscious and well oriented. His BP was 160 by 100 mm of Hg. On examination, tenderness was there in the left iliac region. Investigation, only the positive findings were his creat was 5.4. On the next day of admission, his creat was 8.4. In the ECG, it has been told that it was having the mild ischemic changes. Under the USG, they found that there was a left ureteric calculus of 10 millimeter. It is on the lower side, mild hydronephrosis. On the right side, there was a 20 mm calculus and ureteric with the mid ureteric region with the gross hydronephrosis with thin cortex. Patient was operated next day morning with the ureteroscopy, and stenting was done for removal of the left ureteric calculus under the spinal anesthesia. Procedure was uneventful. Patient was discharged after 48 hours. Creatinine was 2.6 after 2 days. He was readmitted after 1 week. At that time, urea and creatinine was found to be normal. So patient was posted for right side. Left side was cleared. Urethrolithotomy under spinal anesthesia. This procedure was also uneventful. Patient was normal for 3 days. He was moving in the ward. Then early in the morning, he suddenly got convulsions. And welcome, sir. I welcome Karpe, sir, our civil surgeon, to join our panel discussion. He was moving in the ward. Then early in the morning, so sir, we are getting this case and we are discussing, and after that we will come to some conclusion. He suddenly got convulsions and cardiac arrest, and he succumbed to death. All resuscitative measures were taken in the same hospital with all teamwork. That means anesthetist came, that resuscitative measures were taken, ventilator and all those things were properly taken care. And now the post-mortem report is awaited. So now we will come to the discussion, and I will ask some questions accordingly. We should come to our first to the cardiologist, Dr. Bhushan Patil sir. Wait. So Bhushan.
He is always a civil member committee. and GR is 2000 MGR, and either the committee is formed by the civil surgeon
Yes.
or the HOD of the concerned faculty of the medical college, and the chairman is civil surgeon, RMO is the secretary.
Civil surgeon.
Civil surgeon, if it is formed by the civil hospital,
Yes.
civil surgeon is the chairman,
Yes.
RMO is the secretary,
Yes.
and there are 5 members, and it is not IMA member, it is Maharashtra Medical Council.
Yes.
It is Parishad is council.
Council.
We usually grant it that it is the IMA member,
IMA member.
and actually it should be Maharashtra Medical Council member.
Thank you, sir, for your kind inputs. So I will first go to our cardiologist just for now analyzing the case before going to the conclusion. So questions in front of you, sir, Dr. Bhushan Patil. Does this finding on ECG leads to death of the patient 3 days after operation? One question.
Yes.
Other causes of the death related to this case after operation?
Yes.
Your opinion, please.
According to me, I have analyzed the case. It is most probably obstructive uropathy, and initially the symptoms were all related to obstructive uropathy.
Yes, sir.
And after that, they have operated. They have relieved the obstruction. Patient has shown improvement, and patient has been discharged once.
Yes.
And again, he has been admitted for the next procedure. And after procedure, I think 48 hours after the procedure,
Yes,
in
3
the
days.
ward, he had a sudden convulsions, and he had a cardiac arrest. So according to me, this cardiac arrest has nothing to do with the surgery or procedure or what is the illness.
No, your sir
My
main
question, yes,
highlight is
yeah,
on the ECG changes. which
ECG
has been-
changes. They have mentioned mild ischemic changes. What we call as mild ischemic changes. There are some teen versions. So mild ischemic changes can be related to ischemia, or it can be some arrhythmic heart disease also. So there are several arrhythmic heart disease like hypertrophic cardiomyopathy, arrhythmic right ventricle, or even dilated cardiomyopathy. They can even present as mild ischemic changes. So these patients are prone to go for sudden cardiac death, irrespective of the surgery. So this can be happen irrespective of surgery. These patients are prone for sudden cardiac death at any time, irrespective of the surgery. So only the hint or only the lacking evidence in this is was the echo done?
Yes, that's what I want to ask you. Whether echo, any finding of echo,
Yeah. So
wait, sir. Any finding of echo would have prevented this surgery?
no. So any finding the echo might have found that there may be some arrhythmic heart condition. So this would have not stopped the surgery, or this would have not changed the protocol, or this event also this would not change. Only thing that we could have counseled the patient relative that this patient is a high risk for sudden cardiac death, and he may die anytime during the surgery, irrespective of the surgery. Even if the surgery is not done, he is prone to go for sudden cardiac death. So only thing that would have changed, that patient relative would have got counseled that their patient is for high risk for a sudden cardiac death. Now recently 2023 European Society of Cardiology guidelines are there for pre-operative evaluation. So for your pre-operative evaluation, they have mentioned even minute ECG changes, patients should go for a 2D echo. This is a class 2 indication. And patients who are having symptoms like breathlessness or any fluid overload like pedal edema, or even angina, and who is not known case of any heart disease, he should, or any murmur we are suspecting, he should go for echo before a surgery. That is a class 1 indication.
Thank you, sir. So 2 points I will take and give in front of all the panelists. That one thing is counseling would have been done if the echo would have been done, but not the prevention of surgery. One thing. And second thing is, according to new guidelines 23, that any sort of finding regarding to the ischemic changes should be taken as a positive for Doppler study.
Yes.
Thank you, sir. I would like to involve now the surgeon of our panel, Dr. Jeevan Lahoti, sir. Sir, question for you is surgery is cause of death after 3 days in this case?
No, basically considering the history, patient had initially raised creatinine. So considering the fact raised creatinine and obstructive uropathy, he had to undergo this procedure. Primarily the left ureteroscopy with URS was done, and followed by, he was discharged He was stabilized, his creatinine was brought down to normal, and later on again he was posted after the parameters had turned normal. He was posted for right ureteral lithotomy. From considering surgical point of view, I don't feel anything wrong has been done. The things, sudden convulsions might be precipitated due to this arrhythmia and cardiac conditions, but they have been not, means all what he said is very rightly true. It would have helped in counseling the patient's relatives.
So the surgery is not cause of death. Surgery is not contributing directly to the cause of death. Yes.
48 hours hours after surgery. So by that time, is even the right side hydronephrosis will also settle down because the obstruction has been relieved. Otherwise, both the procedures were emergency procedures and were life-saving measures.
Yes, this is the side of surgeon. So now I will like to go for very important person of this our panelist, which always in the focus and always he is analyzed for the death, and he is anesthetist. So I would like to add only one question for you, sir. Dr. Samir Soni, very known and senior anesthesiologist on our Satara. Does anesthesia have caused death in this case after treatment? Everything is occurring, everything will be occurring around the death only, sir. So question will be asked by civil surgeon on this type of issues. So does anesthesia have caused death in this case after 3 days?
The answer is definitely no, because as already mentioned by the cardiologist and the surgeon, it was an emergency because he is having a obstructive uropathy. That was rightly done. First, one side was cleared, his creat was normal. Then the second thing was done. Both times spinal anesthesia was given, which weared off very well. As the second last line of the case discussion explains, that the patient was moving in the wards. That means there is no remnant effects of any of his anesthetic that was given. Whatever drug was given at that time, that has worn off. So, and if it would have been an immediate perioperative death, then the anesthesia part would have been definitely litigated for. But not in this case. Thank you.
Thank you, sir. So surgeon, by taking side of his colleague, and no death has happened because of surgery. Anesthetist, panelist, taking side of his colleague, that whatever the anesthesia might have given by his colleague was definitely very well and very carefully, and after the effect was down, the death has happened after the 3 days. Now our very much informative panelist is Dr. Patangi madam. I would like to ask you, madam, do you need any other information about this case? One question: is the doctor negligent in patient's treatment? And third is why? So first is, do you need any further information about this case?
I would like to ask one thing. On the day 1, there was, on the day 2nd, the creatinine was 8.4. Whether that time the urea and other electrolyte imbalance was checked, or whether there was metabolic acidosis or anything was there, was it checked that time? Because and the negligence is not done because it was obstructive uropathy. Once the obstruction is relieved, the parameters are going to get settled. That is 100% sure. So the person who has operated has done 100% correct thing. But the thing that already cardiologist also has mentioned, that mild ischemic changes were also there. There can be some other pathology in the heart which must have caused this. And other thing that I noticed was 160/100 blood pressure was there, which can be one of the things that must have been found on that day, or might be there, or he must be found to be hypertensive during that time. Whether he was treated at that time for that blood pressure. Sometimes what happens during operative stress or due to anesthesia, there can be rise in the blood pressure. That can be one thing. But whether it was treated or not, because on the last day, there is a history of sudden convergence, which was early in the morning. The early in the morning is very important. because the thrombotic events or any hemorrhagic events, cerebral vascular accidents, which can occur, that can occur in early in the morning. So probably the convulsions and or the cardiac arrest, which might be related to the these two things which must have happened. That is
Okay.
my perception. And
Second question, madam, direct question. Is the doctor is negligent in
I
patient
don't think
treatment?
so. He is not negligent because the time when he had operated, that was the need of time. Actually, that was need of time to relieve all the symptoms and to normalize the things. If he would not have operated, no, then the parameters would have gone high and the patient must have landed in, he must have required dialysis or the further things.
Yes.
So the negligent, I won't say, but the other things, the other parameters were been tackled that time or not, that is my question.
Yes. So 2 points were should be considered over here. That 160 by 100 should be not properly, but should be considered at that time. But the answer from my side, that when there is a pain, agony, and all those things, that might have increased to 160 by 100 because he was not taking any medicine previously. So that might be the reason. Another thing, the other investigations in the form of electrolytes and all those things might have should be done, but not directly contributing towards the treatment of the patient.
Sometimes hyperkalemia can cause.
Yes, these are causing,
They
but
can, means rhythm irregularities can be caused.
yes.
So
But
that was my one of the.
yes, but patient was admitted twice. He was anesthetized twice. Surgery was performed with a good output, wandering in the ward, and so these are not, I think so. Our head of the panelist, civil surgeon, should note this. I would like to suggest that. So these are not directly contributing towards the death of the patient, what I would like to say, but yes. So now I would like to ask Kadam sir, as a he is now the representation of MMC, doing the representation of our members, our colleague, and also he is linking between this panel and our colleague who had done this, and the allegations we have made on this our colleague. So your input, sir, within few words.
After taking history of the patients, whether a pre-anesthetic checkup thoroughly done, physician
ECG
fitness
has
was
been
taken.
done. ECG.
What they saw the obstructive uropathy, the emergency, but first after second time he was operated. As the Bhushan told that whether the ischemic changes, there should be an echo. So whether considering age of patient 40, whether pre-anesthetic checkup was done or not.
It was done.
Done by physician.
It was done by physician very well. He advised the ECG. He advised the ECG.
Echo, he should advise echo.
So according to the ECG, anesthetist and surgeon might have taken decision considering the emergency that we should go ahead. On this, you want to say?
No, actually, as Bhushan said, because just apart from this case,
That is also considered, sir, because
there is
echo
one
was-
case when I was in Pune. The one patient, just I am telling one person, in July 21, he was operated for the some node, etc. Then patient not operated by the senior surgeon, he was operated by the assistant. Then after a patient became well and he went outside. He repeatedly came for the follow-up. Then he met the senior surgeon. He said, "You are all right, no need of medicine, etc." She was asking about the histopathology report, but they didn't answer it. Just you are fine, no need. And after 6 months, again she get more pain. And then again he went to another surgeon, second opinion. And when his histopathology report, she had not got it. But after that, they came to know that it was the malignancy. So that period of 8 months, it was overexcited. And patient succumb and patient death. So they complained against the doctors because this is a negligence, because they are repeatedly asking for the histopathological report, but they are not giving. So that doctor was fine. Doctor went for the CPA, he didn't attend it, he was compensated for 10 lakhs. This is the case was which under.
So considering this case, sir,
What
we
happened?
should, according to
Medical negligence means it is not the round kindness or etc. What court says. When you are going to attend it or attend in any complication happen, so you should be go for it and resuscitate it. If patient death is there, that is not negligence. But you should be attending in time. What court says.
Thank you, sir. This all the board is supervised by the Nivasi Vaidyakya Adhikari, additional CS. So your input, sir.
In this case, the proper investigations. Bhushan sir said कि known hypertension nahi, but BP is 160/100. We have done ECG, also color Doppler. Yeah, I think necessary. And 40 years, male, female, जो काय आहे तो. Otherwise, fitness. In this case, you have not mentioned whether fitness was done or not. Physician fitness was done or not. Mainly thing. त्यामुळे आता कसं आहे की इन्व्हेस्टिगेशन पर्पज की गोइंग टू बी फॉर नेग्लिजंट साइड 40 years cardiomyopathy, hypertension, you should do Doppler. आता this is emergency case. But
second thing,
second
sir,
time,
cardiologist has
that,
given his opinion that color Doppler would, any finding of color Doppler would have not changed the decisions or outcome regarding surgery.
Yes, decision is same. But I think so.
Thank you.
Also, patient got convulsions, maybe electrolyte imbalance, or maybe something in skull. कारण convulsions आहेत, whether that is intracerebral bleed or cerebral bleeding, must be, I think.
Considering second time surgery,
CT.
After anesthesia,
CT,
after 3 days after anesthesia,
I think.
Okay. So now we are going for the conclusion, and just some questions to our head of the panelist, Karpe sir. What is your conclusion, sir? Whether it is negligent on the treatment part? If yes, why it is so? If no, no question.
I think there is no any negligence here, but what will save the doctor socially and legally is, first of all, we all take blanket consent daily. Just patient came and we ask relative to sign here, sign there and go. It should not be like that. We have to take informed written consent. And in this case, procedure specific consent should be taken, ideally. Considering the fact put forward by cardiologist, physician, surgeon, actually we should counsel the patient about can we do it in ICU. That will not change the scenario, or it should not change the what has happened, but it will save us. You have to counsel before the operation. You have to give them option. We can do it in ICU setup, or we can do it in our setup. That's option should be given to the patient. So as a civil surgeon, what I see is usually recently I have came across one case where that surgeon told me we usually don't take patient consent. Just now, he said we take only relatives consent. I said it is not accepted. First you have to take the patient consent. So these things are going on. So I think we should first save us.
Yes.
These things are going to happen, and this will happen once in life. So you have to take care, and you have to take consent properly. You have to talk to the patient in detail. In your practice, because of your load, you don't give them so much time. You have to, as our president rightly said in his lecture, you have to communicate that too empathically, not only communication, with empathy you have to communicate, and then documentation. That all things will save you. And lastly, we are there to support you.
Thank you, sir. Very good inputs from all the panelists, and for some new things we have came to know. Not new things, but very well missed from us from the day-to-day practice. As Bhushan said about the counseling, whenever you get the investigations, you should see the proper investigations, whatever we have done, properly check up, then counseling according to the investigations, that he may need some extra care or he may get some these things. So patient's relatives should be aware about this. As the additional CS sir said, all other things also, that means the convulsions should be looked for. The Kadam sir said, whatever may be the investigations reports are available, we should always follow them, and additional investigation should be advised timely, so that we should become safe ourselves. As the madam said, not a single finding or minor findings like proper taken by the sisters like BP or something should not be neglected, or some other investigations as like electrolyte should be done. And good words by our civil surgeon that may not be negligent, gross negligent. Always there is a possibility that all things were discussed, but we are not thinking about the gross negligence. Minor negligence are there always, but always the court says that it should be seen that doctor should not be suffered because of the gross negligent measures which has been taken by him. So thank you all of you to attend this panel discussion, and such a type of meetings are there in the civil hospital. All our members from the Satara IMA members should consider that this was the awareness panel discussion, and the objective behind the panel discussion was to create the awareness, and the proper documentation should be made so that it will be very easy for the inquest reporter also, and medical negligence board meeting head also, and the members of the medical negligence board to analyze very properly, and you will be safely come out of it. Thank you all of you to attend this panel discussion in the SATCON 24. Thank you. One comment from Kute sir. Yes.
Before going to the committee, proper committee, the police officers negligent declare करून टाकतात. That is absolutely wrong. Second is पेपरवाले निग्लिजन्स करून टाकतात आणि दुसऱ्या वर्षी निष्काळजीपणामुळे किंवा चुकीच्या उपचारामुळे मृत्यू. Again they are doing wrong. It is the only committee which has got the right whether there was a negligence or no negligence. म्हणून याच्यामुळे IMA members आणि IMA association स्ट्रॉंग राहिलं पाहिजे. Whether there was proper committee formation and there was. आता ह्या कमिटीमध्ये प्रत्येक मेंबरला का देतात ते केस पेपर्स का what the surgeon has done in his place, if I would have been there, what steps I would have taken, what he has missed. मला वाटतं ह्या ठिकाणी as a surgeon he has taken right steps. Right kidney was grossly hydronephrotic as compared to the left. Left was mild hydronephrotic, so he has taken a right decision to operate on to relieve the left kidney first. Secondly, when the patient is moribund, we will keep little the fitness and other criteria little aside. Anyhow, the patient is deteriorating. But याच्या वेळेस consent हा महत्त्वाचा आहे, आणि डिसीज स्पेसिफिक कन्सेंट महत्त्वाचा आहे, आणि त्याचे काही न केलं तर काय होईल हे पण सांगितलं गरजेचं आहे. दुसरं काउन्सिलिंग इज ऑल्सो इम्पॉर्टंट. आपल्याला बऱ्याचदा लोक लिटिगेशन का करतात का फॉल्स ॲश्युरन्स हे करणं गरजेचं आहे, म्हणजे तो वाचेल. त्यांना समजून सांगणं गरजेचं होतं काय बायलॅटरल स्टोन्स ऑब्स्ट्रक्टिव्ह अनियुरिया फॉर 2 days आणि रायझिंग क्रिएटिनिन ही इज गोइंग इन टू युरेमिया. काहीतरी आपण जर त्यांना प्रॉपर काउन्सिलिंग केलं असतं तर मला वाटतं पुढे लिटिगेशन झालं नसतं.
Thank you.
One correction. First was emergency. Second, he has got some time that within our so that time there was a chance to do further investigations.
Thank you, sir. Only one question.
I would like to ask one question to expert panelist. I am a gynec surgeon. If I operated one case in my setup and get complicated, I can refer to my senior practitioner where it has been operated, or I can refer to a ICU backup where it is going to be operated. If in both scenario, if patient gets succumb after being referred, the second surgeon will held liable or not? Considering two scenarios, one scenario is this routine hospital which has been referred, and other is a ICU backup where whole facilities are available.
I think he is liable, but expert gynecologist, you want to say?
Any surgeon. Second surgeon was also held liable in this case.
Definitely. I think that case should be analyzed properly.
For example, a case of hysterectomy which has been operated, then had some complication which has been recognized and it's been referred. It is referred to some hospital, it not having some ICU backup, for example, and there the patient has been succumbed. This is one scenario. Or patient has been referred to an ICU backup and then the case has been succumbed. In those cases, second surgeon who is operating should whether be considered as liable or not, because he is managing the complication of some.
Yes, so this is the question. I think civil surgeon sir should answer this.
His liability start when he start treating this patient. His liability started. So he has to take proper, as I said, consent, procedure specific consent. As sir said, you have to take informed consent and you have to counsel the patient that what will happen if you do not again operate and all that. His liability will continue. How can we spare him?
What I want to know that if the case has been operating in a routine setup, then it's okay. Then he has not explained everything. Then the facility of the ventilator and all those things are not available. In that scenario, it's okay. But if it is operated in a well-known setup where whole facility, where other faculties, doctors are available, with all proper consent has been taken of having mortality and morbidity. In that case, what would be the scenario? Whether second surgeon which has been operating, which is trying to save that life, should be held responsible or not?
For what he should be held responsible?
If patient has been succumbed,
That will depend upon what he has precaution he had taken, what treatment he had given. That will decide. But we cannot cover him because he is treating complications.
Second surgeon should be
I
the
think,
choice.
I think
Which
नाही,
setup?
what happened नाही सर, पहिला पेशंटनी पहिला ऑपरेट केलं सर्जननी, the patient relative knows की he was shifted because the facility not available. आणि जेव्हा तो पेशंट सेकंड ह्याच्याकडे जातो तेव्हा ऑलरेडी त्यांना कल्पना असते काय झाले आणि ह्याच्याकडे सेटअप आहे आणि जसं CS सर म्हणले की कन्सर्न घेतोय, त्यामुळे सेकंडचं काही राहिलं काय कॉम्प्लिकेशन कुठं, म्हणजे कॉम्प्लिकेशन किंवा लिगलिजन्स कुठं झाला पहिल्या ठिकाणी जे त्याला वाटतं ते. तुम्ही शिफ्ट का करताय, फॅसिलिटी नाही, बरोबर आहे. आणि जेव्हा सेकंड येतो तो सर्जन कन्सर्न घेतो ना, त्यामुळे सेकंड सर्जन आय डोंट थिंक की ही विल फॉल.
नाही, एका केस मध्ये म्हणजे आंध्र प्रदेश
पहिला बेसिक
घडलेलं आहे असं की त्या रिलेटिव्ह
कोर्ट नाही निग्लिजंट.
कोर्ट मध्ये त्या सर्जनला लायबल
पेशंट कुठे ऑपरेट झाला, पहिल्या ठिकाणी झाला का
सेकंड सेटअपला ऑपरेट झाला, पण तिथं सर्व फॅसिलिटीज नव्हत्या
सेकंड ठिकाणी.
हा, मग त्यामुळं माझा प्रश्न आहे.
नाही मग होणारच की
पहिल्या सेटअपला रुटीन आपलं हॉस्पिटल आहे, दुसऱ्याकडे नव्हते.
एक मिनिट कुमार.
त्याचमुळे मला वाटतं आता बरेचसे PSC ला बिकॉज देर इज नो प्रॉपर इन्फ्रास्ट्रक्चर, ऑक्सिजन, आणि म्हणून पूर्वी जे सर्रास सर्जरी होत होत्या ट्रॉमे वगैरे ते आता बंद केलं. तर आता आपण असं म्हणू शकत नाही का रुटीन याच्यामध्ये मी केलंय, लिमिटेड एक 10x10 थिएटरमध्येच केलंय असं म्हणू शकत नाही आपण आता. परंतु सेकंड सर्जरी
झालं की ते बेसिक क्रायटेरिया असतोच तुम्हाला,
नाही
तुम्हीच रिस्पॉन्सिबल.
नाही, तुझं काय म्हणणं आहे की जर कॉम्प्लिकेशन ट्रीट करत असेल एखादा सर्जन तर त्याला लायबल धरायचंच नाही का?
नाही धरायचं का नाही. समजा ऑपरेट केलाय, सगळं झालंय, पण काय समजा आता मॉस्ट बरी पण त्या ज्या फॅसिलिटी समजा एका हॉस्पिटलला फॅसिलिटी नव्हती तिथं ऑपरेट करताना, कारण समजा ट्रान्सपोर्टचा प्रॉब्लेम झाला, काय झाला असेल असं कॉम्प्लिकेशन बद्दल मी बोलतोय.
नाही, त्यामध्ये कॉम्प्लिकेशन इमर्जन्सी होतं का इलेक्टिव्ह होतं हे महत्वाचं आहे. कॉम्प्लिकेशन इमर्जन्सी असेल तर तो ऑपरेट करू शकतो त्याच्या लेवलला. मग सुरुवातीला मी हेच सांगितलं की तुम्हाला प्रोसिजर स्पेसिफिक कन्सेंट घ्यावी लागेल. आपण प्रोसिजर स्पेसिफिक कन्सेंट घेत नाही अजून सुद्धा. आपल्या फॉक्सीनं सगळ्या पूर्ण दिलेल्या आहेत कन्सेंट की आपण त्यांच्याशी काउन्सिलिंगच करायला पाहिजे, आम्ही इथं करू का नको, तुम्हाला आधी विचारावं लागेल त्यांना आणि प्रॉपर हे घेऊन करावं लागेल. मग त्यानंतर कमिटी त्यांना जर त्यांचं काही निग्लिजन्स नसेल, ॲक्ट ऑफ कमिशन किंवा ॲक्ट ऑफ ओमिशन, तर निग्लिजंट देणार नाही ना प्रायमा पेसीमध्ये. मग त्यानंतर कोर्टनी लायबल धरलंय का?
डिपेंड अपॉन दी सिच्युएशन. आता याच्या संदर्भात एक केसमध्ये आली होती, रिमोट प्लेसला हॉस्पिटलने सर्जन हॅज डन अपेंडिसेक्टॉमी, दॅट पेशंट डेव्हलप फिकल टिश्यू. त्याने तिथून ते रेफर केलं आणि चांगल्या सेटअपमध्ये गेलं, त्यांनी ऑपरेट केलं आणि दॅट पेशंट डेव्हलप अडिजो ऑब्स्ट्रक्शन. त्याने आता हात काढून घेतले आणि त्याने तिसऱ्या ठिकाणी रेफर प्रिव्हियस टू आर लायबल.
Sir, in any case, nobody would like to come then in picture. Now also we are experiencing that. Or suddenly something happened, and if we call, people are hesitating to come because of this. This is not good, na? Sometimes it happens. Whatever. I am operating. I am surgeon.
मॅडम ते वेगळं सांगतायत. तुम्ही तुमच्या इथं जर दुसऱ्या सर्जनला बोलवलं, तुमच्या इथं नाही, आता माझ्या इथं काही कॉम्प्लिकेशन झालं मी दुसऱ्या सर्जनला बोलवलं तर मीच मेन सर्जन असणार आहे ना, माझ्यावरच काय असेल ते लायबिलिटी. त्या दुसऱ्या
ऑल्सो सर, समजा मला रेफर करायचं असेल तरी पीपल विल अवॉइड नो बिकॉज ऑफ दिस.
सो
मेन मॅडम कन्सेंट आहे. सेकंड टाइम पेशंटला कल्पना असते की पेशंट आता, त्यामुळे डेथ कन्सेंट घेतली ना, काही पेशंट काउन्सिलिंग इज मोर इम्पॉर्टंट.
Counseling is more important in this situation, what type of case it is and what type of the consent we should take, where we are taking the patient, what type of surgery we are doing and what type of the patient is there. I think liability starts after that only, to that particular setup or to that particular surgeon. If the patient has come in that particular situation and after that he is handled by another surgeon, he should be well carefully handle that case according to that way in further situation, and according to the patient and relative should be counseled in that way. If he is not treating it properly, then he will be.
नाही सर, मला काय म्हणायचं आहे, he has tried his best. Suddenly one patient comes to me complicated by other surgeon, and I have tried my best. In spite of that, patient is loses his life. So is the second person is responsible.
तेच सांगतो मॅडम, ज्या वेळेला तो पेशंट तुमच्याकडे आला, पाठवलेला असू द्या पाठवलेला नसू द्या, तुम्ही त्याच्यासाठी भरपूर कष्ट घेतले, तुमच्या सेटअपमध्ये चांगल्या पद्धतीने सेटअपमध्ये घेतले, हा आपल्या दृष्टिकोनातून सेव्ह करण्यासाठी तुम्ही झगडला, प्रयत्न केले, हा इमोशनल पार्ट झाला मॅडम. त्यांच्यासाठी हा पार्ट महत्वाचा आहे की पेशंट गेलेला आहे. अशा सिच्युएशनमध्ये तुम्ही काय केलं, कोणत्या सिच्युएशनमध्ये केलं हे तुम्ही त्यांना सांगून केलेलं असलं पाहिजे. दिस इज व्हेरी सिम्पल थिंग. जर त्यांना ते पटत गेलं आणि त्यांना समोर दिसत गेलं तर तुम्हाला ते लायबल धरणार नाहीत. पण हे डिसाईड करण्यासाठी ते पुढे जाऊ शकतात. हे डिसाईड करण्यासाठी
की nobody would like to accept or come in the picture. That is
तो भाग. मॅडमचं काय म्हणणं आहे की असं कोण कोणाला मदत करायला जाणार नाही, तर त्यासाठी आपल्याला वरिष्ठ लेवललाच हे मांडावं लागेल की जर कोणती कॉम्प्लिकेटेड केस दुसऱ्या सर्जनकडनं आली एका सर्जनकडं, तर मग त्याला तुम्ही काहीतरी कन्सिडर किंवा स्पेअर केलं पाहिजे.
सर, otherwise also this has started. Look, people are avoiding to come in picture.
Yes.
We experience that.
So after this long discussion, I would again say that thank you all of you for contributing your valuable inputs, and again thanks for coming here, and we will all join for banquet in the night. Thank you.
I request Dr. Kutte sir to felicitate Dr. Jeevan Lavati sir. I request
Okay, द्यायचं सगळ्यांना. फोटो घ्यायला पाठवतो.
I request Kutte sir to felicitate Dr. Bhushan Patil sir.
Dr. Umesh Patil.
I request Dr. Gorpode sir to felicitate Dr. Samir Soni sir. I request Dr. Asha madam to felicitate Dr. Parange madam. I request Dr. Kutte sir to felicitate additional civil surgeon Dr. Kadam sir. I request Kutte sir to felicitate Dr. Sanjay Kadam sir. I request Kutte sir to felicitate Dr. Sharad Jagtap sir for moderator. Civil surgeon sir, Dr. Karpe sir.
My माझं उद्या.
Sir, moderator, felicitate.
Very well moderated.
We will start our next session. Social Security Scheme, IMA Maharashtra. Dr. Marathe sir from Pune going to join online.
So I welcome all the delegates, and I think this is the last session of this Saturday. Everybody must be tired, but this is a very important topic of Social Security Scheme. Basically, this topic of Social Security Scheme was allotted to our past chairman, Dr. Jayant Navrange sir. And because he was busy, I am Secretary of Social Security Scheme, and I have been told to present on his behalf. The slide you are presenting is the consent form. I request you to take other slide. Other slide, please. Other presentation. What you have shared is the consent form. Dear friends, in between the slide gets shifted, I'll start talking about Social Security Scheme. It is the Social Security Scheme of IMA Maharashtra, in which almost 8,000 members are there. And in the past, it started in the year 1989. Hello, can you change the slide? Otherwise, stop sharing. Hello. If you cannot change the slide, you can stop sharing. Yeah. So basically, the scheme started in 1989, and now after so many years, there are few observations that junior members should get attracted towards our social security scheme. Now, to attract the junior members, young members, to decrease the load of the scheme, I think we have changed so many things. And it is a new format of social security scheme, which is called as Sanjeevani scheme. So on 15th of January, we have done so many changes, and these are the important changes. And what these important changes are, basically these changes were discussed in office bearers, then in managing committee, and then in AGM. So these changes are effective for all the members. And what are the changes and how these are going to affect for your FFC and your death benefit claim amount, that I will be telling you. So what are the changes implemented? The first important change is no changes for retired members. What is retired members? The members who are already paid 25 FFCs and they are just part of the scheme. They are called as retired members. So in their case, there is no change and their social security number is 1 to 1256. So if your number is less than 1256, you are the retired member. These people, they expect the beneficial amount after their death to their family, to their nominee, rupees 10 lakhs. Currently, it was rupees 9.40 lakhs and variable. So for these people, first 20 people will get exit option. What are those first 20 people? That is the seniority wise, age seniority. The person who is 92 years of age, 88 years of age. So we have selected those 20 members and we will be communicating to them if they want to get exit from the scheme. So these first 20 members, retired members, will be given the opportunity and they will be getting 5 lakhs rupees. And these 5 lakhs rupees will be one-time settlement and then they will not be part of the social security scheme. Second important change is there will be fixed FFC. What installment you are paying will be the fixed for new entrants at any age. So suppose you are joining the scheme from today onwards, you will be having the fixed FFC. And the important change what we have made in this is, it is the less FFC, it is the less premium, it is the less installment for the younger generation. So it is much less for younger age group and very reasonable for elders also. Even for elders, we have settled the appropriate FFC installment. So as well as those existing members below age of 45 years. So youngsters, then below age of 45 years, they will be getting the reasonable FFC amount to be paid. And for that, I'll be telling about the proper resolutions. Next important thing is a new member can opt for multiple units of beneficial amount. For example, suppose you are the member of social security scheme, you get 10 lakhs rupees, your nominee gets 10 lakhs rupees. You feel that you want more, that is 20 lakhs or 30 lakhs, you can opt for 2 units, your nominee will get 20 lakhs. You can opt for 2.5 units, your nominee will get 25 lakhs. You can opt for 3 units, your nominee will get 30 lakhs, like that. So this is the new provision in our social security scheme, what we have named this scheme as Sanjeevani scheme. Then fourth point is those existing and contributing members beyond the age of 45 years. See, there are four classifications. First is retired members, what I have talked about. Then youngsters, young members and new entrants. Then existing members less than 45 years, they will be taken to the new scheme automatically. The members who are more than 45 years, they have got the two options. So beyond the age of 45 years have an option to continue as per the old scheme. They can continue in the old scheme. However, the benefit amount is fixed at rupees 10 lakhs. Even for new and old, everyone, their nominee will get 10 lakhs. So those who do not shift to new scheme, those who do not shift to new scheme by specifically signing the denial option form will continue to pay variable FFC. My death benefit is fixed at rupees 10 lakhs. FFC will be calculated as per old scheme. What does that mean? Suppose you are more than 35 years of age. There are two options. You can shift to the new scheme and you can pay fixed FFC. What that fixed FFC is? Rupees 11,800 plus GST. But if you are remaining in the old scheme, you will have to pay your FFC according to number of deaths which are occurring in that particular year. So your FFC may get increased more than 12,000, 13,000, 15,000. So better take for shift for new scheme rather than waiting in the old scheme. Then exit option will be there for this old scheme people, that will be 6 lakhs. And new scheme and old scheme, after their completion of 25 FFCs and 5 years, that is 31 years, and when they are ranging their age around 80 years, they will have that exit option. So that exit option they will get 10 lakhs of rupees that time in that particular year, not today. So today we are giving to first 20 senior most, that is only 5 lakhs. But if you are in this particular scheme, you are going to get 10 lakhs rupees as exit. And what is the prerequisite? You have to pay 25 FFCs, that is installments, then 5 years of extra period, and your age should be around 80 or more than that. The next important thing is that if you are shifting to new scheme, you have to send the consent, or you may not send the consent, automatically you will be taken into the new scheme. But if you want to go to the old scheme, if you want to remain to the old scheme, you have to give your denial form option. It is must. To remain in the old scheme, you have to send your denial option. But if you want to shift to the new scheme, either you can send the consent or you don't send any answer, automatically you will be shifting to the new scheme. And this particular form, consent and denial form, is attached and it has been sent via email to each and every member. The same way, this consent and denial form and all this information is also available on our website of IMA Maharashtra Social Security Scheme, imamssss.com. That's what you can search for. Then the next important thing, this GST amount will be applicable, but your FFC will be 11,800, and in addition to that, GST. Just remember this. Next important thing is what I have said, exit scheme will be there for all of you, that is rupees 10 lakhs, but prerequisites I have already explained to you. Then facility for paying additional installments. Suppose you are going abroad, or you feel that you may not remember how much FFC is to be paid. You can pay your additional installments and get the discount also. Then facility to pay deposit in 1 or 3 installments to obviate need to bother about additional GST. Even additional GST you can pay, and in that case you can get the discount in that GST amount. So another change is coming from 1st of April, that is annual subscription which was 200 rupees will be revised as rupees 250 rupees. Just 50 rupees rise in that annual subscription will be there. So all these changes, you may feel that these are confusing, but then we have made these changes which are important for each and everyone, and that is beneficial for all the members. Now, two things I'll be just showing what slides are projected in this. The same slides you like to observe over here, and these slides one by one we will again revise what I have told and what were the resolutions in that particular scheme we have passed at AGM. And the first slide, you can start with the first slide, resolution number 1. This resolution number 1, what I have said just now, is the revision of the amount, that is from 200 to 250. That is just because the management of this particular scheme, the amount is revised, and that is for each and everyone. This is the difference of only 50 rupees. So I think you understood about this resolution. Now, next resolution. Now, this resolution is telling you about the exit option eligibility. What we have seen here, that 5 years after completion of 25 contributions, means after 31 years of your joining. That's what you have to remember. And eligibility for this exit option will be age-wise seniority. Just remember, it will not be the membership number-wise seniority. And such exit offers will depend on surplus of that particular year. Beneficial amount fixed to rupees 5 lakhs minus 2% admin charges, that comes to around 4.9 lakhs, and minus the income tax if you are applicable for that. So this year we are sending this letter to first 20 people whose age are around 90 to 88 of that type. And what is the explanation? It is a viable scheme. Super veterans may be in the need of money. These exits will not be burdened by way of increasing the FFC of other members. This is very important. Though we are giving exit to these members, the routine members will not be burdened by that. And it will be reducing the burden of death claims by around 50% for the existing members. New slide, please. Now, new entrants. This is very, very important change what we have made. In the past, everyone, even youngster and old person was paying the same sort of FFC. What change we have done is for new entrants, the FFC amount which will be revised and which will be less. For the age less than 30, it will be around 4,800. In that, voluntary deposit will be added, annual subscription will be added, then GST will be added, but the basic amount will be 4,800. So it will be around 6,000. Now, for the age between 30 plus to 40, 8,300. It comes around 9,500. Then in between 40 to 45, 10,300. Then 45 to 50, 12,500. And for the age 50 to 55 up to 60, 16,600. So if you observe here, youngsters are getting that benefit of paying less amount of paternity fund contribution, that is an installment. So to attract the youngsters, this is very important. Now for the age group of 50 to 55 and 55 to 60 years of age, FFC remains same. I think these are the people which is the burden on the scheme, because they are around their retirement, they may have some morbidity, and that may be little burden on the scheme. So for that, the FFC is little more. Next slide, please. Next slide, please. Yeah. So newly joining members at any age have to go for new scheme. This is very important. So new members will be directly getting entry in the new scheme. Existing members more than 45 years of age will be having two options, as I have said. The option of both, that is to continue in the old scheme or shift to the new scheme. And new scheme is called as Sanjeevani. So in short, what I have suggested, that it is better to get shifted into the new scheme because your FFC is fixed, your beneficial amount is also fixed, and there is option of exit at the age of your seniority when you pay 25 installments and 5 years period, that is after 31 years. That opportunity is very good in the new scheme, that is Sanjeevani scheme. Next slide, please. To avoid recurring GST payment every year, you can deposit, that is GST reserve fund, and there are some discounts given. So you can think in that sense, and you can pay your GST in advance, and for that we have given the discount and concession to you if you pay your GST in advance. Next slide, please. The new member may opt for advance installments. Some youngsters may say, after a scheme, you can take 3 to 4 installments. What discount we are going to get? Like in today's era, there are so many sales, so people expect in that sense. Suppose you are paying one extra installment, you are getting the discount of 5%, and that way 2 extra installments 8% and 3 extra installments 10% discount will be given to that extra FFC. Next slide, please. So exit option, as I have said, to the first 20 members, it will be 5 lakhs. And what you feel that what you are going to get afterwards. If you study thoroughly in the past, these are the members. This is the membership number. Membership number 1 to 336. They are retired in the year 2016 and they have paid just 25,000 in their lifetime. The same way those who are retired last year 2023, their number was 1033 to 1256. In their lifetime, they have just paid 81,132. And against that, what they are going to get? 9 to 10 lakhs. So you are not in loss. You don't see this scheme in comparison with shares or mutual funds or FDs. But this is just to give benefit to your member colleagues family. स्वार्थ आणि परमार्थ दोन्ही साधलं जातं. You help your colleagues families the same way that amount what you are giving to social security scheme, you get much more than that. Next slide, please. Now about exit option, conditions apply. What I said, suppose you are in the scheme and you have paid your 25 installments and 5 years extra. This is the age what you can consider. Suppose your joining age is below 30, exit age will be 75. Then 30 to 40, if your joining age at 80 years of age, you will have an exit scheme. Like same way, 40 to 45, 80 years, 45 to 50, 85 years, 50 to 55, 86 years. And if you have joined the scheme 55 to 60 years of age, that is very, very late. Probably your exit will also come very late, that is at the age of 91. But of course, in between, suppose some unfortunate incidents occurs and the person is dead, probably his nominee will definitely get that 10 lakhs amount. Next slide, please. For this particular scheme, office bearers, they have given the special name that is Sanjeevani. That is the revival of the scheme. And by this scheme is going to survive. And we are going to give this benefit to our members across the Maharashtra state. You can stop the sharing of the slides. I'll just speak without the slide now. So, dear friends, you can take out the slide now. Yeah, stop sharing. I think this is my humble appeal to all IMA friends from Satara district and all those delegates, those who have joined this conference. This is very, very important scheme of IMA Maharashtra. The same way there is National Social Security Scheme also. There also you can get more than 10 lakhs. In your specialty, suppose it is ophthalmology, pediatrics or gynecology, there also you can get. So that way you can get 50 to 60 lakhs you can if you are becoming the member of the Social Security Scheme. It is my humble and earnest appeal to each and everyone to bring many more new members and ask them to join this Social Security Scheme. Those who are existing members should propagate our scheme, should say to your colleagues that this is the wonderful scheme and we are there to help you out. Our office of IMA Maharashtra Social Security Scheme is at IMA Pune premises. I am Dr. Prakash Marathi, working as Secretary of Social Security Scheme. I will be definitely helping you. Our past chairman, Dr. Jayan Navarangi sir, has taken tremendous efforts to design this new scheme, along with our treasurer, Dr. Suhas Nene, then our joint secretary, Dr. Amrish Shade, then Dr. Panse, Dr. Damle, they have helped us a lot. Our new chairman, who is from Parbani, Rajgopal Kalani, who is taken over as chairmanship, and there is managing committee, there are volunteers, and there are branch coordinators from each and every branch across the Maharashtra state. Thank you, IMA Satara SATCON Organizing Committee, for giving me the opportunity to present this Social Security Scheme new changes to all of you. Hope your queries are resolved. Even if you have got some queries, I am there to help you out. Anytime you can call me. If the time permits, if you have got any questions, I am there to answer your question. Thank you. Thank you so much.
Sir, there are questions. Is this online available, all these informations?
Yes, yes. You can see those who are members, they have been sent this email by bulk email via us. This information is available on our website www.imassaccess.com. Again, I will repeat www.imassaccess.com. In that website, suppose you open, all this information is available, and the membership form, newly designed membership form, will be available in due course of time. Maybe next week this form will be available. Those who want to take new membership should contact us and that form will be provided to you.
What is time limit for changing previous old one to the new one? Is there in time limit?
That is up to 31st of March. But what I said, to change to the new scheme, either you can send the consent or you may not answer. If you are remaining silent, automatically you will be taken to the new scheme. If you don't want to go into the new scheme, you have to provide the denial which is available on the website, as well as email has been sent to you. So those who want to remain in the scheme, they have to send that denial form to us.
Third question is it informed to all society or you have to approach individually? You have to approach by society through or individually?
Actually, this is the IMA Maharashtra scheme. So existing members have been informed accordingly via email. And as this information is available on website of IMA Maharashtra Social Security Scheme, and then people like you, I think verbal communication, your managing committee members, our social security managing committee members, office bearers, they have to propagate the scheme like past president Dr. Ravindra Kute, who is my friend. Such people are spreading the word for all of you, even the office bearers who are there today's program, Dr. Jagtap, Dr. Ghorpade, they have to spread the word. And that way it has to reach to each and every member.
Sir, with your permission, can we share your slides to the delegates?
Of course, sir, it is for all of you. I am very happy about this question. You can forward my email to each and everyone. Let them study, and if there are any queries and questions, I am definitely there to help you out.
Okay, sir. Thank you, sir. Thank you. You have given briefly idea regarding SSS scheme and what are the parameters and what new changes are there. So I say thank you from IMA Satara. Thank you for your
Thank you.
cooperation.
Thank you so much. Thank you so much. Have a great day. Bye.
Thank you, sir. From the desk of the President, I would like to thank you again for contributing your valuable inputs in the Satara annual conference this year, and we will definitely see that new amendments and new changes which has been done will be percolated to each and every member of our Satara IMA. I would like to conclude this day's session by very well organized and speeches as well as panel discussions. I would like to say that good take-home message has been taken by our members and those who have online participated in this session. So next day with new version and new lectures, we will join tomorrow at the 9 a.m. Thank you very much.
Thank you. Good night.